that statins also do is they decrease the cholesterol in the cell, and so you have less VLDL being produced and less VLDL in the blood. So that's kind of how statins work. They decrease LDL, little bit they decrease triglycerides. Statins if you look at PCSK9 inhibitors, bempedoic acid, they are all increasing the number of LDL receptors. And less remember that. That is the point. So that's kind of how statins work. So the big question, show of hands, there is a slide. If you look on the left side is a lot of small atherogenic particles. On the right is a few large atherogenic particles. Your total LDL cholesterol is the same per 100 ml of blood. On the left side, how many think it's the number of particles that matter? On the right, okay, good. The way I asked it, hopefully that gave away the answer. That's the point. I want you to take that away. What matters is the number of 100 ml of blood. So if you look at this slide, you have no idea how many particles. In most people, when you measure LDL-C, it correlates with the ApoB and the number of particles in many people. That is called concordant. So if you look at this, there are only 6 particles, so ApoB will be less. And there is a little bit of LDL compared to what I'll show next. LDL is less, so this is concordant, low LDL, that is low ApoB, low risk. So if you look at this, got it with me? Both are low, risk is low. Will be less. Now you get something where the particles are big, I'll show next. So they have more LDL. So the LDL cholesterol is high, but the particle number is only 8. Got it with me? Both are low. So the ApoB number is low. Now you get this person's risk is actually low, even though their LDL is somewhat high. So this is a discordant low risk LDL cholesterol is high. Now we get to people with high number of particles. ApoB goes up, right? So we have lot. ApoB is high risk, done, it's a concordant high risk. What you want to find out is who are the discordant people, identify them, and they are the one with the residue. Is high risk, done, it's a concordant high risk. What you want to find out is who are the discordant people, identify them, and they are the one with the residue. Is high risk, done, it's a concordant high risk. What you want to find out is who are the discordant people, identify them, and they are the one with the residue. Is high risk, done, it's a concordant high risk. What you want to find out is who are the discordant people, identify them, and they are the one with the residue. What you want to find out is who are the discordant people, identify them, and they are the one with the residue. Is high risk, done, it's a concordant high risk. What you want to find out is who are the discordant people, identify them, and they are the one with the residue. What you want to find out is who are the discordant people, identify them, and they are the one with the residue. Is high risk, done, it's a concordant So the issue is how does it work, right? So what it is a small piece of DNA which has a tag. The tag is it attacks the messenger RNA that makes the PCSK9.
How does it
Got it?
work?
PCSK9 is
So
a protein.
what it
It's made
is
through
a small
messenger
piece of
RNA,
DNA
which codes
which
for it.
has a
You want to
tag.
destroy it.
The
So
tag
you
is
send
it
this
attacks
molecule,
the messenger RNA that
RNA
makes
molecule,
the
small
PCSK9.
interfering RNA.
Got it?
It goes into the
PCSK9
cell.
is a protein.
Why does it go to the
It's
liver
made
cell?
through
It's
messenger
fascinating.
RNA,
It's
which
coated
codes for
with
it
a
has
sugar
you want to destroy
that
the
can
tag.
be
So you
absorbed
send
only by sugar,
this
liver cells.
molecule, the
So
messenger
you give it in the
RNA
blood, but it goes
molecule,
only to the
small
liver.
interfering RNA.
And
Got
it's
it? It
absorbed by
goes
the
into
liver
the
cell.
cell.
Why
It
does it
goes
goes
in,
in,
the liver
attacks
cell
the
is messenger
mRNA that
It's
makes
coated with a
PCSK9,
sugar
and because
that
can
get
get so
absorbed only by
concentrated in
sugar,
the liver,
molecule,
and
so you
the
give it in the blood, but
PCSK9
it
level
goes only
goes
to the
down,
liver.
it
And
lasts
it's
for a
absorbed
very
by the
good
liver
amount of
cell.
time.
Okay?
Okay?
It goes in,
Attacks
the
so the
mRNA that
big
makes
difference is
PCSK9
it'll
and
lead to
because
decreased
can be
LDL
absorbed
receptors,
only by
just like
the
statin.
liver.
Increased LDL receptors,
you give it in
decreased
the blood,
LDL.
but it
level
goes
The
only
beauty
down.
of this is after
It
the
lasts
first
for a
couple
very good
doses,
amount of
right
time.
now,
Okay?
you dose it
So
every 6 months.
So the
And
big
this
difference
is done in the office,
it'll
at
lead
least in
to
the
that.
lipase. That doesn't work in the liver, it works in the periphery, and it breaks down the fats and gets rid of them. So when LPL decreases the amount of LDL and triglycerides in the blood. That's your natural mechanism.
That doesn't work
And
in the liver.
there is
It
something
works in the
called
periphery, and
angiopoietin-like
it breaks
protein
down
3.
the
I'm sorry,
fats
it's a long,
and gets
hopefully
rid of
they'll
them.
come up with a better way
So
to say it.
LPL
It's
decreases the amount of
ANGPTL3,
LDL and
and this
triglycerides in the blood. That's
breaks
your natural
down
mechanism. That
LPL.
doesn't work
So
in the liver.
LPL
That
is good,
something called
ANGPTL3 is bad. This is also
5 minutes
naturally
remaining.
produced in the liver.
With a better way to say
What
it.
you want to do is get
LPL
rid of
decreases the
ANGPTL
amount
so your
of
LPL goes up.
this
Sorry, this
in the
is
That
a lot of
breaks
stuff in
down
the morning.
LPL.
LPL is good,
LPL is good.
ANGPTL is bad. You want to get rid of this is also
5 minutes
naturally
remaining.
produced in the liver.
With a better way to say
What
it.
you want to do is get rid of
ANGPTL
ANGPTL so your LPL goes up. Sorry, this is a
breaks
lot of stuff in
down
the morning. LPL is good, ANGPTL is bad. You want to get rid of this is also
5 minutes
naturally
remaining.
produced in the liver.
With a better way to say
What
it.
you want to do is get rid of ANGPTL so your LPL goes up. Sorry, this is a lot of stuff in the morning. LPL is good, ANGPTL is bad. You want to get rid of this is also
5 minutes
naturally
remaining.
produced in the liver.
With a better way to say
What
it.
you want to do is get rid of ANGPTL so your LPL goes up. Sorry, this is a lot of stuff in the morning. LPL is good, ANGPTL is bad. You want to get rid of this is also
5 minutes
naturally
remaining.
produced in the liver.
With a better way to say
What
it.
you want to do is get rid of ANGPTL so your LPL goes up. Sorry, this is a lot of stuff in the morning. LPL is good, ANGPTL is bad. You want to get rid of this is also
5 minutes
naturally
remaining.
produced in the liver. What you want to do is get rid of ANGPTL so your LPL goes up. Sorry, this is a lot of stuff in the morning. LPL is good, ANGPTL is bad. You want to get rid of this is also
5 minutes
naturally
remaining.
produced in the liver. What you want to do is get rid of ANGPTL so your LPL goes up. Sorry, this is a lot of stuff in the morning. LPL is good, ANGPTL is bad. You want to get rid of this is also
5 minutes
naturally
remaining.
produced in the liver. What you want to do is get rid of ANGPTL so your LPL goes up. Sorry, this is a lot of stuff in the morning. LPL is good, down to even 50 keeps a residual risk. What has not been proven is, does reducing Lp(a) reduce your risk? That is the part that, keep that in mind, those trials are coming. We now have treatments, and Kirby talked about it, they were part of this study. What has not These treatments are phenomenal in bringing down Lp(a)
2 minutes
by as
remaining.
much as 90%. So they work to reduce Lp(a). Will that reduce your cardiovascular risk? And the reason I say that, we have been burned by medicines that increased HDL, didn't reduce
2
risk.
minutes remaining.
Decreased triglycerides did not reduce the risk. Is this going to be same or different? We need to find that out. So keep inhibitors for getting LDL as low as possible. Last thing I wanted to say, the CRISPR-Cas9 inhibitors for getting LDL as low as possible. Last thing I wanted to say, the CRISPR-Cas9 inhibitors for getting LDL as low as possible. Last thing I wanted to say, the CRISPR-Cas9 inhibitors for getting LDL as low as possible. Last thing I wanted to say, the CRISPR-Cas9 inhibitors for getting LDL as low as possible. Last thing I wanted to say, the CRISPR-Cas9 inhibitors for getting LDL as low as possible. Last thing I wanted to say, the CRISPR-Cas9 inhibitors for getting LDL as low as possible. Last thing I wanted to say, the CRISPR-Cas9 inhibitors for getting LDL as low as possible. Last thing I wanted to say, the CRISPR-Cas9 inhibitors for getting LDL as low as possible. Last thing I wanted to say, the CRISPR-Cas9 inhibitors for getting LDL as low as possible. Last thing I wanted to say, the CRISPR-Cas9 inhibitors for getting LDL as low as possible. Last thing I wanted to say, the CRISPR
ingrained as an indirect risk stratification. If patient is intermediate to high risk, as you see here, you have a pointer, or is it part of here? Ingrained as an indirect risk stratification. If patient is intermediate to high risk, as you see here, okay, found it, fine. You have a pointer. Then you have to do invasive procedure in less than 24 hours. If low risk, you can do a selective approach. If patient is intermediate to high risk, emergency medical system activation, ECG, reduces door to balloon time, all of that we have known. Then you have to do invasive
So let's start
procedure
here.
in less than 24
We have a
hours.
high
If
or
low risk, you
intermediate
can do a
risk,
selective
non-STEMI.
approach.
ACS, we have a
If
low
patient is
risk.
intermediate to high risk,
First thing you see is
emergency medical
irrespective
system
of
activation,
non-STEMI,
ECG,
patient should be offered invasive strategy, should be offered. We have a high, by your bias, if you don't offer, is another story, but non-STEMI, both options, even if it's lower risk. It's a class one
Non-STEMI
strategy.
patient should be offered invasive strategy, should be offered.
Strategy.
By your bias, if you don't offer, is another story, but but for whatever reason you don't want to offer them, it's mainly the
Class
lower
one
risk
strategy.
patient
Once you do invasive
should be
procedure, you have to
offered
stratify into
invasive
three
strategy.
classes. I
Should
tell
be
the
offered.
patient, PCI, bypass, medical therapy.
By your bias, if you don't offer, is another story, but for whatever reason you don't want to offer them, it's
Patient
patient
non-STEMI,
patient
you have very high risk patient, then you have to do angiography within 2 hours. Who are high risk, patient with low blood pressure,
another story, but for whatever reason you don't want to offer them, it's
patient non-STEMI,
patient
you have very high risk patient, then you have to do angiography within 2 hours. Who are high risk, patient with low blood pressure,
another story, but for whatever reason you don't want to offer them, it's
patient non-STEMI,
patient
you have very high risk patient, then you have to do angiography within 2 hours. Who are high risk, patient with low blood pressure,
another story, but for whatever reason you don't want to offer them, it's
patient non-STEMI,
patient
you have very high risk patient, then you have to do angiography within 2 hours. Who are high risk, patient with low blood pressure,
another story, but for whatever reason you don't want to offer them, it's
patient non-STEMI,
patient
you have very high risk patient, then you have to do angiography within 2 hours. Who are high risk, patient with low blood pressure,
but for whatever reason you don't want to offer them, it's
patient non-STEMI,
patient
you have very high risk patient, then you have to do angiography within 2 hours. Who are high risk, patient with low blood pressure,
but for whatever reason you don't want to offer them, it's
patient non-STEMI, you have very high risk patient, then you have to do angiography within 2 hours. Who are high risk, patient with low blood pressure,
but for whatever reason you don't want to offer them, it's
patient non-STEMI, you have very high risk patient, then you have to do angiography within 2 hours. Who are high risk, patient.
Also, it's all early indication. Streptokinase, just curious, how many of you still use streptokinase? Very few. I would recommend try to convince the patient that streptokinase is an obsolete drug now. Use some of the newer agents, please. I know
just
cost
curious,
is an
how
issue,
many
but
of you
newer agents
still use
prices come
streptokinase?
down to 20,000 rupees
Very
range.
few. I would
Which
recommend
compared to a
try to
5,000
convince the
rupee,
patient
15,000 in
that
Indian scenario is not a
streptokinase
big
is an
difference
obsolete
in
drug
now. Use some of
Once
the newer
patient
agents, please.
has
I know
just
cost is
curious,
an
how many
issue,
of
but
you
newer
still
agents
use
prices come
with or
down to
without?
20,000 rupees
These
range.
are the drugs. If you have
Which
PCI,
compared to a
aspirin,
5,000
ticagrelor, or
rupee,
prasugrel.
15,000 in Indian
Clopidogrel
scenario is not a
only
big
if not
difference in
available,
drug
which is
now.
not the case in
Use some
India
of the
anymore.
newer agents.
Price is not a
Has
big
no
issue.
cost
All
is
of
an
them are
issue.
available in
With
generic.
prices come
With
down
or
to
without.
20,000
Considering for
rupees. These are the
bypass,
drugs. If you
ticagrelor or
PCI,
clopidogrel is
aspirin,
better.
ticagrelor, or
Prasugrel.
15,000 in Indian
Clopidogrel
scenario is not a
only if
big
not
difference in
available,
drug
which is
now.
not the case in
Use
India
some of the
anymore.
newer agents.
Price is not a
forgotten or any reason. How long? Guideline is 12 months. Lot of data is now showing 1 to 3 months. ACS 3 months. Non-ACS even 1 month. But to be very safe and scientifically sound, go with 12 months as guidelines.
How long?
3 months in
Guideline
exceptional
is
case.
12
I
months.
would not
Lot
do
of
1
data
month
is now
dual
showing
antiplatelet.
1
to 3 months.
But if there's a high
ACS
bleeding
3
risk,
months, non-ACS
3
even 1
months,
month.
ticagrelor
But to be very
preferred as a
safe
single agent.
and scientifically
I
sound,
am
using
go
in
with
high
12
risk
months as
ACS as
guidelines.
well as high risk
How long?
patients
3 months in
with
guidelines.
multi-stents,
12
long
months, not a 1
stents,
month now
complex
showing
stents,
like
left
3
main.
months. But at
If
least
it is
for
ACS
1
3
month,
months,
people,
non-ACS even 1 month.
newer oral
Very
anticoagulants,
safe
aspirin,
and
to white
scientifically sound,
wine,
using
go
in
to
high
white
risk
wine as
ACS as well
guidelines.
as
I
high risk
prefer a
patients
ticagrelor
with
as a
multi-stents,
reasonably
long
safer,
stents,
otherwise
complex
The knowledge here is to guide your cardiologist to see what he does and counter it. Don't worry, you can counter your cardiologist. If they are not tuned to the latest guideline, the latest science, change the doctor or counter them. The knowledge here is now coming to your cardiologist and see what he does and counter it. Last one, high intensity statins. How many of you are routinely using your ACS patient, irrespective of lipid profile, 80 milligrams? I would recommend that most of our team, almost all of us use these at first. Target LDL 55 or less in very high risk patients. Lot of clinical studies are showing survival even benefit to as low as 20 LDL. Almost all of us use these. High intensity target LDL to 80, 25 days in very high risk patients. Lot of clinical studies are showing very high survival even benefit to as low as 20 LDL. High intensity do not please miss today's pre-lunch session on inclisiran by Professor Komari. He came last year. He has the largest experience in clinical trials practice as an interventionist. He will talk from a clinician. No, please miss pre-lunch session in house listen to him. By Professor Komari. He came last year. He has the largest experience in clinical trials practice as less than 10 minutes. He will talk from a clinician. No, please miss pre-lunch session in house early cardiac rehab. All of you should start teaching your patient on cardiac rehab. All now management in coronary disease, CADs, obesity management, everybody is coming with exercise. 2 more, cardiovascular and muscle strengthening. It is a part and parcel of life. Cardiovascular, post-BCI, post-muscle strengthening. What is a part and parcel of life? Follow-up is mandatory. I won't go into the guidelines. Patient education is very important. We don't spend time with it. All the issues, family, wife, husband, spouse, whoever. And these are components, again, I don't want to go into. Education is very important. So take home message. ERPT issues, aggressive epidural, early invasive strategy, less than 2 hours, less than 24, almost. I don't want to go into. Education is very important. So take home message. ERPT issues, aggressive epidural, early invasive strategy, less than 2 hours, less than 24, almost. I don't want to go into. Education is very important. So take home message. ERPT issues, aggressive epidural, Early invasive strategy, early invasive. So there are people who went with A and B.
Not all MI, not post PCI. Only C is the correct answer, okay? So some of you are still trying to wake up after last night. Please wake up. Wake up, wake up, wake up. What is the default antiplatelet strategy after PCI in SCS according to
2
the
minutes
guidelines?
remaining.
Aspirin clopidogrel for 6 months, aspirin ticagrelor or prasugrel for 12 months, monotherapy, aspirin alone. Pads, 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 everybody, pads. With about 100 people, 10 people are still not as awake. Please wake up, okay? Not.
Most cardiothoracic surgeon and director, Medical Six Hospital. Welcome, Dhiren.
Good morning, and I think so everybody is really awake now. So now, moving from the molecular level to a very structural level or at a macro level, what I'm going to speak about is Lima to LED enough for survival? A very out-of-the-box thought process, very different thought process. We all know that bypass is obviously long-term benefit is there by doing a bypass surgery, but then is only Lima to LED enough during when you are doing a bypass surgery? So this is the question that we are going to answer today in this talk. So I have no disclosure. This is very important because a lot of minimal invasive surgeries are being performed, and I have been performing it since last 15 So let me start with a question. Which artery is called the widowmaker artery? On your pads. Great. So I think so, I don't have to convince everybody that LAD is the main artery, is the artery which is very important when you're dealing with the coronary artery disease, because it supplies 50 to 60% of the blood supply to the left ventricle or the heart in totality. So CABG, we all know, is the standard of care for the patient with intermediate and high coronary artery disease burden. Traditional CABG, whether it is beating heart surgery or off-pump surgery, it is a standard of care now. And we all are aware that the advantage of CABG lies in the Lima to LAD graft, and which it has been stemmed world over by various literature papers and landmark trials also. And minimally invasive approach to CABG are safer and effective alternatives in select patients' population. So Lima to LAD is the ultimate treatment for the coronary artery disease, has been stemmed not now, but way back in 1986 by the Cleveland Clinic group, by Bruce Lytle and Frederick Loop. And what they found out in their data analysis of the Cleveland Clinic is that the patency rate is almost 90 to 95% at the end of 15 years. And the benefit extends if the patient, they survive second decade or third decade of life. So that is where the Lima to LAD gives you an advantage. And why this is a golden graft, why this is a golden conduit? It is basically because of two reasons. LAD supplies, as I said, 50 to 60% of the blood supply to the heart, and it has a fantastic runoff. That is the biggest advantage. And second thing is the Lima, the conduit, which is a conduit which has an anti-inflammatory action inside the conduit. It produces the nitric oxide, and obviously it is histologically made in a way that it is affected by atherosclerosis in the minimal way. There is a continuity of intimal layer because of which the atherosclerosis is not there seen in the internal memory artery. So why this topic? Why this thought process? Because I was trying to analyze my data from 2010 to 2019 of my minimal invasive Lima to LAD cases. So I was trying to get my 5 years, 10 years, and 15 years data. In all these patients, whoever patient I operated were all complex lesion in ostial LAD, CTO of ostial LAD, or complex bifurcation lesion or tortuous LAD lesions were there. So they were referred for Lima to LAD minimal invasive to me from 2010 when I started. So we have total of 264 patients, and I was trying to analyze this data. So there were 3% patients who had triple vessel disease, 17% DVD, and single vessel 79% patients. And this is the spread of cases per year from 2010 to 2019, almost 25 to 30 cases per year of pure Lima to LAD. And when I analyze the cause of the death in these patients, if you look at the cause of death, myocardial infarction was there in only 3% of 3 cases only. Rest all the mortality was of different reason. An unknown reason for death was 6, so we could not find out what the reason was. Very important question was, how many patients required revascularization after getting Lima to LAD after 15 years or within that period of 15 years? So only 1 patient required CABG and 6 patients required PTCA. Hybrid was done as a combined procedure in 12 patients in 2011. Few patients we did both Lima to LAD and then angioplasty to other vessel. So practically only 7 patients required out of 264 patients revascularization. And what is the survival of this patient right now? So 5 year survival 88%, 10-year survival 85%, and 15-year survival 78%. An important thing is they are all asymptomatic and good health. That is very important. So after this analysis of my data, I thought, is it so that this is only my data, or there are other data across the world? And I was surprised to find that there are a lot of other papers which have described this thing, that Lima to LAD only, and patients, they have done well even after 20 years. This is a data of Leipzig group from Germany, which shows that 20 years of outcomes of minimal invasive coronary artery bypass surgery with only Lima to LAD, patients are doing well. And this is, if you look at the combo of these patients, almost 70% patients were either double vessel disease or triple vessel disease, but just got Lima to LAD, just got minimal invasive Lima to LAD graft in these patients. And if you look at the survival data, it was as good as the general population or as good as any other CABG patients who have undergone any CABG. The important subgroup analysis was that the patients who were less than 50 years of age, they got maximum benefit just by Lima to LAD graft by minimal invasive. And obviously the patient who had EF more than 40% benefited more as compared to EF less than 40%. This is another data from the other part of the world, that is the Australian data, which shows that 20-year outcomes of mid-cap patients, they were matching at the end of 20 years with the general population of Australia. So outcomes are same, the survival is same, and there is no MACE at the end of 20 years. Just Lima to LAD was done in that patients. So when you compare the data of various studies, I was comparing the data. So these are the different studies, that is the Pirose is from the Leipzig group, then Herfield, Presica Italian group, and the Manuel from the Australian group. The 5 years, 10 years survival, and 15 years survival was more or less equal in all the group, and even our data was matching with that group. So now, if you compare PCI with Lima to LAD, then a recent meta-analysis demonstrated that 2.62 times more angina, 2.86 times more adverse coronary and cerebral events, and 4.63 times greater repeat revascularization was seen in PCI compared to Lima to LAD mid-cap. So what are the long-term survival of the overall CABG in general population? I'm not talking about only Lima to LAD, but if the patient has undergone bypass surgery, then what is the survival? 10-year survival, 5-year survival is 92%, 10 years, 77%, 15 years is 57%, and 20 years survival is 40% in the general population in a general bypass patients. So if you look at the Lima to LAD survival rate also, it is more or less similar with this group of population. So almost 20 years, 56% patients are surviving by just Lima to LAD graft, and they are doing well. So now the question comes, is complete revascularization required to improve survival? Can we just do a Lima to LAD graft minimally invasive and go away? Is there a requirement for multi-vessel bypass grafting? So again, there are papers on this also. And this is a very interesting paper from, again, the Leipzig group. Does reasonable incomplete revascularization affect early or long-term survival in patients with multi-vessel coronary artery disease receiving Lima to LAD? Only mid-cap was done. So what does this study shows? The overall survival at the end of 8 years was similar in both the group. Whether you do complete revascularization or you do just Lima to LAD
5
graft.
minutes remaining.
So this is another study. High-risk patient with multi-vessel disease, is there a role of incomplete revascularization by minimally invasive? Here again, if you look at, again, it's from the Leipzig group. Incomplete revascularization via mid-cap is safe and effective in high-risk patients. You get a morbid patient, you get multiple comorbidity patient, you do a Lima to LAD in spite of the fact that patient is having multi-vessel disease, patient is going to do well at the end of 4 years. This is the recent trial published in 2024. This is the regroup trial.
And what does this regroup trial states? They examined a cohort of 1,147 patients undergoing CABG and compared complete revascularization against incomplete revascularization. And over median follow-up of 4.5 years, what they found that complete revascularization was associated with less repeat revascularization, 7.7% against 11.6%. But very important point is, there was no difference in MACE or mortality. No difference between MACE and mortality. Again, revascularization was required in slightly higher number of cases. And I'm pretty sure if we can increase the compliance of go with this guidelines therapy, I'm pretty sure we can halt the disease of coronary artery disease, and with the inclisiran and PSK2 inhibitors and all these drugs, probably in future, just giving a Lima to LED graft and then treating rest of the things by the medical management may be the future. Maybe the future. I'm not sure, but yes, in another 5-10 years, everything will be quite clear. So what I did is, this was my thought process. I thought, let me ask the cardiac surgeon across India. So I pushed this survey across the cardiac surgeons in India. I got response from 75 cardiac surgeons across India. The first question I posed was, in difficult case with diffuse disease, will you graft Lima to LED and come out? And 70% of the surgeons said yes. If I do just Lima to LED, patient is going to do well. There is no need of treating or doing a bypass graft for a diffusely disease, circumflex or right. Another question which I posed was, if the post-CABG patient has patent Lima to LED and other grafts are blocked, will you do a redo CABG or medical management? And the answer was, by majority of the people, 76% surgeons said, or even the cardiologist will say,
2 minutes
that
remaining.
only medical management is good enough. And third question which I posed was, do you think that only Lima to LED is enough for survival? And 57% patients, surgeons said, they said yes. So they were aligning with what I was thinking. Yes, if you do a Lima to LED graft nicely, then definitely you are going to benefit this patient significantly. So the take-home message from this whole trial and analysis that I went through, that Lima to LED, all your patients, if you are subjecting your patients for a bypass surgery, see to that at least they get a Lima to LED, whether it is a midline sternotomy or minimal invasive. Because right now, a lot of in Ayushman cases and everywhere, only SVG to LED is being done. Lima to LED graft is not being given to majority of the patient. So see to that they get Lima to LED. Mid-cap mixed CABG with Lima to LED have shown authentic long-term data. In MICS, even if incomplete revascularization is done with good Lima to LED, no issues. Don't worry, that patient is going to survive, may have some chronic stable angina, but he will be doing fine. In older age patient with high morbidities, just go in, do minimal invasive Lima to LED, and that patient is going to go do well. Incomplete revascularization is better than not doing anything in a symptomatic high-risk patient. You at least offer them Lima to LED minimal invasive. Thank you very much and appreciate.
Thank you. Thank you, sir. Excellent topic. Discussed very well. Now I invite Dr. Satya Gupta for the management of active pulmonary embolism, latest update.
Yeah, good morning, everybody. So, Dhiranbhai, can we interpret it like this, that if Lima LED is doable angioplasty and triple vessel disease, we can just come out with the LED angioplasty and rest we can manage medically? No, Lima to LED and whatever the good angioplasty to LED, I think it's a and hybrid maybe, yeah. Yeah, so good morning, everybody. So I'll be talking on the acute pulmonary embolism. This is the one area where I love to diagnose the patient with acute pulmonary embolism and love to treat the patient, because I think this is the one condition where we really take a much interest. You can save the patient from like high mortality. I think no patient should die from acute pulmonary embolism, because this condition is totally preventable and it's 100% curable. So if you diagnose this pulmonary embolism at a correct time, I think you can save your patient. So I'll be just briefing about the acute pulmonary embolism. I have no financial disclosure for this. So whenever we talk about the pulmonary embolism, we must talk about the DVT, because the pulmonary embolism and DVT go hands on hands. Almost 90% of the patient, if you diagnose a acute pulmonary embolism, they will be having the deep vein thrombosis. So it's gone hand on hand. And it all depends upon how much physician take interest in diagnosis and the treatment of the pulmonary embolism. Sometimes when the radiologists do a sonography and they say there is no DVT, but as a physician, as a treating physician, you have to ask your radiologist whether there is a pelvic DVT, because pelvic DVT is the one thing where mostly the radiologists miss if you are not giving a clinical condition. So whenever you are advising ultrasonography or Doppler for a patient with acute pulmonary embolism, ask your radiologist to do a proper ultrasound study and see if there is a pelvic DVT, because almost 90% of the patient, the pulmonary embolism originates from the deep vein of the lower limb or the pelvic vein. So it's very important how you investigate your patient. And it's not very rare condition. It's almost out of 1,000, 1 or 2 patients will develop the acute pulmonary embolism. So ratio is very high. Almost it's the third leading cause of death worldwide. And it's the largest unexpected death in the hospital. You must have heard so many times the patient was doing all after surgery and suddenly he died. So it's a leading cause of sudden unexpected death in the hospital. And the most worrisome part is almost 50% of patients who underwent the post-mortem, they could not find there was suspicion of the pulmonary embolism. So still, we are not suspecting in those patients of pulmonary embolism, and those who are suspecting, only 25 to 35% of patients have the acute pulmonary embolism. So pulmonary embolism is a diagnosis of a suspicion. Once you suspect the pulmonary embolism, then only you can diagnose the pulmonary embolism. So your clinical acumen has to understand that what subset of patient can present with the pulmonary embolism. Whenever there is a disharmony between the stasis of the blood, like the flowing blood stays somewhere, if there is an imbalance in the coagulability status of the body, or if there is a trauma to the vessel, that can lead to the thrombus formation in the body. And ultimately, there are so many conditions like the long haul travel, like long flights, surgery, immobilization, post-operative orthopedic surgeries, patient with elderly patient, patient smoking, diabetes, all these conditions that can lead to the stasis of the blood, hypercoagulable state, and that can lead to the acute pulmonary embolism. So you have to think whether your patient belong to this high-risk category group. Yes, if yes, then you must investigate these patients for the acute pulmonary embolism. And what happens once the patient develops pulmonary embolism? The pulmonary pressure goes high, patient hyperventilate, there is a decrease in the oxygenation and decrease in the pulmonary compliance, and ultimately patient develop the symptoms. Not to confuse that, people think that all patients with pulmonary embolism will have the dyspnea. No, some patients, almost 25% of patients may not have the dyspnea. They just have the pleurisy kind of pain, cough, leg swelling, and non-specific symptoms. Some patients even may present with acute coronary syndrome. So it's very important what subset of patient you are treating and what are the symptoms of the presentation. And there are 2 scores. One is a revised Geneva score, other is a Wells score. Based on that, these scores are nothing but just based on the clinical risk factor scenario and the clinical presentation. If you know elderly patient, obese patient had orthopedic surgery and now he suddenly developed the dyspnea, you don't need all this score. You just have to suspect that this patient may have the pulmonary embolism and diagnose and treat accordingly. So the pulmonary embolism is definitely a diagnosis of suspicion. The more high level of suspicion, you will be able to diagnose the pulmonary embolism. There are so many batteries of investigations available. You don't need all investigation in all the patients. You just have to select which patient require which investigation, and based on that you can diagnose. There is a myth that all pulmonary embolism patient will have the hypoxia. No, because of the hyperventilation, the SpO2 level may be normal. So it is not that all pulmonary embolism patient will have the hypoxia. This is very good test. Like if you want to rule out the pulmonary embolism, do a simple D-dimer. If D-dimer is normal, you have almost ruled out the pulmonary embolism. But if D-dimer is high, then you can advise probably the CT pulmonary angiography, and if positive, then the diagnosis is confirmed. So only with the D-dimer and CT pulmonary angiography, you can diagnose this very grievous disease. And X-ray may not be helpful, but sometimes it may be helpful. You may see the this clear-cut sign of Pella signs. There is a enlargement of the descending pulmonary artery. There may be abrupt, smaller of the pulmonary artery, or you may see sometimes the hilar opacity, like the wedge-shaped opacity, which we call the Hampton sum. These are the radiological signs, but they may not be present in all the patients, and they may just guide you, but they may not diagnose the acute pulmonary embolism. So almost all patients can have the either abnormal X-ray or the normal X-ray. So based on X-ray, we cannot diagnose the acute pulmonary embolism. Yes, the certain findings in the X-ray may help you the diagnosis of the acute pulmonary embolism. Some patient may appear just like opacity. But if your clinical suspicion is very high for the acute pulmonary embolism, I think you must investigate these patients for the pulmonary embolism. Most of the patients, they have just tachycardia, incomplete RBB, axis deviation, and only 20% of patients will develop the typical S1Q3 T3 pattern, like in the MBBS days, DM days, MD days. We just see acute pulmonary embolism, there has to be S1Q3 T3 pattern. It doesn't mean. Only 20% of the patient can have the S1Q3 T3 pattern, and most of the patients, they will have either tachycardia, they will have the incomplete RBB, or they will have the finding of the RV strain. This is very important. All patients with suspected acute embolism must have a good echocardiography, and if it's a massive pulmonary embolism or it's a submassive pulmonary embolism, you will definitely see RV dilatation in the echocardiography. You will see the increase in the pulmonary pressure, and based on that we decide, okay, clinical scenario is fitting, D-dimer is positive, and echocardiography is also suggesting the RV strain. That means the patient is having the acute pulmonary embolism, and these sorts of patients should go for a immediate CT pulmonary angiography. RV overload, yes, if RV is dilated, RV dimension more than 30, RV to LV ratio more than 1, 60/60 sign means PA pressure more than 60 and pulmonary acceleration time less than 60. Again, it suggests severe pulmonary hypertension. McConnell signs are typically seen in the echocardiography. The RV apex will be hypercontractile, but the body of RV and the middle part of the RV will be hypocontractile or the hypokinesia. So which is a typical telltale sign of the acute pulmonary embolism, which we call the McConnell signs in the echocardiography. As I said, venous ultrasonography is good tool to rule out the DVT, but again you have to tell your radiologist to check
I have questions. Dr. Dhiren sir here very nicely mentioned when to do Lima to LED. But I have another different question. When to avoid Lima to LED? What are the situations where we have to avoid Lima to LED for a patient? What are the indications?
Avoid Lima to LED is only if the Lima is damaged. Otherwise, by default, Lima, if you are doing a bypass surgery, it is mandatory that the patient should get a Lima to LED. So one is, if the Lima is damaged, don't use that Lima. And second, sometimes you do get, after LED infarction, there's a big aneurysm there. Apical big aneurysm is a scarred area, totally dead area. You're doing aneurysmectomy in that patients. Then definitely Lima to LED has no scope or any reason for doing it. So these are the only two indications where you should not do Lima to LED. Otherwise, even in low EF, in crashic patients, every patient is undergoing bypass surgery, Lima to LED is mandatory.
Sir, in case of pulmonary embolism.
Yeah, I think when there is a crashing patient, I think when you want to do immediate, early bypass surgery, sometimes it's not possible to get the harvest the Lima, and then this emergency scenario also, I think.
No, in that case scenario also, what we do is we put that patient on pump, and then we harvest the memory artery.
Okay.
So subclavian stenosis is one situation, obviously, wherein you should not do Lima to LED.
Sir, in cases of pulmonary embolism, why we all should responsible the orthopedic surgeries, which are including TKR, no surgery is a major surgery or even a long surgery. Patient remains mobile pre-operatively and also post-operatively immediately after the anesthesia is over. So why there should be more pulmonary embolism in orthopedic surgery?
Yes, orthopedic surgery, they ambulate the patient second or third day, but at least there will be 48 hours at least immobilization. So
No,
it's
sir.
a one
No,
kind of procedure where you have the high risk for a pulmonary embolism. And all orthopedic surgery, I think they should have the prevention or prophylaxis for the DVT.
That is true, but we do not keep the patient immobile for a so long time. Till
But at least you keep for
up to
24 hours.
anesthesia is over.
Hello.
Patient is mobile, sir. Even in a case of TKR also, sir.
Sir,
Yeah.
I mean, see, let me also put some point to that. In spite of all vigorous efforts of all the orthopedicians to mobilize patient early, as soon as they go home, they are immobilized. Entire society will be on that patient. Bhai, aapko hilna nahi hai, chalna nahi hai, dulna nahi hai. So immobilization is enforced by the people, by the society, by the families. Orthopedic surgeon might be asking that my patient goes home walking on day 2, but then it doesn't happen when they go home. It's really a very high-risk situation. It's very unfortunate that most of the orthopedic surgeons do not believe and accept that it's a very serious condition. We keep on treating so many acute pulmonary embolisms of orthopedic surgery. Not only it's orthopedic surgery, anything which is immobilized. If somebody is paraplegic, somebody has embolization because of some other reasons, they are extremely serious conditions. And it's proven across the world. There are so many orthopedic surgeons, I have talked to them, they say, Anish, in my practice I have not seen, I unfortunately do not give them answers back, but then across world there is huge data. We Indian patients even more risk of DVT post-orthopedic surgery. So we have to have preventive strategies. We have to have, there is no other side of that.
Sir, I am a physician. Here I am confused with the talk with Dr. K. Bhai and Dr. Dhiren Bhai. What is your opinion regarding the complete revascularization? Whether you suggest or he refused. So what is the difference?
I'll tell you, it's a debate next year. Me and Dhiren Shah will have a debate because I don't think we have time to discuss that. So wait till next year. We'll stop the session now. Time is over. Lunchtime questions. Next session to start.
Thank you very much, everyone.
No. My point was that complete revascularization definitely
Next
is
year,
a superior.
Dhiren.
But yes.
So for the next session, I invite Dr. Urmil
If he's
Shah
around, he can just join me.
on the dais as panelist and call everyone. Dr. Virendra Pal Bhalla as a panelist. Dr. Apurva Patel, Dr. Mahadev Patel, Dr. Manish Mehta, Dr. Mayank Thakkar, Dr. Nakul Sinha, Dr. Pragnesh Vora as chairpersons, and Dr. Akash Joshi, Dr. Bhavesh Oza, Dr. Kaushal Patel, Dr. Riddhi Pandya, and Dr. Leena Dabi as moderators. Request all to be on the dais. And Dr. Ashok Shah. Dr. Ashok Shah, please be on the dais. Yes.
Good morning, everyone. We'll start with the next session. I have Dr. Urmil Shah presenting on clinical trial of 2025, which may change my practice, part 1.
Good morning, everyone, respected chairpersons and moderator. All these trials which I'm going to publish today are mainly, I've divided it into two parts. Today I'm going to talk more about acute coronary intervention, then regarding heart failure and myocardial infarction and antiplatelet agents. And all these trials have been taken from the NEJM, JIC, so big journal, because there are so many trials, so it's very difficult to decide which trial to take and which trial not to take. So without wasting much of time, I will just go to the trial. We all know that single vessel disease, double vessel disease, by and large angioplasty is better, but there is always a debate. And recently, Keyur Bey and Dhiren Bey was talking what to do. The discussion many times goes for the triple vessel disease, okay, and whether we should go for a bypass surgery or angioplasty, multivessel. That is always the question. One interesting study which was published this year, that was a FAME study, where a multivessel revascularization were compared with the bypass surgery. And the same study at 1 year data did not show that angioplasty was superior to the bypass surgery, or equivalent to the bypass surgery. The 5 data has been published on this time. As you can see here, 1 year there was a difference, but at the end of 5 years, the landmark analysis of death, stroke, and myocardial infarction at the end of 5 years were practically same. There was no major difference. Only difference was repeat revascularization was slightly more, and as you can see here, death, stroke, and MI was almost comparable. So 5-year long-term data, triple vessel disease, by and large angioplasty and bypass surgery was same in this study. Second, always confusion is left main disease, whether one should go for a bypass surgery or angioplasty. This was a study, 10-year data was published this year. That was a Nobel study. Patient with acute coronary syndrome and chronic coronary syndrome, left main disease, both surgeons and angioplasty were taken into consideration and finally decided to randomize the patient. As you can see, at the end of 10 years, the outcome is practically same. There is no major difference in the outcome at the end of 10 years. And as you can see, if you use an intravascular ultrasound during the angioplasty of left main disease, the outcome was slightly better. So overall, left main disease also, bypass surgery and angioplasties are comparable, and especially when using IVAS, then outcomes are definitely good. Sub-analysis showed that when the patient presented with acute coronary syndrome, okay, and left main disease is there, angioplasty was slightly better compared to the bypass surgery. So this also is a important landmark study which was published. The sub-analysis showed diabetic patient, distal left main disease, syntax score high, also showed almost similar results. So there was no major difference in this subgroup. So 10-year data, all mortality, left main disease, bypass surgery versus angioplasty is practically same. On the contrary, subgroup analysis showed that acute coronary syndrome, the PCR outcome was definitely better. In 2020, a study was published regarding the patient who is having heart failure and recent hospitalization. That means patient required an IV therapy or patient has been admitted, and they were subjected to oral therapy, very cigarette, and the results were positive. That means they showed that the primary outcome as far as myocardial infarction and heart failure is concerned was definitely better. The another study in different subgroup with the same molecule has been published this year. These are a stable patient, ambulatory patient, no recent hospitalization, but they were having a high NT-proBNP. The primary outcome was death and recurrent hospital admission, and secondary outcome also were looked into it. That was mainly a cardiovascular mortality. 6,000 patients were being followed, but as you can see, the primary outcome was not much different, meaning by the cardiovascular death or a first hospitalization were practically same in this group. But if you look at the secondary endpoint, the cardiovascular death was definitely improved with the VeriSiGate, and all-cause death also was definitely better. As far as heart failure readmission concerned, there was no major difference. But when you consider the OPD emergency giving of the diuretic therapy in an unstable patient, there was a significant improvement. So overall, this study was a positive study. It did show a mortality benefit in this group of patients also. The adverse effects were mainly symptomatic hypertension and anemia in some of the patients. So though it did not show a primary endpoint benefit of this study, the secondary analysis, detailed analysis clearly shown that mortality was definitely better with this group. And when you include the OPD IV therapy in this group with the heart failure recurrent admission, there was also improvement. So overall, it was a positive study. So VeriSiGate, the meta-analysis was done later on in all the subgroup of patients, like recently admitted patient and the stable patient, which was done in both the studies like Victoria and Victor. Both have meta-analysis clearly showed that there is a significant advantage as far as heart failure recurrent admission and cardiovascular mortality is concerned. So this is a molecule which can be given across all subset of patients. SGLT2 inhibitor, we all know, is a good molecule. We use it in all the patients of heart failure with different ejection fraction, meaning by preserved ejection fraction and LV dysfunction. This was the meta-analysis which was done, which has included 3 major studies, DAPA-HF, DELIVER, and DAPA-ACT. All, and the meta-analysis clearly shown that outcome as far as death and worsening of heart failure is concerned is definitely better. The cardiovascular death also was good, and worsening of heart failure also was good. So all the subset of patient, whether recently hospitalized or patient is a stable patient, addition of dapagliflozin was found to be beneficial regardless of age, sex, GFR, presence of diabetes or non-diabetes. And it was beneficial across all subset of patient, meaning by patient with preserved ejection fraction, the benefit also was there. Another molecule similar is empagliflozin. We all know both are a SGLT2 inhibitor. And this was the one-to-one analysis or comparison of both the group, whether one is superior to the another. Almost 4,000 patients, 4,900 patients were taken. And as you can see, both have a similar result. Meaning by whether you use dapagliflozin or empagliflozin, the benefit as far as outcome is concerned is good. They have also done a separate analysis for looking at the ejection fraction. That also showed that the beneficial effects of both molecules were comparable. When you look at the patient of obesity and heart failure, we know that we have an obesity-reducing molecule like tirzepatide, which reduces it, and we all know that heart failure with preserved ejection fraction is also associated with obesity. This study clearly shown that along with reduction in obesity, the heart failure with preserved ejection fraction, the long-term outcome was also better as far as heart failure is concerned. So this was also a very good positive study. We all know that semaglutide also is an obesity-reducing medicine. Tirzepatide also is an, and we know that tirzepatide has more weight reduction compared to the semaglutide. And this was a study which was done in patient who is having diabetes with heart failure and preserved ejection fraction. We have previous comparison with the placebo, and this was more of a head-to-head comparison. And what basically it showed that as far as outcome is concerned, heart failure and cardiovascular mortality, reduction was definitely there compared to the placebo, but tirzepatide did not show a significant advantage as far as outcome is concerned. So both molecule, though the anti-obesity effects is more with the tirzepatide, but semaglutide also has a good effect, and both are practically same as far as heart failure recurrent admission is concerned. Finerenone is a good molecule which we normally use for heart failure with preserved ejection fraction. As you can see here, this was a sub-analysis which was done of the FINARIS-HF study. The need of oral emergency up-titration of diuretic therapy was significantly reduced with this group of molecule. And as you can see, the composite of cardiovascular death, heart failure admission, and urgent heart failure visit, emergency visit also was significantly done when finerenone was used. So this was a sub-analysis of the big study which was done previously. We all know that heart failure with preserved ejection fraction, atrial fibrillation is a deadly combination, because if this patient goes in the atrial fibrillation, they are more worse. So this was a separate analysis which was done, whether finerenone was useful in this subgroup of patient or not there. And this is finerenone was titrated 20 to 40 milligram. As you can see, around 6,000 patients were taken. One conclusion with whenever atrial fibrillation is there, overall outcome for this group of patients is bad. But if you look at the comparison of heart failure with preserved ejection fraction with AF and without AF, those with the AF also showed a benefit. So irrespective of patient's presence of AF or not AF, the beneficial effect of finerenone was continued in this group of patients. Many times we do come across a patient whose ejection fraction was low previously and now it has gone to normal, maybe more than 40 or 45. And this group of patient, whether we should be giving finerenone or not. So this was a good study which was done. This study clearly shown that whether the ejection fraction was previously low or previously normal, the beneficial effects of finerenone was there. So those patients who has ejection fraction improved, finerenone has found to be beneficial according to this study which was published this year. We all know that finerenone and acetylcholine beta are good molecules as far as cardiovascular mortality and kidney outcome is concerned. This was a study which was done in patient who is having renal dysfunction. Combination of this therapy versus single therapy. And what was found that if you combine this, both therapy have been found to be beneficial separately, individually, but this study clearly shown that if you combine this molecule, the beneficial effects as far as mainly the renal outcome is concerned is definitely high. And no major side effect as far as unexpected hypertension, serious hypertension or acute kidney injury or hyperkalemia was concerned. Heart failure with normal ejection fraction has very limited option at present. One of the option we know it is an MRA, that is a finerenone which we are using. Acetylcholine inhibitor also is found to be beneficial, as I have shown, dapagliflozin, empagliflozin, and GLP-1. When the obesity is there, all these three molecules have been found to be better. This was a study which was done mainly to see whether a combination of these three therapy will give an overall benefit to these patients or not. And as you can see here, when you combine this molecule, it may be 2 molecule or a 3 molecule, meaning by MRA, acetylcholine inhibitor, and GLP-1 agonist. All these therapy have shown to be additional benefits. So heart failure ejection fraction, it is something like different pillars for the reduced ejection fraction. Now we can say that we have 3 options available, and especially when obesity is also there, this 3 combination is definitely found to be better as far as cardiovascular outcome is concerned. Iron therapy for a patient who is having heart failure is an important subset of patient, important group to be treated. This was a study which was done. The corrective dose was 2,000 milligram of IV therapy was given, and maintenance of find it for about 4 months. Main study outcome purpose was to see whether the heart failure recurrent admission is gone down or mortality has gone down. As you can see, there is a significant advantage of heart failure recurrent hospitalization, which was there. Mortality was not that much better, but if you analyze the quality of life indicator, that was also superior. So overall, heart failure recurrent admission and quality of life will be much better if in a patient of heart failure with reduced ejection fraction, you give IV iron therapy. Previously also, the studies have been done regarding this subset of patient, and this meta-analysis which was also published after this study, where they have included all the patient where IP was given to the group of patient who has low ferritin or low saturation, and overall benefit as far as outcome is concerned, recurrent hospital admission was definitely better. Many times we try to tell our patient to restrict fluid intake, okay? Whether it is good, it is advisable in this group of patients. So those patients who, this was the fresh up study which was published. One study have a fluid restriction. Over the outcome of this study, there was no major advantage of restricting the fluid intake, especially those patients who are relatively stable at the end of 3 or 4 months. So those patients who are having volume overload or edema, we can definitely tell them to restrict the fluid, but otherwise there is no need to restrict this thing. Digoxin is a molecule which has been studied, one good study which was published. It was an international double-blind study, digitoxin was used, and this was a little positive study. So those patients who are having ejection fraction less than 40%, digoxin primary outcome as far as heart failure, recurrent admission and death is concerned was definitely found in this group of patients. When coming to the dual interpreted agent, we all know that ticagrelor, aspirin, post-CABG patients, many a times we continue for initial 2 or 3 months. This was a study which was published, whether we should be continuing the dual interpreted agent longer than 3 months. And the outcome of this study was clear. We should not be continuing. It more cause more bleeding complication. It does not give additional advantage. So we can stop the dual interpreted agent after 3 months of a bypass surgery. Another important subset of patient post-angioplasty, how much to continue a combination of antiplatelet therapy. And they have stratified this in this study into 2 groups, high bleeding risk group and low bleeding risk group. And the conclusion of this study was, the medicine dual antiplatelet to be continued 1 month versus 3 months. And what was found that if you reduce the radiation to 1 month, the advantage is not there. So the conclusion that we should be continuing even in the high bleeding risk group of minimum of 3 months of dual antiplatelet agents unless the patient has any major bleeding complication. With the low bleeding risk, there is an advantage. You should be continuing dual antiplatelet for 3 months. After 3 months, if you stop one, because if you continue later on, the bleeding complication chances are more. So overall conclusion that 3-month dual antiplatelet agent with the recent drug protest sense is by and large good. There is no need to continue for a longer time. After dual antiplatelet agent, whether one should be continuing with aspirin or we should be continuing with clopidogrel, there is always a debate regarding this. This was the study which clearly analyzing this group, clopidogrel monotherapy versus aspirin. As we can see here, the outcome of this study as far as bleeding complication is concerned, the clopidogrel was found to be superior compared to aspirin. So after 3 months of dual antiplatelet agent, we should be continuing comfortably only clopidogrel, and we may not be giving aspirin to this group of patients. This was a meta-analysis which also published related to this, whether we should be continuing aspirin post-dual antiplatelet agent or clopidogrel, and this trial clearly shown the advantage of continuing clopidogrel compared to the aspirin. Whether we should be stopping aspirin early in a patient with low-risk microinfarction, because most of the patients are now undergoing angioplasty. And this was a study which said that up to 3 months we should be continuing the dual antiplatelet agent. After that, a single antiplatelet agent should be by and large okay. Many times we do come across a patient who are having LV dysfunction and a clot in the left ventricle. Normally we try to give an warfarin or acetylene this group patient. This was a study where the comparison was done with the NOAC, that was rivaroxaban. And this study clearly shown that if you use a rivaroxaban versus warfarin, the clot resolution was almost same. So we can practice, whenever you come across a patient with clot after post-MI, we can continue with, there is no need of warfarin, we can give a rivaroxaban in this group of patients. Atrial fibrillation and oral integration, there is always a debate whether we should be continuing. This was a very nice study which was published.
5 minutes remaining.
Which was published, which clearly shown that at the end of 12 months of the angioplasty, those patients who are having atrial fibrillation need an oral integration. The data clearly showed that this group of patients, we should not be stopping aspirin after 1 year. So atrial fibrillation and drug coated stents, we should not be giving aspirin after 1 year. That was the conclusion of this. A similar sort of study where the duration of oral regulation and antiplatelet agent was 6 months. So after 6 months, it's also the bleeding complications are more, and there is no advantage as far as outcome is concerned. So we can safely stop the antiplatelet agent in a patient who is having atrial fibrillation and drug coated stent after 6 months or maybe 12 months. Regarding a beta blocker in myocardial infarction patient, as you can see, there is always a debate. Nowadays, we are doing with the angioplasty with good antiplatelet agent and anti-lipid lowering agent. Whether ejection fraction is good, okay, after myocardial infarction, we should be giving beta blocker or not. So this was a study which was published recently in NEJM, which clearly shown that continuing beta blocker after myocardial infarction, if ejection fraction is more than 50%, is not good. The similar study was published which showed some advantage of using beta blocker, and that was the reason a good meta-analysis also was published in the NEJM this year, which showed that whenever the ejection fraction is more than 50%, we can definitely stop the beta blocker. But if ejection fraction is between 40 to 50%, we may be giving, or maybe less than 40%, definitely beta blocker will be beneficial in this group of patients. So beta blocker and myocardial infarction, we can safely stop after a certain period of time. This was a meta-analysis which clearly shown that ejection fraction is more than 50%. There is no advantage of continuing beta blocker if the ejection fraction is good post-myocardial infarction. Drug-coated balloons have been recently used. We are using drug-coated balloons since long. This was, but by and large, the data was more in the favor of stent. That was the reason we are using stents. As you can see here, this was a study which was published recently with the new drug-coated balloon, and this showed that it is equivalent. So in some subset of patients nowadays, there is an option of de novo drug-coated balloon rather than putting stent in all the patients. So this was one positive study which has come as far as drug-coated balloon is concerned. So de novo drug-coated balloon may be equivalent to the stent implantation which was found in solution de novo study, as you can see. The same way, a patient who is having severe carotid stenosis, whether a carotid endarterectomy versus putting a stent. So this was a study, CREST study, which was published recently, where they have done comparison of endarterectomy versus angioplasty. And this study clearly showed that compared to the medical management, even in the asymptomatic patient with high-grade carotid artery stenosis, the beneficial effects of put a stent is there as far as stroke reduction is concerned. But at the same time, this study showed that if the patient undergoes further intervention, surgery, the beneficial effects were not there. So an asymptomatic patient, severe high-grade carotid artery stenosis, compared to the medical management, carotid artery stenting is found to be superior. There are last two studies which I'm going to talk regarding the intervention. This was a long-term study, partnered through study regarding a low-risk TAVI patient. Previously, we have the data up to 5 years. Now we have the data up to 7 years. And at the end of the 7 years, we can simply say that outcome of surgical versus TAVI is almost equivalent. So long-term data now we have for a low-risk patient, symptomatic severe aortic stenosis, comparing surgery versus non-surgery, and the beneficial effects were there. Regarding the aortic regurgitation also, nowadays there is a special valve which is possible we can put percutaneously. And as you can see here, overall the hemodynamic performance of this valve was found to be very good. Paravalvular regurgitation was quite less, and NYHA symptom benefit also was there, quality of life also was good. So this was a study and which clearly tells that in severe AR also we can use this molecule. Conclusion, I would say, heart failure, Victoria and Victorian varicocele is found to be superior. Dapagliflozin is good in all subset of patients. Empire-Dapa is practically same. Finerenone is found to be beneficial even in the patient who is having atrial fibrillation. Beneficial effects of tirzepatide and semaglutide heart failure admission is concerned is by and large same. I will just like to conclude by saying last two things. Beta blocker, ejection fraction more than 50% we should be using. And I did not do, but the colchicine in one of the trial has found to be not beneficial post-MI. So it is still a controversial molecule to be used. Thank you very much.
Thank you, sir, for a nice presentation. So next is Dr. Apurva Patel, sir, for screening of aortic valve replacement when physicians should refer for aortic valve replacement. Thank you.
Good morning, everyone. My name is Apurva Patel. I come from New York. I'm an interventional cardiologist. First of all, thank you, Dr. Anish Bhai and Dr. Tejas Bhai and the entire JIC 26 committee for this opportunity to present today. I'm going to be speaking on screening for TAVR. These are my disclosures. So TAVR has been a disruptive technology. It initially was used in patients with extremely high risk and was found to be superior to medical therapy, which we all know that there is no medical therapy for aortic stenosis. Then it has been proven along the years to be non-inferior to surgery in high risk, superior to surgery in high risk, then non-inferior to surgery in intermediate risk, and as well as in low risk. As it was mentioned just now by Dr. Urmil Shah, that it has been faring similar to surgery for over 7 years. And one of the misconceptions is that there is no long-term data for TAVR. That has been dismantled now. So with that thought in mind, the current guidelines, and the main thought behind presenting these guidelines is Whenever there are two therapies, one is a lesser invasive strategy compared to the other, and if both are similar, the lesser invasive strategy always becomes the superior strategy. So currently in the United States, there are two things that drive when TAVR is offered to the patient. One is age, and second is the anatomy. The surgical risk profile currently does not hold much value when we come to screening patients. So anybody above the age of 80, there is no questions. Patient is going to go for TAVR, irrespective of whatever the thing is. If the patient is less than 65, because there were no TAVR patients, there were no patients that were evaluated for TAVR in the trials, the guidelines are never going to recommend TAVR in this particular population. The patient is going to go for surgical aortic valve replacement. Whether you get a mechanical valve or a bioprosthetic valve, that is a secondary level of debate, which we can talk about. Now, coming to the majority group, age of 65 to 80, which are patients with symptomatic severe AS, as well as symptoms, and they're active as well, and what do you offer? And that's where both surgery and TAVR have a class 1 indication. And it is all driven by anatomy. What can you do safely for a patient? And what is the particular center amenable on offering? So currently in the United States, there are more than 800 sites that offer TAVR, 832 to be very specific. And more than 1 lakh TAVR procedures happen annually. And the number of surgical AVRs have dramatically reduced. It happens like 4,000 cases a year. An average AVR performed by a surgeon is like 4 to 6 per year. That's it. And India is growing when it comes to TAVR. It's not at the same level as United States, probably because of the cost. But we have here in India around 250 to 275 sites, and they perform around 4,000 cases a year, not 400, 4,000 cases. The major difference between United States, or actually the entire Western world, and India is India has predominantly bicuspid cases. 40% are bicuspid aortic valve stenosis, which is primarily a genetic feature. And in my short experience while working in India, you see a stark difference between the north and the south. There is a political debate about it. There is an aortic stenosis debate about it as well. So northern India has more bicuspids compared to southern India. I don't know why. So the key decisions, like, when you talk about from a referring perspective or a patient perspective or even the implanter's perspective, there are three things that matter. Like, the outcomes, you want the procedure to get it done safely. How long the valve is going to last, right? If somebody is paying 20 lakhs out of pocket, they want to make sure their return on investment is like supreme. And the third thing is the person doing it, whether he or she is good, like whether they feel that, whether they can offer a good result out of it. So when we talk about lifetime management of aortic stenosis, right, like we talked about the anatomy, which I'll discuss further in detail, but what do you offer first, surgery or TAVR? And it all depends on what do you want to do with, like it's depending on the life expectancy of the patient. So in the United States, the life expectancy is around 87 years, right? So our job as a doctor is like, with the minimum amount of re-interventions, how can we make that patient reach that particular age, right? Statistically, beyond 87, it's all in God's hand. Like nobody can predict or offer long-term longevity. In India, per the data, the expectancy is 67. Obviously, this is skewed. Maybe it's even higher in the current day and age. It's probably closer to mid-70s. But the same concept will also work. Like, what do you offer? Bioprosthetic valves do not last a lifetime. Okay, everybody needs to know whether it's placed surgically or transcatheterly, 10, 15 years maximum. So when it comes down to anatomy, right, like I've been talking a lot about it, like what prohibits TAVR? So if you look at this CT aortogram here, you see these thick chunks of calcium. So in TAVI valve, we cannot remove the calcium that is there in the aortic valve. Like Dhiren and Dhaval, they can scoop this thing out and put a new valve in its place. So this is the only prohibition from the TAVR perspective, because just like in a stent, if there is calcium and if you don't modify it, the stent will not open. The same thing in a TAVR valve. I don't have a rotablator for that space. So the TAVR valve will not open and will lead to PVL and under expansion. This is not that extremely common, small percentage of the people, but that needs to be taken into consideration when you're planning a procedure for your patient. There are favorable anatomies, which is majority of the cases, where you have nice, crisp calcification for the valve to stick in there, your femoral artery is wide and open for the devices to go in. If you look at the TAVR procedure by itself, the procedural time is 30 minutes. By the time the crack is just open, Milan Bhai and Tejas Bhai will probably be having tea outside in the doctor's lounge after doing the case. So it's basically like you align the pigtails to create your angle, and you basically deploy the valve by doing an aortogram. And this is an aortic valve in your right column functioning normally at the end of 30 minutes. So how about bicuspids? They say bicuspid, there's an oval annulus, doesn't work. Well, that's not true. It does work. If it is not heavily calcified and the anatomy is favorable, this is a type 0 bicuspid, like real bicuspid. And if the femoral arteries are fine, TAVR valve will work. And it has fared very well. There is lots of data which says that TAVR in a bicuspid valve fares the same as a tricuspid valve. And this is just an example of a Medtronic valve being deployed. This is the valve being deployed at 80%. This is the release of the valve. And this is the final aortogram, which says good sealing, no PVL, and great functioning of the valve leaflets. As shown before, 7-year follow-up of the PARTNER SAPIEN data, valve functioning is excellent, and freedom from death and any complication is actually numerically lower, statistically the same as surgical aortic valve replacement. You have to understand, if this was a low-risk patient for surgery, it was a low-risk patient for TAVR as well. Same thing for Medtronic, which is a self-expanding valve platform. We have 5-year data, and the results are actually better when it comes there. And following up on the data in our community, their long-term follow-up and their valve performance actually will turn out to be even better than the other platforms. And the same results are coming out from the Abbott Portico valve, where the valve performance at 5 years is actually doing very good, and the balloon and the valve failure is only 2%, which is very minuscule. We have data up to 10 years, which is commercially available from Europe, where TAVR valves actually fare better than surgical valves in long-term follow-up. So from the patient's perspective, it's at the end of the day, it's what the patient wants, right? When it comes to cost, as like, I know exactly what I want. And what they really mean is they want the lowest risk. It's like low risk, high benefit. That's what they want. And what you can do to offer them in this particular spectrum. The quality of life also has to be good. Like we have lots of data to prove that the NYHA class at 30 days, length of stay, and getting back to the routine day-to-day activities is much faster, quicker with TAVR valves. Because you don't have an open chest, you don't have to worry about a whole lot of morbidities which are normally not presented in routine data when we talk about open heart surgery. So then the question arises that, okay, what if the TAVR valve fails? Can you explant it? Can you do a surgery, or you do a TAV in TAV? TAV in TAV technically has lesser risk if done in the right way, but TAVR explant is also an option. The mortality with TAVR explant is there at 6%, which is there with any redo surgeries, but with TAV in TAV, the mortality is much less. So TAVI valve, we talked about de novo aortic valve stenosis,
5 minutes remaining.
but it is also offered in patients with surgical valve dysfunction. On the left, you see a SAPIEN valve, a balloon expandable valve, being deployed in a surgical valve, which also had a PVL. So the PVL was closed with a plug, followed by a surgical aortic valve replacement. And on the right side, there is a self-expanding valve being implanted in a failed surgical valve. These are just some examples where a TAVR valve can be implanted inside a failed TAVR valve. On the left side, a balloon expandable valve is being deployed in a self-expanding platform, and on the right side is the other way around. They tend to do well, and the functioning of the valve is the same as in a de novo prosthesis. TAVR valves are also used in other spaces, like in the mitral space. You have a bioprosthetic mitral valve which has failed, or a mitral ring that has failed, and you can deploy, if it's a full ring, then you can safely deploy a TAVR valve in that particular space to take care of the bioprosthetic MR or MS. So this is a case courtesy of Dr. Milanchak that he performed last week, that I was part to discuss it with him. And this is a TAVR prosthesis that was deployed inside a tricuspid valve done via the femoral vein, and to take care of the tricuspid dysfunction. So key takeaways from my talk. So severe aortic valve stenosis and other valvular disease are largely undertreated. Like, main thing is lack of education, lack of access, and probably cost. And there are a lot of times that these patients are sent for open heart surgery, and in the past there have been high mortality and patients just refrain from getting any form of therapy. TAVR and even valve-in-valve is a definitive therapy. It's not a palliative option. Please, I'm underlining my words, it's not a palliative therapy, it's a definitive therapy, just like a stent is. And so normally in my practice in the United States, anybody above the age of 65, it's always evaluated for a TAVR. The patient is screened with a CT aortogram to see if the patient is feasible or not. And that, with the whole thought process, is you get a TAVR. In 10 to 15 years, if he needs another intervention, we'll offer a TAV-in-TAV, depending if the anatomy fulfills or suffices. If you think that a future TAV-in-TAV may not be an option, then the patient will go for surgery first, followed by valve-in-valve. In India, maybe it's different. Like, the frailty starts early, and maybe the cutoff is 60 to 65. But as I said, that it's always good to discuss with the referring physician and at the center to see what's the best for the patient. So kudos to the SIMS team. They have been doing a whole lot of structural heart procedures, and this is the tally, which is probably increased since the last time I made this slide. So congratulations to them as well, and thank you very much.
Now I request Dr. Nakul Sinha for a guest lecture on optimizing worsening heart failure patient care, exploring evidence with Please go.
A very good morning, and I believe I was coming to attend JIC 20 years back when it is started, and I think the standards have been very well maintained. So all the best wishes to the JIC team. I think this slide set which I had sent has not been loaded. So can it be corrected, or we just do with the I had sent it on WhatsApp 2 days back. Okay,
Hello.
fine. I think I'd like to do that.
So
thank you.
We'll keep on moving. We'll have Dr. Ajay Nayak speak on modification of natural history of atrial fibrillation by appropriately timed intervention. If you could please have Dr. Nayak's talk up, and then we can move to Dr. Sinha at the end. By that time, hopefully we can square his slides away. Thank you.
Can you put on my talk? So I'm going to speak on modifying the natural history of atrial fibrillation. Let it come up. Oh, here it is. Okay. Somebody is competing with my mouse. Remote. Yeah. So modification of natural history of AF with appropriately timed interventions. Okay. Yeah. AF is a very progressive disease.
risk factors accumulate: diabetes, hypertension, obesity. There is electrical remodeling which happens in the heart, which results in structural remodeling, atrial fibrosis. So it's a relentless progressive disease. With time, the AF burden increases. The type of AF moves from paroxysmal to persistent to permanent. And with time, the chances of getting rhythm under control or restoring sinus rhythm becomes difficult. As the AF becomes more prevalent, there is higher risk of stroke, higher risk of heart failure. So we need to understand that this AF natural history, everybody should understand. You should be able to identify the stages of AF and catch it at the right time. Recognize time-sensitive interventions. We'll talk about it. And as far as possible, try to get the patient into sinus rhythm. So when we talk about atrial fibrillation, we have to be aware of which patients are at risk of going into AF. When you've been in practice long enough and you know there is an obese patient, diabetic, hypertensive, BP is uncontrolled, and he is getting some mitral regurgitation, you know that this patient is at some point of time going to go into AF. If on ECGs you start seeing premature atrial beats and all, most likely in the next few years the patient will go into AF. Initially it's paroxysmal, it can go to persistent, and then long-standing persisting. Why does timing matter? Because early AF is more reversible. There is less atrial fibrosis, better response to rhythm control of all kind, and there is a opportunity to alter the trajectory of disease. This is how it would go, remodeling. So you may be able to stabilize the disease and keep the patient in sinus rhythm. So initially the therapy will be upstream therapy: control diabetes, control hypertension, keep weight under control. Rate control and anticoagulation, if needed, should be thought of right in the beginning when the patient presents with AF. And then give consideration for getting the patient into sinus rhythm, either by antiarrhythmic drugs, cardioversion, or ablation. If the disease is too far gone, then you have to think of other ways, other problems to manage. So risk factor modification, upstream therapy: hypertension control, weight control, diabetes control, and we should never forget obstructive sleep apnea, because that is a big risk for patients getting atrial fibrillation. Often these episodes will start in the night, and they are more frequent in the night. They need to be picked up at the right time. So one of the essential questions that I ask these patients is, I ask the patient's partner, does the patient snore at night? Is there any breathing pattern where the patient is breathing and the breathing subsides and breathes again? So that is the time you refer for a sleep study. Lifestyle interventions, very important for AF. A weight loss of 10% will mean a better outcome, more chances of patient being in sinus rhythm, even without antiarrhythmic drug, even without ablation being done. If there is weight fluctuation, patient gains weight, loses weight, gains weight, the results are not that good. But if there is sustained weight loss, 10% of body weight, the chances of patient being in sinus rhythm are much better. This is a very good study published from Australia by Dr. Pathak, who's a good friend. Regular exercise, alcohol reduction, smoking cessation, these are no-brainers. So this was legacy study where it was found that if you reduce weight by 10% or more, chances of patient being in sinus rhythm is much higher. If patient weight loss is less than 3% or there is fluctuation, they don't do as well. Early rhythm control. So treat AF early after diagnosis. It prevents remodeling, it reduces cardiovascular outcome. There is a very good study, East AFNET study, early rhythm control versus usual care. There is reduction in cardiovascular death, stroke, heart failure, hospitalization, and benefit. The separation of these two graphs occurred within a year, so you see the impact right away. Antiarrhythmic drugs, early use, higher efficacy in early AF, lower atrial fibrosis, better long-term rhythm maintenance. The other essential part of treatment means judiciously doing cardioversion, if required once, if required twice, if required 3 or 4 times. But beyond third or fourth time, nobody would try to cardiovert the patient unless you have intervened in some way by putting a CRT, or you've done a surgery and then you would want to cardiovert the patient again. So apart from antiarrhythmic drugs, cardioversions periodically may be necessary. to keep the patient in sinus rhythm, but then if the patient is progressing with the disease, then chances are that the intercardioversion AF sinus rhythm episodes, sinus rhythm periods will be shorter and the patient will go into further AF with time. Catheter ablation, very important, and this was Cabana trial. Best outcomes are seen in paroxysmal AF, so early in part of AF disease. Lower chances of recurrence if done early in the disease, and if you delay it too long, if they are too far gone, then the success rate is less. So after ablation, patients who underwent, who are compared with only antiarrhythmic drug therapy, patients remain free from AF, remain in sinus rhythm, much higher chances than compared to with antiarrhythmic drug. But judiciously chosen patient and optimally managed patient. So this Cabana trial, it showed that patients in the ablation group, symptomatic AF was less compared to those on antiarrhythmic, and any AF was less compared to those on antiarrhythmic drug. So this is the same thing from time of diagnosis. Progression to persistent AF is relentless, remodeling occurs, increased risk of stroke, death, hospitalization, and catheter ablation efficacy reduces. Ablation could be trigger elimination. We do pulmonary vein isolation or VACA or autonomic modulation in some cases, and the technology is improving every day. So we used to do RF energy, irrigation energy, cryo came into picture. The new kid on the block is pulse field ablation. It is a predictable, anatypical way of doing these. The procedure is pretty predictable, shorter, and success rates are much higher. We don't have it in India yet, but hopefully we should be having it by next year. So ablation as disease-modifying therapy. It reduces AF burden, prevents progression, improves the quality of life. Now we need to understand heart failure, atrial fibrillation. Heart failure is going to worsen AF, AF worsens heart failure. And the moment heart failure, even preserved EF, once it starts occurring, chances of AF are likely to be there. It's a positive feedback cycle, one feeds the other. AF worsens heart failure outcome, early rhythm control improves EF, and Castle AF was ablation in patients with heart failure. AF ablation was done. Again, here it was found that patients who underwent AF ablation and remained in sinus rhythm after that, the chances they did very well compared to patients who remain in AF. So getting the patient back to sinus rhythm, the chances of getting any event, primary endpoint, all-cause mortality, heart failure hospitalization, much lesser with ablation and patient in sinus rhythm compared to patients who were in atrial fibrillation. So these are a couple of cases. I'll just show a representation. Initially, you picked up paroxysmal AF, you treated
5 minutes
patients
remaining.
with antiarrhythmic drugs, cardioverted if necessary, if there are repeated episodes. And in right person, maybe these patients will be the right candidates for further intervention. There's a 70-plus-year-old lady, recurrent AF on multiple antiarrhythmic drugs, CVA in past. She had GI bleeding on NOACs, so our options become quite less. So this is atrial fibrillation. What we did here was went ahead and did atrial fibrillation ablation. So this is wide antral circumferential ablation to isolate the pulmonary veins. That restored the patient to sinus rhythm on table, and at the same time she had bleeding on NOACs. So at the same time I went ahead and did a LA appendage closure. This is LA appendage occlusion. 90% of thromboembolism in patients with structurally normal heart, non-rheumatic heart disease, patients with AF, 90% of the time the embolus will be coming from the left atrial appendage. So went ahead and just occluded this. This was a 4 to 5 hours procedure, single sitting AF ablation plus LA appendage. Rarely done in the country, and that is what we had done a few years ago. Patient is doing very well. So this is LA appendage closure. This is what you see here in the LA appendage. Just another example, 50-year-old gentleman, coronary artery disease, severe LV dysfunction, heart failure. Here patient is in sinus rhythm, QRS is wide, LBBB, went into AF, had acute decompensated heart failure. This is a graph I show every year. Patients who are in heart failure, if they have neither AF nor LBBB, narrow QRS, mortality is around 10% at 1 year. If they have either atrial fibrillation or left bundle branch block, then the mortality goes to 15%. But if they have both atrial fibrillation and left bundle branch block, the mortality is 3 times of these. So this is a very, very severe disease. So AF, LBBB, LV dysfunction, these patients are going to do very badly. So here the patient had coronary artery disease, LV dysfunction. We went ahead and planted CRTD. And I told you at some point of time, we may decide to cardiovert the patient again. So we cardioverted on table. Patient is in sinus rhythm. And this is the narrow QRS, narrower than before. And patient did quite well. So heart failure management, you've heard of the 4 pillars. When the patients get atrial fibrillation, you have to always think of anticoagulation, digitalis, and AF ablation in appropriate cases. Nowadays, we would do, if the disease is still further gone, we are not able to restore sinus rhythm, difficult to control ventricular rate, we would go ahead and do AV node ablation. Previously, we would just put a dual chamber pacemaker. Now we may actually do a CRT or conduction system pacing. So this is a patient where AV node ablation was done, and then conduction system pacing was done at the same time. Patient now post-pacing has a narrow QRS. So always think of ABC, avoid stroke, better symptom control, cardiovascular risk management. Never forget about anticoagulation. Always start it. Nowadays we give DOACs to most patients. I talked about atrial selective drugs a bit yesterday. Early screening. Nowadays the eye watches and people have a lot of variables where AF can be detected very easily, and they are aids in management of patient. Always use them positively. So AF is progressive, relentless disease, but it is modifiable. Early intervention is critical. It may be in the form of weight reduction, diabetes, hypertension control, antiarrhythmic drugs, appropriately timed cardioversion, appropriately timed ablation, and for patients who are too far gone, doing device implantation if required. Rhythm control and risk factor management is so important. Integrated care, drugs, ablation, devices will change the outcome. You can change the graph of relentless progression to stabilization of these patients. So you may be able to give them a better life. That is how you alter the natural history, natural progression of AF with appropriately timed interventions. Thank you. I'll stop here.
Thank you, Dr. Naik. We'll go to Dr. Dhaval Naik to speak on surgical aspects of. No, we'll do Dr. Nakul Sinha at the end. So we'll do Dr. Nakul Sinha at the end after Dr. Dhaval Naik. So they can finalize the slides by then.
Good morning. Slightly unwell and apologize for any inconvenience caused. So we're just going to discuss about the surgical aspects of heart failure, not medical aspect. Medical, I think our team has discussed so many things. So I just want to be very precise, and I hope you'll get the necessary message. Before we start, look at the numbers actually. Now heart failure is one of the leading cause of death worldwide. These are the figures from JAMA in 2017, but the numbers are now more discourages. And another thing is, particularly for the chronic heart failure, the number of hospitalization is directly associated with the increased morbidity and mortality. So we need to discuss heart failure a bit seriously, and being a surgeon, we'll just focus on certain aspects of surgical management. Now, for the sake of understanding, actually, I've divided the heart failure in 3 parts. One is acute heart failure, another is acute on chronic heart failure, and the third one is chronic heart failure. Objectives of treatment is we need to understand the pathology relevant to surgical options. It is very important. You will come across in further slides. We need to review the indications if the patient required what kind of surgical treatment. We need to discuss major surgical procedures with the heart team, and we are fortunate we have one of the best team. And we need to summarize the patient selection and outcomes.
of any pathology. So what surgical options we have? So this is for acute heart failure, surgery for MI. So MI is one of the major reasons of acute heart failure, complications of MI. We have another reasons also, some valvular disease and certain other medical issues which may need, but most common is MI complications. Another thing just we need to highlight on ECMO because it is very important modality to treat certain acute heart failure and acute and chronic heart failure patients, followed by long-term ventricular assist device and heart transplant. Now, I think most of you are aware of MI complications. 4 things could happen after acute myocardial infarction. One is papillary muscle rupture, causing severe mitral regurgitation, which is acute. Post-MI VSD, left ventricular free rupture, bit rare, but still we get patients occasionally. And left ventricular aneurysm and pseudoaneurysm, which could be acute or chronic. Papillary muscle rupture, as you can see the diagram actually, at pinpoint where the papillary muscles is attached at the wall actually, that part is been damaged due to MI, and that causes either partial or complete rupture of the either cord eye or papillary muscle, which causes acute MR, and that causes pulmonary edema, cardiogenic shock following by heart failure. So urgent surgery is indicated in all patients actually. After stabilization, most of the time we put IVP and then we just take that patients for surgery. It is very hard to repair this valve because the acute condition, this tissue is very fragile, so it is a bit difficult to repair. So in most instances, we have to replace this valve. And if the angiography has been done, then it's okay. If it is not been, just we have to check whether the patient needs CABG or not. Another one is post-MI VSD. This is one of the most common post-MI complication. I think most of you have just practiced or witnessed these patients in your day-to-day practice. So it is a sudden left to right shunt, which was not there before, causing acute heart failure and cardiogenic shock. It depends on the size of the VSD. If it is a small VSD, sometimes the patient remains stable, but it's a large VSD. These patients are very unstable, so we need to stabilize with IVP and inotropes. And then the definite treatment is to take for the emergency surgery. Rare causes, as I said, small VSD. Sometimes the patient remain stable, and that can be subject to the surgery after 4 to 6 weeks. But most of the cases we have to take in them. There are different methods of surgical repairs, as you can see in the diagram. There are we put a patch, or sometimes we have to use the double patch technique. It depends on the place of the VSD. As you can see, the septum. It could be apical, it could be mid-septal, it could be a basal. Left free wall rupture, it is very rare, but often catastrophic. Sometimes the presentation is slightly delayed because of the tamponade which is holding the blood, but these patients, they come with acute heart failure, and the definite plan is to just surgery. You can see on the figure, this is just empty heart after going on a heart-lung machine. You can see that blackout wall, that's rupture. So it is slightly tricky actually to repair, depend on the size of the infarct and size of the free wall rupture, but we need to repair that. And the last one is LV aneurysm or pseudoaneurysm. Again, more or less, sometimes if the wall doesn't get fully ruptured, just it causes severe necrosis, echinacea, and ultimately turned out to be aneurysm. The next is, so these are some surgical insights of acute heart failure. There are some other results also there for acute heart failure. It's because of the time limit, we can't discuss everything here. Another thing is mechanical circulatory support. Now the 2 things come. One is a short term, that is ECMO, and the another one is long term, that is called LVAD. Either we can use as a bridge to transplant or as a bridge to destination therapy for recovery. Now, how this mechanical circulatory support works, it increases the flow, it increases the mean arterial pressure, increase the cardiac output, and increase the end organ perfusion. Meanwhile, also it reduces the either left or right ventricular and diastolic pressure and volume, so which decreases the wall tension and mechanical work. Ultimately, it turned out to be increased coronary perfusion, which increased the O2 supply and decreased O2 demand. So the myocardial recovery just been started. If you add oxygenator, so then it will become ECMO, so we can use as a heart and lungs both support. ECMO, I think most of you are familiar with the ECMO. There are two types, VV and VV. VV is only mainly for respiratory. VA is for either heart and both, heart or lung. And in VA ECMO, it is either we just put as a peripheral using femoral or neck vessels, or central, sometimes after heart transplant or major heart surgery, that is central to aorta and right atrium. Now this is bit good slide actually for ECMO indication. Now this is showing as a acute certain cardiogenic conditions where the outcomes are good after ECMO actually. So fulminant myocarditis, ventricular arrhythmias, acute cardiomyopathy after postpartum, Takotsubo syndrome, chemotherapy, drug overdose, certain poisons like sulfa, and pulmonary embolus trauma. So there ECMO is very much indicated because the outcomes are very good. Intermediate outcome, survival to discharge, maybe more than 30% is post-cardiotomy, post-heart surgery. When the etiology is not known, post-MI, because most of the wall is gone actually, and return of spontaneous circulation following in-hospital cardiac arrest. So whenever we patient have some cardiogenic shock which arrest, and when we put, so patient has been witnessed return of circulation. While the worst outcome is ROSC following out-hospital cardiac arrest, congenital heart disease, they don't do well, and severe sepsis. So that is how we identify the indication, and we just explain the prognosis to the patient relative. LVAD, I think also it is very common terminology. Still, we were the first one to perform actually a few years before. So it is a basically small machine which sits in the left ventricle or right ventricle or both ventricle, and it's a small magnetically levitated motor. So there is no connection of any part of the machine with the blood, and the blood capacity, up to 8 liters of the blood flow can directly go to the aorta, and this machine is been connected outside with the battery and some console. That's how we manage LVAD. Unfortunately, in India, because of certain financial things, it is not becoming that much popular modality, and some bit another reason also. But still, I think USA approval must be knowing. They use left and right. So when we use LVAD actually, so LVAD is as a bridge to transplant. So again, if patient is having acute on chronic heart failure, and that patient, come in the ICU, the patient is already established case of chronic heart failure, and then that deteriorated. Then we can use this machine or LVAD or ECMO as a bridge to transplant, because to get a heart is very natural thing. We don't know actually, it is a 1 day or 1 week or 1 month. Then we can stabilize this patient with the use of LVAD or ECMO. And then once we get a heart, we can. And also nowadays, as a bridge to recovery, as a destination therapy also, LVAD is much more common, because some patients, the heart transplant is not possible at all because of certain reasons. LVAD survival is quite impressive. Nowadays, the results are more like a heart transplant actually. 1 year survival is almost 80 to 85, while 5 year survival is 60 approximately %. These numbers are a bit increasing with the more centers actually getting expertise to manage these machines. Heart transplantation, we have talked a lot actually. And
5 minutes remaining.
So it is a gold standard for chronic stable heart failure patients. The careful selection criteria is very important. Donor availability is very crucial. As I told you in the second slide, the chronic heart failure patient, they keep coming to you actually. So more and more hospital admissions for heart failure reduces the survival chances. So criteria is very important. They require lifelong immunosuppression. They have to fight with infection. So, but the results are better than just managing conservatively. So it is a process. We have a full-fledged heart failure clinic, including our cardiology colleagues, surgeons, anesthesia, and rest of the team. We have a very stringent evaluation protocol, patient guide. We have a home milrinone therapy. That is one of the parallel therapy we use so many times before heart transplant, post-operative care. Must be aware of our transplant unit. So this is very important actually, the referral. When to refer these patients for the chronic heart failure. Early referral actually we don't need. As being a senior experienced physician, cardiologist, we can always these patients medically manage or sometimes with the devices NYHF 1, 2, troldentine, good medicines, there is no hospitalization. So these patients are still stable. There is no meaning actually to refer this patient for heart transplant. But then there is no meaning to refer it too late also. Once the patient is developing multiple organ failure, patient is having severe malnutrition, severe cachexia because of the frequent hospitalization. So the golden period we need to identify. So NYHA class 3, 4 symptoms, persistence of symptoms even after optimizing the medical therapy, frequent hospitalization. I said now in USA, I believe even the one hospitalization, now they refer the patients for transplant evaluation. Arrhythmias, even after the ICD shocks and worsening renal or hepatic function. So we need to identify this golden video. When you refer this patient for heart transplant, you know they do very well. The results are excellent. So 1 year survival is almost now 90–92% after heart transplant. 10-year survival is almost 60%. Our first, second heart transplant, they're just finishing 9 years. They're doing very well. In fact, our 3 patients, they're just completed almost 7–8 years. So that's the magic of heart transplant, but it is only possible, feasible when you refer this patient at appropriate time. So summary, appropriate, so acute heart failure, acute and chronic or chronic heart failure, just I'm discussing only surgical management, but we need to combine everything, you know, medical management, devices, like Ajay Bhai and Hiren Bhai, they're doing, and then surgical aspect. So it is a more comprehensive, more hard team work, and we just scrutinize this all patients that way, appropriate way. So whenever it matters for the surgery, just we involve. So multiple surgical options exist based on the pathology as we discussed for acute heart failure and chronic heart failure. Elevated transplants, they are best. If you don't do anything for the chronic heart failure patient, the survival is maybe 1 year is 24 and 2 years is only 8–10%. If you do, that survival can reach up to the 90%. So heart transplant, LVADs are best, proven, and multidisciplinary heart failure team is essential what we have at SIMS Hospital. Thank you.
Hello. Thank you, Dr. Dhaval Nayak. Now we'll have Dr. Nakul Sinha, who will talk on optimizing worsening of heart patient care, exploring evidence with Verisagod. And we feel sorry for inconvenience caused to you.
Can we open the correct presentation? Right. Okay. So I believe these 2 trials have been referred to by Dr. Urmil Shah, but I have slightly put in some more data to try and see what is the correct placing of these type of medications in today's management of worsening heart failure. We all know established facts about heart failure treatment. One being that you need to put the patient on all the 4 established, well-documented pillars of medical therapy: beta blockers, MRAs, ARNI, and SGLT2. No dispute about that. And moreover, they need to be done as quickly as possible. If you can do it within 4 weeks, you are giving the best chance to the patient. The next thing is that you perhaps should choose the correct sequencing of putting these therapy. If the patient has a low blood pressure, then avoid ARNI initially. You can start with low-dose beta blocker and SGLT2. If the patient has a normal blood pressure, ARNI may slightly precede the MRA. So all these are known facts. What we need to realize that the temporal trends over the years of heart failure mortality are showing that home deaths are increasing while
the hospital deaths have slightly come down. You can see on the right-hand panel. Possibly because once the patients get admitted, they are given appropriate, quick treatment and they recover. But then the heart failure doesn't go away. It keeps on coming back and back. Moreover, whatever be the stage of heart failure, the patient is high risk. On the left-hand bar, you can see the atherosclerotic disease. The chances of major adverse cardiac events will be around maximum 10% per year. Here, even if the patient is a stable outpatient heart failure, they are high risk, more than 10 to 12%. And as the thing progresses, the worsening heart failure appears, the risk is very high. In fact, following an event which necessitates admission or an increase in the treatment, 25 to 40% is the accepted mortality rate depending on the comorbidities, which is very, very high. So we can't really relax our treatment or even think of downgrading it at any point of time. So in this trajectory, which all of us are quite aware, this worsening heart failure was sort of recognized, denoted, and acted upon because there was a need for it. You just don't go from a stable heart failure. Of course, sudden deaths are there. They are not uncommon. But then there is a gradual trajectory. So what we need to realize, what is worsening heart failure? What are we talking about? Patients don't come with this thing written on their forehead that I am going into worsening heart failure. Firstly, no first episode of heart failure can be designated as a worsening heart failure. It has to be a chronic heart failure. Deterioration of signs and symptoms despite stable background therapy. Now, that background therapy may not be the optimal therapy, but at least some therapy has been there. And patients are requiring escalation of therapy. That is where the red light needs to be flashing. Beyond our expectations, the prevalence of worsening heart failure in registries has been found to be very high, although we usually think these patients are stable. There is a ESC consensus statement which is telling the same thing, and which is again stressing that new onset or heart failure episodes due to a recognizable precipitating cause are not to be labeled as worsening heart failure. So we know about the Victoria trial, that's some years down the line. And this Victor was presented last year in ESC. Now, what was the difference? So, I mean, this was also from the same group of patients, but at a stage where they had become stable. So if we see how was Victor population different from the Victoria, the similarities were that yes, patients, all of them were receiving some therapy, previous worsening had occurred, but in Victor, the stable patient, at least for more than 4 to 6 weeks or even for 1 year, where they had not had a heart failure hospitalization. So this was targeting at a stage in heart failure where the patient had been stable for quite a long time, but still has the potential to worsen and have a mortality. So Victor was a better, well-treated population indicative of the patients that we are seeing in the OPD day in and day out. And as you can see here, around half of those patients had either had no heart failure hospitalization or had remained stable for at least 1 year. Results, definitely not so impressive perhaps as were expected. There was a difference, there was a trend. The time to first heart failure hospitalization, time to CV death. Now this was nearly a 20 to 24 months follow-up. The time to all-cause mortality came out to be significant, but the time to CV mortality was just approaching significance. However, on additional analysis, there was a relative risk reduction of around 25% in time to sudden death and heart failure-related death, respectively. So, if we combine both the data, Victor and Victoria, what do we get? Yes, there is a reduction in the primary composite endpoint of heart failure, hospitalization, and CV death. Component-wise, yes, there was a difference from placebo, and in summary, it could be said that the use of Verisugat at the proper time and place with the build-up of the dosages as recommended reduce the composite endpoint versus placebo in patients across the spectrum of risk. Even those stable patients were showing a benefit. Well tolerated and a good safety profile. Now, I think these are plus points going in favor of this medication. Now, this is just a slide which is showing the build-up of therapies in heart failure. At the top, you see the quintuple therapies, the 5 pillars. They have an incremental benefit. The issue is that most of these patients were already on a good background therapy. So, for example, if in the Indian cricket team you already have Dhoni, Rohit Sharma, and Virat Kohli, you need to be a real super person to show an additional effect. So, there was always a good background recommended therapy, but still this drug
5 minutes
showed
remaining.
some benefit. And taken in different ways is showing that when used properly, it may really benefit the patients. It is well tolerated. There is no significant drop of blood pressure unless there are other things like dehydration or something. And the clinical benefit is independent of the fact whether you are taking all the background therapy or not, or you are on half therapy or something. Can be initiated with minimal monitoring requirements and does not require hospitalization to be initiated. Even you can go straight to the 5 milligram dose. Nearly half of the patients tolerated it very well as the first initial dose. When would you like to use it? When all the background therapy is complete, but the patient is still having some problem. Yes, that is scenario number 1. Number 2, when some portion of the therapy like ARNI cannot be given because of very low blood pressure or hyperkalemia or a very low GFR. So if the GFR is more than 15, you can use Verisugat. And the third scenario is where the background therapy also needs to be adjusted alongside, and you can start Verisugat. Careful timing and dosage of the initiation improves patient's outcome by significant degree. And you can see these 3-4 situations. Following a decompensation event, as soon as the patient is off IV diuretics, the GFR is okay, the blood pressure is 100 or more, that's the time to try out this drug and see whether the patient benefits or not. So the current totality of evidence is showing an incremental benefit in reducing the recognized endpoints which indicate a poor prognosis and a heart failure mortality which is going to approach. On top of that, it is safe and well tolerable. So therefore, there are ways to understand when to initiate or sort of insert this medication into the prescription. And that's not too difficult to follow. Along with the
2
dose
minutes
escalation
remaining.
of the oral therapies, you can include vericiguat. So after all this, after all the editorials and debates, what would you place it? I would place it as an evolution in therapy, not a revolution. It cannot be called a revolution. But yes, things are evolving, things are becoming more clear, and it has a certain place. It is a pragmatic, safe add-on for the selected high-risk patients. Do not expect very low-risk or initial patients who are not yet diagnosed as heart failure to have any benefit. Selected high-risk patients or those intolerant to other therapies. That is where I believe, and I use very commonly in patients who cannot tolerate ARNI or MRAs for different reasons. So it has the potential to reshape the standard of care. We need to see further, study the evidence, and understand it better. Thank you very much.
Now we take two questions to Dr. Apurva. Patient of 68 years old has undergone aortic valve replacement before 14 years, who has a bicuspid aortic valve stenosis. Now he has developed pressure gradient of 45, but is still asymptomatic. What would you suggest? We should wait or undergo TAVR or a surgical replacement?
So, when somebody says asymptomatic aortic valve stenosis, like, whether it's a misnomer or whether it's a really asymptomatic, like you put them on the treadmill, they will prove themselves. Like, there is technically, like if that person is not doing any form of activity or very minimal activity, then they are asymptomatic. So it's very rare to find a real asymptomatic aortic stenosis, especially with bioprosthetic valve dysfunction. What is their EF? If their EF is on the lower side, then it does not matter what the level of symptoms are at this point of time. Their BNP or NT-proBNP could be checked. If they are elevated, then those guys are symptomatic. You're having markers for dysfunction. And the last thing, let's say everything is negative, you put them on the treadmill, they go over 4 mets, they will really show their true colors, whether they're symptomatic or not.
My question is to Dr. Sinha, sir. Sir, heart failure patients, usually we see that their blood pressure remains little low. So we should see the reading of systolic, diastolic while adding each end, beta blocker to SGL2, MRA, ARNI. And if patient is asymptomatic, then we should add further, or we should see the reading. Okay, it should not be systolic, blood pressure should not go below, in spite of patient is well tolerated with 90 systolic, 50 diastolic.
Very good question and a very common situation. See, first of all, whenever you are adding some new medication, there may be hemodynamic changes, and you need to give a week or so for the patient to settle down. If you try to see the acute changes in blood pressure, that may not be so well guiding your therapy later on. So if you are adding ARNI and seeing the blood pressure has fallen down, give it some time, it may come back. See whether the patient is not dehydrated, malnourished, etc. If the blood pressure is still remaining around 90 or 100, then see whether the patient is getting symptomatic or not. There are many patients who are just going around with a systolic blood pressure of 90, and they can do all their activities to a reasonable level. So then also you can initiate the Varixogat if you want, because these patients are already at a very high risk. A systolic blood pressure below 100 in any heart failure patient is a very high risk indicator. So that is how I would say you can try, but go slow and keep a watch.
Thank you, sir.
Question for you, sir. As we seen, right patient, right time, and right therapy for aortic valve replacement. So my question is that post-procedure, at what time or what period of interval we can ask the patient to come for follow-up, or what advice we can give, or as a physician, what we can do for follow-up?
So let's say the patient gets aortic valve replacement of any nature, surgical or transcatheter. Like normally the protocol should be like the surgical team or the procedural team should see the patient in a week or two just to make sure that there is no immediate post-procedure complication. When you're seeing them from the physician perspective in the office, you have to make sure that the scar through which the surgery was done, be it the groin or the chest, they are healing well. There is no infection, there is no open wound. Pain control becomes important from that perspective. Electrical disturbances like getting an ECG, make sure there is no level of block, etc. Like normally at the end of 1 month, these things tend to stabilize themselves. You will not see any delayed things, but never say never. And when it comes to long-term follow-up, most important thing is if they're going for any other procedures, dental cleaning, endoscopies, then endocarditis prophylaxis becomes very important. So that needs to be ingrained in their mind. And I would say echocardiogram at 1 month, just to see what their baseline gradients are from the valve, and an echocardiogram on a yearly basis, just to make sure that how the gradients are moving along, how the EF is happening and moving forward. So when the valve fails, you want to catch it at an earlier time rather than not see where LV dysfunction has already occurred and at that stage.
In fact,
just to add to this,
fibrillation.
Just to add to this.
Yeah.
Sorry. Just to add to this valvular cases, for all physicians, I think so. One central message should be there. Any patient who has undergone any valve replacement, see to that and ingrain in their mind that if they have any fever, any infection in your body, they are supposed to meet you immediately. Because if the infection goes into blood, then infective endocarditis is a high likely. So whether it is urinary tract infection, tooth infection, any fever, they should see you. So repeatedly tell them that this is important.
Everyone, we're going to close this session.
I was just making a point that for atrial fibrillation, I think it's now a part of the lifestyle disease. It's not just electrophysiology. And I think all my electrophysiology friends will agree to that. And in fact, now with the sort of this adipokine hypothesis coming up, which has really shown that the visceral fat, the neuroendocrine feedback, so that also affects this atrial fibrillation besides obesity, diabetes, hypertension, and whatnot. So I think everything is going to come within that large circuit. Thank you.
Thank you, sir, for your comment. I would like to invite the next group of panelists, chairpersons Dr. Ajay Kotalia, Professor Derek Conley, Dr. Dhiren Patel, Dr. Kamlesh Upadhyay, Dr. Parth Parikh, Dr. Rajiv Singhal, Dr. Sunil Mehta, Dr. Tanish Modi. Moderators, Dr. Anil Jain, Dr. Ami Parikh, Dr. Bipin Shah, Dr. Haresh Udani, Dr. Sunil Maniar, and panelists, Dr. Karthik Patel, Dr. Parul Bhatt, and Dr. Vipul Kapoor. And I would also like to invite Dr. Keyur Parikh, Dr. Anish Chandarana, and Dr. Tejas Patel as the core program directors on the podium as well. Thank you very much.
So ladies and gentlemen, by the time speakers, chairpersons, moderators are coming, let's have an exercise. हम कब से बैठे हैं? जरा those all who can stand up at their place, let us stand up. Stretch yourselves, have a laughing sound. Ha 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 ha. Wow. Stretch yourself, be happy, enjoy the time, enjoy the learning. Life is nothing but fitness and happiness. So maybe with the due permission and consent of the chairperson and moderators, I can start. So before I start, let me just show of hand, how many of you have ever sent one patient for CT coronary calcium score? Oh, very good. So many physicians have been using this wonderful tool, and I'm very sure you will be using it optimally. But what is most important I'm going to talk to you is how to take the inference, what is score has come and how to deal with the score. So no conflict of interest. And again, before we go further, I would like to have your vote. Read very carefully, I'll give you full time. So CT coronary calcium testing, which statement is true? Out of these 5, only one is true. Number 1, it is to be prescribed to patients with angina as a primary screening test. Anybody of angina comes to you, you will send as a primary. Number 2, when you treat with statin plus aspirin, CT coronary calcium score reduces in future. Number 3, when CT coronary calcium score is very high, more than 600 units, coronary angiography should be done to assess the major blocks. Number 4, all above statements are true. And number 5, all above statements are wrong. Read carefully, your time starts now. Can I have the seconds, time meter? So, a huge job I have to do, huge job. So D is the wrongest statement, where 60% people have answered. So let me again come back to you. Number 1, it's not a primary tool for angina. When patient has angina, you have to send them for stress test. It's a tool for asymptomatic people for the risk stratification. Number 2, whatever treatment you give, once the calcium has gone inside your coronary arteries, you are not going to reduce it, whatever you do. Maybe heart transplant is the only way. Number 3, whatever CT calcium score does not necessitate need of angiography. Unfortunately, in today's world in Ahmedabad, hundreds of angiographies are done very wrongly just based on CT calcium score in asymptomatic people. If a person is asymptomatic, whatever score doesn't need angiography, yes, you can send the patient for stress test. If stress test is positive, you may send. Stress test is negative, you may not. So let me explain all this. So see, this slide was shown by Professor Nakul Sinha. What is most important in cardiovascular science is risk stratification, so that not only you can explain the patient, but at the same time, you can treat patient accordingly. So let me have a pointer. So if you look here, the previous session, the previous talk, heart failure patients are at a very high risk. They have a yearly risk of heart failure admission or death more than 10%. So a patient who has got heart failure, there is no role of getting CT coronary calcium done. CT coronary calcium score is done in asymptomatic people for primary prevention, those who never had any kind of event. Somebody who had myocardial infarction, somebody who had unstable angina, somebody who has undergone angioplasty bypass, it's done. His future risk is very, very, very high. You are doing CT coronary calcium for people who have seemingly low to intermediate or high risk, who do not have any manifestation of disease. The moment disease has manifested itself in terms of events or intervention or heart failure, patient has already progressed much ahead in the path of risk. So where do you suggest? It's for primary prevention, where patient might not have any risk factors or where patient might have 1, 2, or 3 risk factors. The moment patient is here, multiple risk factors, his risk goes high. So number 1, you will prescribe CT coronary calcium score only a person where disease has not manifested. It's a very simple procedure, very small dose of radiation, outdoor-based procedure, takes 10 to 15 minutes, and ECG gating we do so that in diastole we capture the frame. Even all those CT scans which are done by pulmonologists and by physicians for the chest purpose, please write a statement to your radiologist, please justify, is there calcium in coronary arteries? Those routine machines cannot give you score, but they can give you the information that there is calcium in the coronary arteries, and that's enough, because when you send a patient for routine CT scan, you are getting that additional information. But when you send a patient for specific CT coronary calcium score, they give you a score in Augustin unit. What does it detect? It detects presence of atherosclerosis, location of atherosclerosis, and extent of atherosclerosis. But it will pick up only that part of atherosclerosis which has calcification inside. So calcium coronary score is highly specific feature of atherosclerosis. It's not simply the result of aging. Yes, with the increase in age, the score will go high. If you are 40 years, your chance of having score more than 0 is very less. If you are 80 years, you will have at least some score. So with aging, as the atherosclerosis and calcification goes up, it goes up, but not because of aging that you have to have high score. There are people who are 70 years and can have a score 0, 1, 2, or 3. But as you get aged, certain ethnicities like Indians, certain diseases like diabetes and CKD, they increase the calcium score. Now, what is the importance of CT coronary calcium score? It's not a risk factor. It's a disease itself. When you have got diabetes, when you have got blood pressure, when you are having habit of tobacco smoking, they all are risk factors, and risk factors may or may not cause atherosclerosis and events. While CT coronary calcium score, presence of calcium there is not a risk factor, is a disease itself. And it gives you a sum total effect of all the risk factors. Known and unknown risk factors, measurable and non-measurable risk factors, innate or acquired, all the risk factors together. Ultimately, your purpose when you want to understand the risk factor is whether all these risk factors have produced disease there inside or not. Now, there are so many risk factors which you don't measure. There are so many risk factors which you don't know, or as a science we don't know. But there are people who are 45 years of age and they do not have any classical traditional risk factors, but still calcium score can be 50. So they are the people who have some other kind of risk factors which are not measured, not known. So that's why CT coronary calcium score is sort of end path to understand whether a patient has a disease or not. So what the higher score means, higher the score, higher the disease and atherosclerosis. Higher the score, higher the future risk of heart attack, stroke, and cardiovascular death. And it adds over and above the risk factors. This was a data previously done, very well done, MESA, a study of 6,000 plus people. They were aging 45 to 85 years, and what was found is if your calcium score is 0, your 5-year risk of CV event is close to 0. Close to, not 0, close to 0. And as the calcium score goes up, your future risk of coronary event goes up. It adds to the risk factors. What do I want to convey? Say, for example, there is a gentleman of 45 years who have 0 risk factors. You send him for calcium score. If his calcium score comes more than 100, his future risk is high. On the other side, there are people who have got multiple risk factors, but if their calcium score is 0, less likely, but if it is 0, their risk is less. So it adds over and above clinical risk factors, and that's why you have to get it done. There are 2 very important caveats, and mind that well. If you have to understand these 2 most important points, number 1, soft non-calcified plaques are not picked up in CT coronary calcium scoring. So there can be a young boy who comes to you at the age of 30 who wants to assess his future risk. He's living life the way he wants to live. You send him for calcium score is 0, you give him a false sense of security. No. At that age, it is very less likely that a person will have calcium in coronary. So you should not give them false sense of security. Something called as power of 0. When calcium score is 0, your future is reasonably safeguarded as far as heart attack, stroke is concerned, but it doesn't work if somebody has got familial hyperlipidemia, if there is family history of premature atherosclerosis and CAD, if your lipoprotein is high, or if you are a smoker. So mind well before. See, this is one example. Young man, 35 years, calcium score 0 before 1 month, went ahead and had acute inflammatory, hardly he was saved. So 0 doesn't give you guarantee, especially when you've got certain other risk factors. And second point, which why I'm quoting so heavily is because it is getting misused. Any score, however high, does not suggest degree of luminal narrowing. I might have a calcium score of 2,000 and I might not have any significant block which produces ischemia. I might have a calcium score of 100 and I might have a significant block. Obviously, as the calcium score increases, your chances of having significant block goes up, but there is no mathematics that if you have a certain calcium score, there is certain degree of narrowing. it doesn't give you any idea about inducibility of ischemia, and that's why any calcium score doesn't give you a suggestion to go for angiography. That's a very wrong practice. Say, for example, this is a gentleman who had a calcium score of 1,000, angiographically, no luminal narrowing, no ischemia, stress test was normal. I have hundreds of patients whose calcium score is more than 600. They are living happily on medical management without angiogram. So who should undergo CT calcium score in Indian context? Asymptomatic people, mind well. Symptomatic people, you have to do adopt other pathway. In Europe and America, it is done for the people more than 40 years who are intermediate risk zone. People who have got low risk, manage them for the risk factors. People who have got high risk, anyway, are going to give high intensity lipid lowering therapy. So what in India, we do not have risk calculators, unfortunately. And I'm very sure we'll not have proper risk calculators. So anybody and everybody in India who is more than 40 years, at least men, I would love to put for CT calcium score. Anybody and everybody more than 40 years, asymptomatic. Female, you can have a cutoff of 45 to 48 unless there are certain histories. But somebody who has got multiple risk factors, somebody who has got family history of premature disease, diabetes, smoker, I would love to send them for calcium score at a little younger age, 35. But in these people, when I send them for calcium score, I tell radiologists that if you find 0 calcium score, but I have a doubt he has got severe premature family history, smoking, lipoprotein, do angiography and put dye also, because that's where you can pick up soft plaque. So anybody and everybody, man more than 40, anybody and everybody, female more than 45 in India, I would love. It's a debatable statement, but I'm very sure we have to save country. So when you take CT calcium score 0, when do you repeat? At roughly 5 years. A 0 score or maybe very low score of 10 should be repeated at 5 years, not before that. And once you have achieved a score of more than 300, there is no need to repeat. Because then whether it is 300, 600 or 1000, your preventive efforts are going to be same. So there is no role of putting the patient for test. Now mind well, whatever you do, whether you give statin, inclisiran, aspirin, clopidogrel or ticagrelol, calcium score does not reduce. So once somebody has got a calcium score of 300, please do not send him after treating that, let's see what has happened. No, there is no role of doing that. So how do you take calcium score further so that you reduce the risk of patient? Number one, you can intensify the lipid lowering treatment. Those who have got calcium score of 0, I don't say they are at 0 risk, so treat the risk factors whatever they have. If I have got blood pressure, I need to treat blood pressure. If I have got diabetes, I need to treat diabetes. If my LDL is 130, I need to take statin. But per se, calcium score 0 gives me a reasonable safety benchmark, but doesn't mean that I should not take statin if my lipids are high. I have to. But when calcium score is between 1 to 100, you have to give intensity of treatment of lipid where you achieve LDL of 70. Once the score is between 100 to 300, you have to achieve LDL of 50. And once the score is 300, you are even as low as 30. So calcium score 0, treat the risk factors, follow the guidelines. Calcium score 1 to 100, LDL is 70 target. 100 to 300, LDL target is 50, and more than 300, LDL target is 30. Number 2, how do you take calcium score? We all know that aspirin has fallen out of favor as far as primary prevention is concerned. But calcium score can help you. I won't go into the details because we know that aspirin causes bleeding. So you have to pick up all those patients who have got low bleeding risk. Their hemoglobin, platelet count, etc. is okay. There is no past history of bleeding. So if you are giving aspirin for primary prevention, when a person has got calcium score of more than 100, that's where benefit will be more than the harm. So if there is a patient who is for primary prevention asymptomatic, you want to give him aspirin, small dose. First, check that he is not high bleeding risk, and second, send him for calcium score. If his calcium score is more than 100, a small dose of aspirin for primary prevention helps. And third point, we all know that aggressive treatment of blood pressure helps. But then you cannot give treatment to a BP target of less than 120/70 to everyone who comes to your chamber. You have to take a target of 120/70 to the people who have got high risk. So how to define high risk? You can clinically check.
2
and
minutes
again,
remaining.
calcium score comes to your help. If your calcium score is more than 100, you treat that patient to the strictest BP target. Take his or her blood pressure, try to take it to less than 120/70 because that's where benefit is huge. So coming to sort of 2 conclusive slide, CT coronary calcium score and how would you take that score for the treatment. If score is 0, treat the risk factors. Don't give a false sense of security to your patient, just treat the risk factors. Once the score is between 1 to 100, even one score means your risk has gone up. So don't think that 1 is too low. 1 to 100, you have to achieve LDL 70 by statin. 100 to 300, you have to further intensify the dose to have LDL of 50. And once it is 300, LDL has to touch 50 or less or even 30. What about aspirin? Once your score has crossed to more than 100, even for primary prevention, you can give statin and you should give. BP target has to become more aggressive once the score has gone more than 100. And once the score is 300, you start using these newer, costlier, and riskier molecules. See, there is a question, whom to use colchicine, because it's a high-risk medicine with less proof. But if you have a patient for chronic coronary syndrome who has got multiple diffuse disease and blocks and whose calcium score is 500, you can think of GLP-1 RA. People say that they are costly drugs. They are costly drugs. But where you will get maximum benefit? Those people whose calcium score is 300, 400, or 500. So these are the patients whose calcium score is very high. That's where you can dare to use little riskier molecules or costlier molecules. So ladies and gentlemen, coming to conclusion, carry home message, it's a very handy tool for risk prediction in asymptomatic people. It's very specific for coronary atherosclerosis. It is not just function of age, higher the score, higher the risk. No calcium score needs and necessitates the angiography. Angiography is to be done based on symptoms and positivity of stress test. There is something called as power of zero, but be careful about everything. So decide the intensity of lipid-lowering treatment, use of aspirin, and use of costlier drugs based on calcium score. Thank you very much.
I think very insight information regarding CT calcium score by Dr. Anish Chandarana. Thank you very much. And now over to next speaker, Dr. Parth Parikh, Seeing the Unseen, Coronary Imaging in the Era of Precision Cardiology. Over to you.
Good afternoon, everyone. Thank you so much for having me here to give this talk. We just had a great talk by Dr. Anish Chandarana on how we assess coronary artery disease with non-invasive testing. I'm going to now talk about assessing coronary artery disease invasively. I'll be talking about seeing the unseen, coronary imaging in the era of precision cardiology. These are my disclosures. From an overview perspective, we're going to talk about the role of intravascular imaging, the different invasive imaging modalities which are there for coronary artery disease, IVUS versus OCT, case-based applications to show the utility of IVUS and OCT. So by a show of hands, how many people follow cricket and at least some of the new rules in cricket? By a show of hands, can you raise your hands? So I think most of them. So there's a decision review system that was introduced somewhere around 2011. Can we have the timer for the audience response, please? How many of you feel that this has improved decision-making in cricket? Yes or no? I don't. 100%, okay. So I think most of my talk is done then I just have to convince you that if we feel that technology is advantageous in a sport like cricket, then why can we not use it when it comes to life, when it comes to coronary artery disease, and when it comes to saving patients and improving patient outcome? So precision and accuracy. There's no point about talking about precision when you cannot see what you're talking about, which is again what I'm trying to prove a point that we want to talk about precision and accuracy by seeing stuff that we cannot see otherwise routinely. So Dave Richardson, who is an ICC chief, prior ICC chief in 2016, had made a statement, if we can achieve 98% accuracy with DRS, it is better than the 93% accuracy that we have with umpires who've been doing this for years now. You may not have a lifeboat, but if you have a life vest, it is better than having no vest at all. So again, just as an example, we have a captain. I don't know if these are validated numbers or anything, but this is something I found, that 432 times he has taken reviews in his career. 98% of those reviews have been successful. So again, to the point that in sport like cricket, if we have technology that we're using to improve accuracy and precision, then why can we not do that in the field of cardiology? And just to put that into perspective, in India currently, intravascular imaging is done in less than 10% of the PCIs that happen in the country. Putting that into perspective, there are more than 100,000 1,000 stents or 1 lakh stents that go in, if only 10% of those stents are done under intravascular imaging, that to me is a big disservice that is being done to the patients. Now going over the guidelines. So we heard about this in the morning as well. The 2025 guidelines were most recently updated in patients who presented with ACS or acute coronary syndrome, where it is now a class 1A indication that in patients who have ACS and undergo coronary stent implantation in left main or any complex intervention, intravascular imaging, either IVUS or OCT, is absolutely, absolutely recommended and must. Then we also have class 2A indications where it is recommended that patients having any kind of intervention should be getting imaging done, especially in the cases of left main complex coronary artery disease. It does not quite matter which kind of imaging test that we're doing, but it should be done. The role of intravascular imaging is multifold. It's not just one or two things. You use it for pre-intervention, you use it for PCI guidance. There are at least 15 different applications where you are going to use intravascular imaging for. In terms of data, so there is also a lot of data that has been here not just recently. This is not data that has come up in the last 2, 3, 5 years, but this is data that has been there for more than 15, 20 years showing the benefit of intravascular imaging improving the outcomes. So just based on angiography guidance, compared to IVUS guidance, you see that there is a significant decrease in the role of target vessel failure at 3 years, 10% versus 6%. So again, going back to the thing that a cardiologist may say, oh, I can see stuff with an angio. I've been doing this for 15, 20, 30 years of my career. Why do I need additional modalities? This is the reason that additional modalities are needed, because we are trying to strive for more precision and more accuracy. We just don't want to give an okay result. We want to give a perfect result to the patient. Again, I'm not going to go in detail in terms of the trials which are there. Multiple trials over years which have shown benefit of intravascular imaging. Two basic techniques that are there. One is IVUS and one is OCT. The main difference to know is from a technical standpoint that you do need to give contrast in OCT. So in patients who have renal dysfunction, IVUS is something that is going to be used much more compared to OCT. These are just showing some different images that the amount of information that you can get with IVUS, the IVUS is on the top screen and this is the OCT, that you can go into absolute micromillimeter data where you can look at the intima, media, adventitia, and differentiate what exactly is going on with the vessel. You can look at the stents, you can look at how many layers of stents are there, you can look at malapposition of stent, where over here there are struts that are not opposing against the wall. You can look at calcium to make sure that you're modifying the lesion properly, and then you can also look at complications like dissections with intravascular imaging. Now, just going over some case applications. So there's a 68-year-old female who's presenting with ACS with an NSTEMI. She has past medical history of hypertension, hyperlipidemia, end-stage renal disease on dialysis, has respiratory failure in the setting of COVID. This is the coronary angiogram. There is severe distal left main disease, going into the ostial LAD as well. The darkness that you see before the contrast goes in is all calcification. Now, can you do a stent in this procedure without imaging? Absolutely. Any one of the interventionalists is going to say, I can definitely do this without imaging. Are you going to get a 100% result? Probably not, because you need to see what exactly is going on. So going to the question that is intravascular imaging necessary? Yes, it will help with additional information. No, I can see everything on the angiogram and I know how to treat the lesion. Okay, so 95% agree that we do need additional information. And again, going back to the same thing about DRS, that if we are using this in cricket, there's no reason we should not be using it when it comes to the life of a patient. So this is an IVUS image which shows, I'm just going to run it slowly. So all this white is calcium. What you cannot see beyond this is very dense calcification. Now, you can definitely put in a stent. you would have not appreciated how much calcification is there, not modified this, put in a stent, and this patient's probably going to come back in less than 1 year with restenosis. This is severe concentric calcification, more than 180 degrees. You can not see anything beyond this, which is all suggestive of dense calcification. Because we were able to see it with intravascular imaging, we were able to do additional modifications and also see a complication from this, which this lumen that you see at the 6 o'clock position is a dissection that has happened after appropriate lesion preparation. So this is a calcium nodule that after shockwave therapy and after cutting balloon angioplasty, you see the calcium moving. This is very important to make sure that the stent expands and does not lead to recurrent restenosis. And this is the final result that we can get after using intravascular imaging. A second case, 80-year-old male with past medical history of coronary artery disease, has a history of CABG done in the past, multiple layers of stents in the RCA with multiple PCIs done, none of which were done with intravascular imaging, hypertension, hyperlipidemia, comes in with escalating anginal symptoms. This is the coronary angiogram of the RCA. And you can see here that this area involves 2 layers of stents, and then there's restenosis. Can you do this without intravascular imaging? Yes. What would have been the next step? Just do a balloon dilation, try and put in a drug-eluting balloon since there are 2 layers of stents. We ended up doing OCT to better understand that this patient's coming in with multiple stent failures. Easy option is to just blame the patient, saying that you're not taking care of your diet, you're not taking medicines, that is why this is coming back. But the reason is not that. The reason, as I'll show here, so this is a stent. If you see here in the horizontal view, you can see the stent is very underexpanded. There's calcium all around the stent. So the reason that the patient's coming back with ISR is that the lesion was never prepared properly, as we showed in the first case, that you need to modify the calcium to make sure that the stent expands properly. So this patient underwent, again, shockwave and cutting balloon angioplasty. We did repeat OCT to make sure that we have modified the calcium, and then did a drug-eluting balloon
5
placement.
minutes remaining.
This patient has been out of the hospital for the last 2 years now, or 3 years, without any reintervention. And again, I'm just letting the OCT run. This is compared to before. So on the left, you can see how it looked before the intervention, that it's all stent under expansion because of incomplete lesion preparation, after which we did additional modifications to open up the stent much better. Case 3, 68-year-old, presenting with, again, ACS, has history of CABG, type 2 diabetes, CKD stage 3, creatinine of 1.8 to 2, comes in with, again, an ACS presentation, and during the hospitalization has an AKI with creatinine up to 3.5. He's having escalating anginal symptoms. He had a coronary angiogram done at the outside facility. So we have one of this picture which shows that, again, there is ISR in the proximal stent. There's a de novo lesion here at the distal stent edge, and then there's another lesion all the way distal. He's not a repeat CABG candidate, so the plan was to do a PCI. However, he has an AKI with a creatinine of 3.5. He's having severe symptoms right now. Either we give a lot of contrast and end up with the patient ending up on dialysis, versus try and use intravascular imaging and do this completely with zero contrast just based on fluoro and using intracoronary vascular imaging with an IVUS. So this, again, I don't have any before and after pictures because we did this procedure with absolutely zero contrast. This is a balloon dilation. Again, another balloon dilation, putting a stent in the de novo place, and then doing drug-eluting balloon inflations at the region of ISR. The way we were able to do this is by using IVUS as markers to see how the disease is, where the disease is, and correlating that with fluoroscopy. Again, repeating IVUS to make sure that we have modified the lesion appropriately. And then finally making sure that we have our final IVUS run, showing all the distal vessels all the way up to the proximal to make sure that there is no harm done. There's no dissection, because again, the resolution that you get from this is incredible, that you can make sure you're not having any kind of complications. Again, this is not something that I would promote as an individual therapy. We need a combination, but then with the advance of therapies, with intravascular imaging, we have different options where we can give the best treatment to the patient. Another case is a 43-year-old male presenting with, again, crushing substernal chest pain radiating to the left shoulder and neck, which started 2 hours prior to the ED presentation. He said that he was working out in the gym and then started having this pain. He did feel some stuttering chest pain the day prior. So again, a very typical history where history is extremely important. Dynamic ECG changes as well. This is the coronary angiogram. You don't really see much on the coronary angiogram. This would have passed the eyeball test where looking at this, we would have been like, oh, this is all non-specific. There's no significant coronary artery disease, and I can't find an answer to your chest pain. This is something psychological, or we need to look up for other etiologies. In this case, if you look back, I'll show you some haziness that if you look with the, let me see. So over here, there's some haziness that you see. This is all very straight, and then there's some haziness, lumpy bumpiness that you see. Do an OCT, and I'll pull it just to the lesion. So all of this is very healthy tissue, or relatively healthy tissue. You see some plaque buildup in the media. And this is plaque erosion. So that can be a presentation for ACS as well. The difference I have is on the right of the screen, you see plaque erosion, which is just plaque coming out, versus a plaque rupture, which is an acute plaque rupture where there's a dissection flap in between. And based on this, there's enough data to say that if there's just plaque erosion, you can get away without stenting the patient at all. So key takeaways are important tool before and after and during coronary interventions. Aortoostal lesions or advanced kidney disease, you want to prefer a modality which does not include giving contrast, which is IVUS. In the era of precision cardiology, intravascular imaging is an absolute must. PCI can be also performed with zero or ultra low contrast in patients with advanced kidney disease with the help of intravascular imaging. And I think this is one of the most important points, that when referring patients for a cardiac catheterization procedure, it is extremely important to confirm that wherever this patient is going, for the patient's sake, do they have advanced technology and modalities with expertise and interpretation as well. I believe that just having a modality is not important. It's extremely important that the person who's doing the procedure is used to interpreting these pictures, whether it's IVUS, OCT on their own, and making sure you give the best treatment to the patients. Thank you.
Thank you, Dr. Parth, for excellent presentation. There are 5 mistakes made in cardiology by the physicians and how to avoid them will be presented by Dr. Vipul Kapoor. I invite Kapoor, sir.
Thank you, chairpersons, moderators, and panelists for giving me this opportunity. Morning, everybody. So my topic, after 2 technology-driven talks, is something about some clinical knowledge, some introspection, some retrospective analysis. As physicians, we are all physicians here. We may be specialists at one point of time, but we have all been physicians, and we have all made mistakes. And one who learns from his mistakes is the one who has really done a good job. So it is nothing about procrastination in this talk, but it is something where we can improve all ourselves, and all of us have always an opportunity to improve. So let us look at the 5 common mistakes as far as cardiology is concerned, and how we can avoid them would be the giveaway. So from heuristics to high reliability, what do you mean by heuristics? So it's a German word, and what it actually means is by biases. Like, you know, a crowded restaurant always looks busy. So you mean that if a restaurant is crowded, it is good. So heuristics are basically clinical biases, or basically practical shortcuts or mental shortcuts that you use to come to a diagnosis. Like, say, an elderly gentleman who has chest pain, he's a diabetic, you assume that it is a cardiac problem, isn't it? So you don't wait for tests, and you immediately subject that patient to an angiogram. So that is where the problem comes. Quite often, it can be laden with errors and biases, right? That is where human bias comes in, and that is where we err, and that is where we make mistakes. And that is what the focus here would be, that we just don't go by biases, we come to a clinical conclusion wherein we can avoid mistakes, isn't it? So in our clinical practice, there are certain diagnostic and therapeutic pitfalls, and they occur with surprising frequency. We do not realize it, but we are making mistakes. And this is where this guide comes in, where we can systematically dismantle our assumptions, 5 common assumptions, and we can replace them with evidence-based, structured approaches, and that would ultimately improve patient outcomes and, in fact, resource utilization. Like we just heard in our previous 2 talks, wherein to use CT calcium scoring, CT angiography, wherein to use imaging. Not all patients require everything, isn't it? And that is where our clinical judgment comes in. And this is where we are, and this is where we can avoid those pitfalls. So the first and foremost common mistake that we make is in the presence of LBBB. So that is the LBBB conundrum, the left bundle branch conundrum, and diagnosing MI in the presence of a left bundle branch block. That is where we commonly make mistakes, right? So that is how I will show how to navigate acute myocardial infarction in the setting of this. The second thing, which is again very, very common and which you all would agree, would be a troponin signal. Injury versus infarction, whether all troponin positives mean MI, or whether sometimes you can even have a troponin negative, but you can still have an MI. The normal ejection fraction illusion, again a very, very common mistake, that if there is a normal ejection fraction, if the pump is normal, there can be no heart failure. Again, a very common mistake which we will try and dismantle. The anticoagulation cascade and the balance, AFib, stroke prevention. We sometimes are very much afraid of bleeding, that in a way that we err to give anticoagulation or under anticoagulate. So that is another mistake that I will try and address. And the last and the most important, I believe, is the chest pain cascade. The risk first investigation, that when to identify that this particular chest pain requires further investigation and this chest pain is free enough or is low risk enough to be sent home. So these are the 5 common mistakes that I would be talking about. So let us start with the first one, the LBBB conundrum. So the clinical dogma here is very simple, that you cannot diagnose MI in the presence of LBBB. But my friends, that is a wrong dogma and that is a mistake. The error dismissing acute MI in patients with LBBB, assuming that all the STT changes are secondary to a conduction abnormality. So you can either miss it or you can overdiagnose it. But this outdated teaching leads to false reassurance and missed opportunities for reperfusion, and we can definitely lose the patient if we do not intervene in that right particular patient. So which would be the right patient is what we need to know. So let us start with a question. I hope you have your meters ready. So this is one ECG, and as you can see, I believe all of you can recognize that this is left bundle branch block, which is pretty clear. So that we will not be discussing. But what does this ECG show? Is it just LBBB? Is it with a myocardial infarction? Or it is just a normal? Some of you may say that it is not even LBBB. So our time starts now. So quite a few, in fact, majority think that it is LBBB with a myocardial infarction. So that is the common mistake that I wanted to show, and that is what I believe that what has happened in this poll. So you say that it is with MI, I would say it is not, and then we will see how and why it is not. Let us then move on to the next question as well. And here you have got 2 ECGs, and you can see that again it is LBBB. And what do you see in these 2 ECGs? Whether it is again just LBBB. This is a paced rhythm, by the way, and you have a normal except the paced rhythm in the lower ECG. And the third is LBBB with a myocardial infarction. Time starts now. So the C, that is LBBB with MI. So I believe everybody has learned, and that is what I wanted you to learn. So learning by just 2 examples. So you learned that this is myocardial infarction. Now why you voted, it is not just that this was the second question and you could actually now go for the second option, but there is a science to it, all right? So why it is an MI, right? So the toolkit is quite simple. Just apply the Scarboza's criteria. So there are criterion are these 3, right? So 5 points for when you have a concordant ST elevation that is more than 1 millimeter from the J point. So this is your J point, and when you have a 1 millimeter elevation with a positive QRS complex, concordant leads, you get 5 points for it. 3 points are for ST depression from the leads more than 1 millimeter ST depression from V1 to V3. And when you have an excessively discordant ST elevation of more than 5 millimeters in the leads where you have a negative QRS. So when you have discordance and you have got 5 millimeter ST elevation, that is an MI, you get 2 points. And that is where this is the Scarbosa's criteria. If you have any of these, you can say that there is MI. So look at this ECG, you can see ST depressions. Can you appreciate this? So you have got Scarbosa's criteria, V1 to V3. Look at the V4 in this example. Can you see ST elevations? You have got a negative QRS, and if you look at the J point, there is a 5 millimeter ST elevation. Even in V2 and V3, almost 10 millimeters of ST elevation. So this is very clearly an MI in the presence of LBBB. While if you look at the first example, here if you see your typical Scarbosa's criteria are not satisfied or not fulfilled when you look at the ST elevations here. So this was just benign LBBB, if I could say, but in the next few examples you can clearly identify that there is a way to identify LBBB and myocardial infarctions. Obviously troponins would be there, but that is a different thing. But it is just from the ECG where you can appreciate examples, concordant QRS ST elevation in any lead, concordant ST depressions in V1, V2, V3, and any ST elevation more than 1/4 of the S wave. So this is the S wave prior, and look at the depth here. So from the J point, if you look at, this is the depth of the QRS, 7 millimeters. So if it is 25% of it, 4 millimeters here and 2 millimeters, that is more than 0.25. So that qualifies as an MI in the presence of LBBB. So this, my friends, is the science, and not just that I asked you a couple of questions differently. All right? So I think that is all. A raise of hands, you understood? Great, good. So now let us move on to the next fallacy, and that is troponin signal. So cognitive error, equating elevated troponin with acute myocardial infarction. So very commonly we send troponins, and any time that there is an elevated troponin, it is almost synonymous with an acute myocardial infarction, and urgent cardiac reference is done, particularly common with our critical care and other non-cardiac specialties. And then we have to firefight, and we have to explain that sometimes it may just be a myocardial injury and does not mean infarction. So that is very, very important. So look at the corroborative evidence to suggest that this is a myocardial infarction, not just a troponin elevation. Look at the clinical setting, look at whether there is any acute chest pain, look at the ECG, look at the echo. All of these things and the clinical background would actually tell you that it is a misdiagnosis, and you may avoid unnecessary further evaluation, and you may sidetrack the actual diagnosis of the patient. So therefore, a troponin positive may be because of pulmonary embolism, maybe a demand ischemia, maybe an extreme exercise sometimes, marathon runners, myocarditis, renal failure, sepsis, all of these and so forth can actually give you a falsely elevated troponin. So my friends, this is the takeaway here, that not all troponin positives mean that there is an infarction. So the toolkit is here, decoding myocardial injury. So look for the delta. So troponin elevation, hallmark is fall, rise or fall, that is the delta, the change in the troponin. So more than 20% over 3 to 6 hours, that might suggest an acute event, while on the other hand, there might be acute injury, there is a sudden rise, and it takes some time to fall. But when you have a chronic injury, it tends to remain plateaued, like in the presence of renal failure. Okay, so always apply the clinical context. Remember the universal definition of myocardial infarction. So that is very important, as I said. And then again, as I mentioned, synthesize all data. Look at the patient as a particular picture as a whole, not just treating one report of troponin positivity. That would tell you to misdiagnose or to underdiagnose or overdiagnose. The third, as we mentioned, is about ejection fraction illusion. Now this is a very common problem. Very commonly we encounter that if there is oversimplification, if the ejection fraction is normal, means you are out of danger, you are safe, there is no heart failure. But my friends, this is the error. Almost 50% of heart failure patients actually have HFpAF. Right? So that is very, very important. That is an error that we need to find out. This is a massive blind spot. And you can have so many conditions wherein you can identify ejection fraction 55%, but can still have heart failure. Early hypertrophic cardiomyopathy, subclinical systolic dysfunction, diastolic dysfunction, valvular heart disease, even restrictive or constrictive physiologies may in fact have completely normal ejection fraction and may still have heart failures. So the toolkit is to assess the diastolic function very properly. And that requires biomarkers, and that requires a very detailed and a careful attention to details as far as echocardiography goes. So LV filling pressures, if you find that the E by E ratio is more than 14, it suggests elevated filling pressures. Look at the left atrial size, look at the volume index. If it is more than 34 ml per meter square, it is definitely abnormal, may give you an indication that the patient may have heart failure. E by E ratio less than 1, very simple, no tissue Doppler required. Impaired relaxation, and if it is more than 2, definitely suggests that there is a restrictive filling physiology. If the pulmonary pressures are elevated, it may be an indicator that there might be left heart failure there. So clinical correlates, just send your NT-proBNP. That would again, clear the picture further. So if your NT-proBNPs are more than 125, look at the clinical diagnosis, and it might fit in, and that might suggest heart failure. And look at the HuFPEF score. So look into your scoring systems, get your HuFPEF score, fill in the details, and you may actually find that the patient may have heart failure with a normal ejection fraction. So the toolkit is look for these parameters on your echo. Look at wall thickness of the LV, may suggest hypertrophy. Look at chamber dimensions, particularly LA enlargement, which we very commonly ignore in our routine echoes. Look at regional wall motion abnormality, and a very good tool nowadays is GLS, Global Longitudinal Strain, which we use for certain specific subset of patients. If you find that the value is less negative than -16 or -18, then it might indicate a subclinical dysfunction despite a normal ejection fraction. So that is very important. Chemotherapy patients, heart replacement, valvular heart disease patients, wherein you can detect subclinical LV dysfunction prior to the actual overt LV dysfunction that might happen over a period of time. The fourth is anticoagulation balance, balancing between stroke and bleeding risk and miscalculating the risk. And that is where you might end up over or under treating atrial fibrillation. Now this is very important. In atrial fibrillation, you have to know about two particular scores, the CHADS2-VASc score and the Hess-Bled score, which might help you to come to a detail. Now this is one question which I want you to answer, whether all of you are aware of CHADS-VASc and Hess-Bled score. So time starts now. Are you aware but you don't use it? Aware but you use infrequently, and you are aware and you use it routinely. All right, so aware but you use infrequently. So good and honest answer, and I believe, but the good point is that you are aware. So the teaching would be this, that if you are aware, then you please use it in useful patients in deciding what the CHADS-VASc score is and whether anticoagulation, because that will lead to under anticoagulation. So CHADS-VASc score is very simple based upon these criteria. Look at the mnemonic here: congestive heart failure, hypertension, age more than 75, diabetes, prior TIA, stroke, vascular disease, age 65-74, and sex category of female getting 1 point. So you add up these CHADS-VASc scores, and if the risk score is more than 2, more than 3, then this patient would require anticoagulation. Whether even if it is the first episode of atrial fibrillation, chances are 70-year-old first episode of AF, better to anticoagulate. On the other hand, if the patient is on anticoagulation and you are worried about the bleeding risk, look at the Hess-Bled score and decide whether what dose of anticoagulation that you would require and whether that patient is at a risk of high risk of bleeding. So driven approach is this: quantify the stroke risk with the CHADS-VASc score. Look at the DOAC modern therapy guidelines. So more than 2 in men and 3 in women would be eligible for anticoagulation. Nowadays, we know that with presence of lone AF, DOACs are preferred over warfarin. Step 2 is manage the bleeding risk with Hess-Bled. So if you find that there is not great degree of uncontrolled hypertension, labile INR, then it is not a contraindication. So give proper dose of anticoagulation. Don't undertreat these patients because the stroke risk would be much higher than the bleeding risk. And that would be the take-home message, that you properly decide whether bleeding is there or anticoagulation is required. And the chest pain cascade is the last one. And the error is very simple, that you low-risk patient, extensive workup, you get up with false positives and leads to patient anxiety. On the other hand, if you work them up too much, then it would lead to wasted resources, and in fact almost like an incidentaloma, I would call it. It is almost like a trauma, or it is like a tumor incidentaloma. So the risk-based pathways are like this. You look at history, you look at ECG, you look at age, risk factors, and troponin. The pitfall to avoid is patients less than 40, routine stress tests, no symptoms, just chest pain, comes to ER, just send the patient home if there is no significant, if everything is done, nothing else to be done. But on the other hand, a 70, 80-year-old diabetic chest pain, evaluate and then only decide what needs to be done. That way, you optimize resources and give the best outcome to the patient. Thank you.
Thank you very much, Dr. Vipul Kapoor, on the 5 mistakes which we hope to avoid in the future. We now have Professor Derek Connolly, who's joining us from UK, Birmingham, who's going to be talking about a new era in LDL management, inclisiran outcomes in high-risk patients. He has a particular interest in preventive cardiology and has published extensively in this field. Thank you for joining us.
Thanks for inviting me. It's great to be here. You know, my unit is in Birmingham, and 70% of my patients are South Asian in heritage. 80% of my colleagues are South Asian, and cricket is the biggest topic of the day in our unit. I should also point out that they've had 2 feet of snow in the last 2 days, so this nice warm weather here in Gujarat is absolutely fantastic. Now, one of the interesting things, as well as being interested in preventive cardiology, I started off one of Europe's first primary angioplasty programs, one of Europe's first cardiac CT programs. And what I realized was that prevention is better than cure, both for primary and secondary prevention. And of course, LDL cholesterol is not the only risk factor. You're going to be hearing a lot about GLP-1 agonists this afternoon, and I published a study of 63,000 patients last year. But LDL, we know a lot about, and more importantly, we have therapies that work. So my conflict of interest is I've been funded by Novartis to be here, and I've done an awful lot of the lipid trials over the last 30 years. You all know that like pack years in smoking, the higher your LDL cholesterol and the longer it is high, the more likely you are to have cardiovascular disease. That's why if you have familial hyperlipidemia and you have an LDL of 400, you present to my department, as one patient did a couple of years ago, age 16, with an acute myocardial infarction. But for most people, it's a lifetime before they develop that heart disease, a lifetime of exposure to high cholesterols and gradual accumulation of atherosclerosis. And we know that although LDL is not the only risk factor, it's all of the apolipoprotein B containing lipoproteins. It is the big risk factor, with the one caveat that I see an awful lot of my South Asian patients with very high lipoprotein A. And it's important when you measure a full lipid profile, and you should, that you measure the lipoprotein A, because I think next time you invite me back, we'll be talking about specific lipoprotein A inhibitors, I hope. But the bottom line is the cholesterol cargo is carried in these 3 lipoproteins, the biggest of which, for the vast majority of your patients, will be LDL. And we know your total cholesterol varies in your life. Your lipoprotein A is the same at 18 months as it is at age 80, but your LDL is very low at birth at 30, and it rises. You can see for men it peaks sort of around 30 to 40, then dips. For women, it stays lower, but then rises at the menopause, which is why women get heart disease with around a 10-year lag to men. We also know that very low LDL cholesterol is physiological. An LDL cholesterol of 30 is normal in babies. And of course, there are no ICU babies in pediatric ICU on infusions of LDL. So our high levels in society are abnormal. We know this from places like China, where people in the fields had low LDL. Now they're in Shanghai making mobile phones. Their LDL is very high, and of course, China's seen a large rise in cardiovascular disease. In more simple populations and wild animals, the total cholesterol, the LDL, is much lower than it is in westernized or now globalized populations eating McDonald's and Burger King. Now, plenty of evidence that having a high LDL is bad for you. Is there evidence that lowering the LDL works? So I was a young fellow out of Cambridge 31 years ago in Dallas when my now friend Terry Pedersen presented the 4S study using simvastatin. We shouldn't use simvastatin now. It's a moderate intensity statin. We should use atorvastatin and rosuvastatin. But he lowered the LDL, albeit from a level of over 200, by a modest 35%. But when he did this, and this is Terry's original slide, he showed a big reduction in total mortality, in the need for revascularization and event-free survival. And of course, that changed everything, and many of us did studies on statins with more potent statins versus less potent statins, higher doses of more potent statins, and then for the last 15 years, additional therapies. At the moment, we have 5 therapies to lower LDL. By the end of this decade, we'll have 10 therapies. And a bit like blood pressure, we don't call blood pressure therapy amlodipine therapy. We call it blood pressure therapy. So we should move away from statin therapy to lipid-lowering therapy. And also, like blood pressure, if someone's blood pressure is 180 and you lower it with 5 milligrams of amlodipine to 165, you don't stop there. You add in combinations of therapy. And one of the big lessons we've learned, it's now in the European guidance, is that combinations of therapy are necessary. But we know from the randomized trials, the lower we get the LDL, the lower the event rate. We know from big studies like MESA, over 12 years, cohort studies, that lowering LDL is good. But the big new thing in the research world is biobanks. In the UK Biobank, we have 500,000 people's genetics. And we can see there over 50 years what genes and what gene polymorphisms cause the risk factors for heart disease and make it much more likely you are to have an acute myocardial infarction. What's more, we've gone back and we've looked at all of the clinical trials we've done lowering LDL cholesterol, and it doesn't matter how you lower LDL. What matters is how low you take it and how long you keep it there to reduce the event rate. So I've already mentioned statins. Please use rosuvastatin and atorvastatin. They are very, very cheap. There's no major differences between the two, but they get about a 50% reduction in your LDL. And if you don't take them, for the cardiac surgeons in the room, in Sweden they did an analysis, and if you don't take your statins, you're twice as likely to die. Now, ACE inhibitors and angiotensin receptor blockers and antiplatelet drugs also have an effect. Interestingly, beta blockers don't have an effect, and if you want to read an interesting paper, look at the New England Journal a few weeks ago, 5 big studies. If you have normal left ventricular function post-infarct, and most of my patients now we have primary angioplasty do, then beta blockers don't work, and that was shown here in the Sweetheart study many years ago. Now, my friends in America, I was presenting this data at the ESC, and Bob Giuliano was in the audience, my friend Bob Giuliano, and I got him to stand up and have a round of applause, because the Americans say, LDL, you don't need LDL, it's the packaging. Lowest is best. Very low LDLs, and we've shown this in clinical trials, are safe and the most effective level to have. Now, given all of that, how are we doing? We did a big study all around Europe, a report card of how we were doing in the best units all around Europe. And kind of amazingly, we found that still 21.8% of patients were on no lipid therapy at all. And only 24% were on combination therapies. That was really quite bad. But what we realized is the only patients that get statin lowers your cholesterol by 50%. You get a residual 50%. It's lowered by 15 to 20% by ezetimibe or 50% by PCSK9 targeted therapy. And if you add all 3 of them together, you get around an 80% reduction in your LDL. At 1 year, we went back. We gave everybody a missive. And the good news is very few patients are now on no lipid-lowering therapy, and more patients are on combinations of therapy. And that is definitely the direction of travel. Now, let's talk about the LDL receptor. The LDL receptor is the dumper truck. It grabs LDL, takes it into the liver, throws it out into the biliary tree, into the gut, and then it goes back and does it again. And each molecule will do it around 100 times. And if you have familial hyperlipidemia, and you get a bad gene from mom and a bad gene from dad, you have heterozygous FH, your homozygous FH, your LDL may be 400, and you may present to me at 16 with an acute myocardial infarction. And about 97% of patients with FH have an abnormality of the LDL receptor, but just over 20 years ago, Boal and our colleagues in Paris showed that the other 3% generally have an abnormality of PCSK9. PCSK9 is an interesting protein. It binds to the complex of the LDL and the LDL receptor, the dumper truck that's full of rubbish. And when it binds to it, instead of the liver getting rid of the rubbish and the LDL receptor comes back to the surface, the liver also gets rid of the dumper truck, gets rid of the LDL receptor. So high PCSK9, low levels of LDL receptor, high LDL cholesterol. It seemed like the ideal target for therapy, particularly when we found there were individuals in the world with no PCSK9, and they had lower levels of LDL, and they seemed to be entirely normal. So with a company called Amgen, we produced a molecule called evolocumab, a monoclonal antibody, which lowered this. We took it into a massive phase 3b trial. I was the UKCI for this, called the Fourier trial. To get into it, you had to have an LDL above 70 and be on a statin. And we followed the patients up for about 2.5 years. We took the LDL down. The median LDL was 30, and about 2/3 of the patients had an LDL of 40 or below. And intriguingly, we not only saw a reduction in the first event, we saw a reduction in the second, third, fourth. Now, it takes time to get the cholesterol into the artery. It takes time to get the cholesterol out of the artery. So the benefit on episode 2 was bigger than on 1, 3 again bigger, and 4 we showed a 40% reduction in the 4th event. So undoubtedly, it takes time to have that reduction in the atheromatous plaque, which is why adherence to therapy is so important. But there is no bottom to LDL. You can take it as low as you can get it with the tools that we now have. What's more, we did an open label extension with this, and there was no catch-up. It took about 3 years for the people. In the open label extension, everybody got the active evolocumab. It took about 3 years for the curves to become parallel. More recently, in the last month, the Vesalius was published. I was a Vesalius investigator. This is in patients who haven't had a heart attack or a stroke. What we used to call primary prevention, we now call patients with arthromatous disease who haven't had a stroke secondary prevention, but these are the traditional, more primary prevention that you see on the cardiac CT. We talked about earlier on calcium scoring. And go and read this in the New England Journal, but again, a 25% reduction in 3-point MACE, heart attack, strokes, cardiovascular death. So no doubt, many, many studies, nearly 6 million people in studies now, showing that the lower your LDL, the less likely you are to have a cardiovascular event. And this is why in Europe we changed the guidance last year based on a paper we had written suggesting we want the LDL for secondary prevention to be under 55. But you'll see there we've put this new term, extreme. That's the frequent flyers, where we want the LDL below 40. How are you going to achieve that? The only way you're going to achieve it, like in blood pressure, getting to that target of 120 we were talking about, is combinations of therapy. Ideally with something to block PCSK9, ideally with something to block cholesterol synthesis as well as absorption. But when you do that, you take the LDL, you can see me there in Dallas 31 years ago, Terry bringing the LDL down from 200 to 125. Here's our Fourier now a decade old, showing we're bringing it down from 100 down to a median of 30. So evolocumab's fantastic, but it isn't being used. And when we do use it, patients stop it. We know this from studies. And this is my data from the UK. The yellow line is where we thought we were going to be. The blue line is where we actually are. So the technique of blocking PCSK9 works. Maybe antibodies are not the perfect way of doing it. So is inclisiran the best way of doing it? Inclisiran is the first mass-market small interfering RNA. It blocks the same protein. It's not gene therapy. Gene therapy is coming. CRISPR-2 is coming. This is a molecule that blocks production of the protein. And the good news about it is it's once every 6 months in the chronic phase. A technique, Andy Farr and Craig Mello got the Nobel Prize for this. I thought this was going to be around the corner when I was doing my PhD in Cambridge 30 years ago. It's taken this long, but there are now 200 small interfering RNAs in development. So all aspects of medicine, there is almost certainly a small interfering RNA that is going to change your practice. But inclisiran's the first mass market one. We've now given over 1 million doses worldwide, and we're not seeing any major adverse events. There are nearly 40 studies with inclisiran. Orion 9 heterozygous FH, Orion 10 in North America, Orion 11 in Europe and Africa. Again, showing whether this worked or not. And when you do a meta-analysis of these 3 studies, you're getting around a 25% reduction in MACE. This is exactly where we expect the large phase 3B trial, Orion 4, to present later this year. But, you know, I had the honor of looking at all the abstracts for the European Society of Cardiology, and every country published its first 10, its first 100, its first 1,000, its first 10,000 patients, and all the time you see a 50% reduction in LDL with virtually no side effects. The only side effect we see is mild erythema in the arm in about 5% of the patients, as you would with a flu injection. I've got 4,000 patients on it. I've had to stop 2 patients who get a rash with the injection. Both of them wanted to stay on the therapy. But other than that, I've not seen any adverse events. In the UK, I launched this in the UK for the NHS 5 years ago. It's very much part of our guidance. You can look that up easily. Just Google NHS lipid guidance, and you'll see that it's there. More recently, we've had the Victorian Initiate study in North America, ostensibly, as you can see, randomizing patients to usual care or usual care plus inclisiran. We did put one add-on in. If you are on atorvastatin and you lower your cholesterol by 50%, and you go on inclisiran, but you stop your atorvastatin, then your cholesterol stays the same, non-responders. And I studied this, but bottom line is, you have to tell the patient, this is in addition to their statin therapy. We did this in Victorian Initiate, and more patients stayed on their statin. And as you can see there in blue, many more of the patients were achieving the goals we know work from the clinical trials. We also have insurance database evidence that this might be a better therapy. This is the Komodo database, and ostensibly this compared evolocumab, alirocumab versus inclisiran, and the area under the curve for LDL
5
was
minutes
better,
remaining.
and the adherence levels were better. We have long-term data. We have Orion 8, which was an open-label extension going out to 8 years, which was presented at the European Society a couple of years ago. And ostensibly, it showed no significant safety issues. Everybody got a long-term reduction of around 50% with no diminution of effect, which is great news. There was no effect on the liver. In Europe, you don't have to measure the liver function test on this, which is great news for all the other small interfering RNAs coming. I still measure the liver function test in my patients, but that's because they're on statins as well. You don't have to measure it for inclisiran. Interestingly, statins cause diabetes. You all know that. This drug doesn't. And in fact, there was a lower level of diabetes. I don't think it's protecting you against diabetes. You just don't have to titrate the statin dose up as much. But we were seeing around a 25% reduction in 3-point MACE, suggesting this is going to have an impact on clinical outcomes. So this is my slide from one of our publications. I'm on atorvastatin 40 milligrams daily. In a leap year, I take 365 tablets. There's evolocumab, 26 injections a year, and it has to be refrigerated and taken at home. There's inclisiran every 6 months. In fact, you can go out to 9 months without having to reload. It's 0, 3 months, and then every 6 months. Okay, latest trial, my friends in Germany, the Czech Republic, Poland, and Croatia did a study looking at giving this straight up front. I do this on the wards. Last week I had 3 patients come in who were already on statins with acute MI, and their LDL was still raised, so I gave them inclisiran on the ward. But the Germans very kindly studied this for us, and guess what? It works. You get much more likely to get to target quickly, indeed. And interestingly, you don't have to put the statin up as much, so they showed less muscle-related adverse events. The latest paper, and I can't show you the data for it, is published in the last month, and this is a prediction of where we're going to go with the phase 3B studies. Okay, so where am I using it? I'm using it in patients with infarct. So this is patient 4 in my program. So this is during COVID. He's a truck driver. He's Sikh. We have many truck drivers in Birmingham because it's in the center of the country. And he presented with an infarct with no previous risk factors, but he did have a strong family history. He just never had his lipids measured. He had primary angioplasty. I did the primary angioplasty. And you can see his basal LDL. Please do a full lipid profile when they present. Was 245.9. We gave him atorvastatin and ezetimibe. We published this paper in the European Journal about 5 years ago, suggesting why not give statins and ezetimibe straight up, because they're very, very cheap. You can get combination tablets in most of the countries
2
around
minutes
the world.
remaining.
But his LDL cholesterol was still 100, so I give him inclisiran, and it's come down to 40. He's now 5 years on, still driving his truck, no problems. Second case, 67-year-old lady with an ischemic stroke. A lot of stroke physicians still don't give lipid-lowering therapy. From Fourier, we show clear evidence it works. This patient's LDL was 260. My stroke physicians put her on 80. I don't see all stroke patients in preventive cardiology, but this one came. My nurses added an ezetimibe, but the LDL was still 123, so we added an inclisiran, and it's 54.9. Third case, last case, really important, 33-year-old, my fellow's wife, 10 years ago at a dinner party, she leaned over to me and said, my mum had a heart attack at 44. I want to have babies. How safe is it? I said, what's your LDL? She didn't know. Her LDL was 300. She's got heterozygous FH. So 10 years ago, I did a CT coronary angiogram. This is a technique I introduced to Europe called heart flow FFRCT. She had a tight LED, as you can see that, well, modestly tight. Normal stress echo. I did not stent her because she's asymptomatic. I put her on aggressive therapy of evolocumab, ezetimibe, and atorvastatin. Her LDL came down to 65. And then 5 years later, she knocked on my door and said, Derek, I want to have babies now. And the license says you have to stop everything. So we did. She had a baby boy. I said, time to go back on therapy. She said, no, I want a second baby. She went on and did that. By the way, the stress echoes were normal. And then she came to me and said, I'll go back on therapy now. So I wanted to put her back on the same therapy. She said, I've been to your lecture. I want to go on this new therapy, inclisiran. She's about patient 5 or 6. So she's been on inclisiran because she thought it was better for her lifestyle. She loves it. Her LDL initially was 63. I checked it about 2 weeks ago. It's now 40. The two babies have grown very well. She's lost a lot of weight. She looks very fit indeed, and everything's going well. So we have changed the world. We now believe that combination therapy is the way forward. This is a Delphi paper I published a couple of years ago. And lowering LDL works. And the only way you're going to achieve the targets we know work is with combinations of therapy. But the truth is, we have a long way to convince the public, the media, and especially colleagues that those 6 million plus patients we have in clinical trials, this clear evidence that things work is incredibly powerful. So please check everybody's lipid profile, including your own, and please use combinations of therapy. And in doing so, we'll save lives. Thank you very much indeed.
Dear friends, first thing, after 18 hours of conference, more than that actually, we started 8 yesterday morning, we finished at 10 last night, and 6 hours this morning. We are right dot on time. Only conference in the Indian history of 50 years, Dr. Nakul Sena Aditya, which consistently in 20 years have kept its time, number one. Number two, Dr. Connolly, disclosure. My brother had stents, 5 stents, I put it in. My mom had a stent, elderly. My father had bypass surgery, and I take statins, alternate day, ezetimibe, and I took the first commercial available dose of inclisiran in India. We are part of the Victorian trial for many years. So does my wife. I have a 30% plaque for last many years, so I'm on triple therapy. I do take my inclisiran every few months, usually not 6, but 9 months to 1 year. And my wife also does take it. So it's a disclosure, no commercial intent. But I truly believe it's a phenomenal drug from its scientific basis. Having said that, I would like every panelist here to stay over there and all of you to stay here. I'd like to invite Dr. Rajeev Singhal, our MD CEO, to talk a little bit about, in a limited time, your slide will be cut off if you exceed. We are ruthless. To talk a little bit about our institute, hospital, Marengo, its growth. After that, we are still in time, so we'll have 15 minutes of phenomenal question-answer session from all of the speakers, whether it's imaging, cardiac, we pull with his tips, or obviously I would like Derek Connolly to be the prime faculty for the very controversial questions, after which you can go for our sumptuous lunch by Gordon Maharaj. Dr. Singhal, welcome.
Thank you, sir. So I just heard Dr. Conley over amazing lecture from him. And I think a cardiologist threatening a surgeon about the cut, so I will be very precise in cutting the lecture. So it was interesting from that particular angle. Thank you once again, and this is, as we move forward on this entire, without wasting time, I would quickly give a brief background about what Marengo Asia is all about and what we are intending to build over a period of time. This is the organization which is backed by 3 big investors, the family office of Godrej, the Havels Group family office in Samara, which is a private equity group. They were responsible for building Thyrocare, and they were responsible for building Asian Institute of Gastroenterology in Hyderabad over a period of time. And they are still the biggest investors in Sahajanan Medical Technologies also, as far as this is concerned. We all came together. The idea was to build a platform which is more than 5,000 beds, pan-India platform, with the intention of creating regional center of excellence as we move towards achieving this intention of creating a 5,000 bed platform over a period of time. This is how the journey started. As I've said multiple times, this is a company formed at my house in Gurgaon in October 2020. At that particular time, in US, people call it as company founded in garage. And then 2021, the first merger of Marengo Sims happened. And thanks to Dr. Kayur Parikh sir and his group of colleagues who trusted us in this journey, and this was the beginning of Marengo Asia platform as far as the country is concerned. The second asset we acquired was in Faridabad, which is now 600-bed facility. We are setting up oncology unit also there. Bhuj is an integral part of us. That came to us in April 2022. Then we acquired 100% stake in our Gurgaon facility, which is presently 250, and we have acquired land in front of it. We'll take that hospital to 450 bed as far as Gurgaon is concerned. We added the holy city of Varanasi in our armamentarium, and in fact, this is a hospital which is 300-bed hospital. And then we were the first hospital group to venture into Kingdom of Saudi Arabia. So we have a hospital in Saudi Arabia which we operate and manage. Presently 120 beds, 100 more beds are getting added. So Maringo Asia is the first hospital group with the official hospital running capability and asset in Kingdom of Saudi Arabia. And people who are following up the news, this is one area which is opening up very strongly, and somewhere down the line, Kingdom of Saudi Arabia is becoming much stronger than rest of the UAE countries as far as the healthcare is concerned. Those who have followed, the Arab health has moved towards as a global health, and they just had the biggest conference of the healthcare as far as the global health is concerned in Kingdom of Saudi Arabia. Then recently we have added 2 hospitals in Gujarat, and I would spend few minutes here on Gujarat because I think this has become more of a karma bhumi for us, where by next year we'll have the highest number of beds as far as our network is concerned, and we will be the largest group in Gujarat with acquisition of these 2 assets, one in Baroda, Surat, and there is something else which may come up over a period of time. So we will be strongest healthcare providers as far as Gujarat is concerned. This is a snapshot of our assets. Delhi asset looks absolutely like this, and people who visit Delhi, please do visit us. We have been very quality conscious as far as the assets are concerned. This hospital of Ahmedabad, those who have been associated, this is 4-time JCI asset. In our endeavor to create a center of excellence, we have tied up with American College of Cardiology, and we are looking at now getting accreditation for a center of excellence for cardiology here, and we are starting the accreditation process in our Delhi assets in this financial year. There are certain associations in addition to this, what we are talking about, that we have tied up with Mass General Hospital and NHS Bristol. This is an interesting conversation. Last to last year, there was a group of hospital CEOs from NHS hospital, trust hospitals who were visiting India. They visited around 7-8 groups all across. We are the newest kid on the block as far as the healthcare is concerned, with the giants like Fortis, Max Apollo sitting there. And we were given the last slot to meet from the association perspective. We met at 8:30 in the night, 17th of December, and they had to catch a flight at 2 in the morning. The conversations happened, and we said that conversations may have been cold, but somewhere after 2 months, I received a message from NHS Trust Hospital guys and said, 13th and 14th of April, they are having their strategy session for Vision 2030, that how we want to shape up, and they have chosen Maringo Asia as to be a strategic partner for the discussions. So we went to London, and we had this conversation with them. Now we are working very aggressively with NHS, and I'll roll out certain programs, what we are doing with them, nursing training programs, MRCP programs, and other associations. In our endeavor to do this, when we joined hands with Dr. Parikh sir and his team, our intention was to build Center of Excellence. In my conversation with Dr. Mohammed Biden from Mayo, I asked him that, how do you actually define a Center of Excellence? And I think there is no clear-cut definition which actually gives the comfort of saying what is Center of Excellence. We said, let us try to define the ingredients of Center of Excellence. The most important are people, process, infrastructure. If you have clinicians who are par excellence, they can put the team together. You can give them the infrastructure which can help them to perform, and then they can put the processes in place. That is the starting of putting a Center of Excellence. Our endeavor will be that in 3 to 5 years' time down the line, we should have these institutes coming out of Maringo Asia platform in various assets at Center of Excellence, which we have highlighted here. And academics, research, and innovation will be key component without which we will never progress. This is a couple of things which I think all the clinicians. Happy to say that Dr. Dhiren Shah is sitting here. Dr. Naren and Dhiren Shah, they were the pioneers in doing the first bloodless heart transplant, first outside United States of America. Nobody has done this in Asia. We were the first ones to do that. And patient could go home in 9 days' time. So thank you, sir. We really appreciate this being a showstopper of the event as far as the Indian healthcare is concerned. And over a period of time, we have focused on trying to do certain things which we want to build over a period of time, which will be differentiator, innovators, and at the same time will put us on a different pedestal as we continue to progress in this journey. As we have a global footprint also, we operate in 7 countries in addition to what I spoke about Bristol. Today, in fact, Dr. Bala Ganpati from this hospital is operating in Iraq. There is a team flying to Uzbekistan tomorrow from Gurgaon Hospital. And last week we had people who came back from Nigeria after completing 40 renal transplants in 1 year with our association in this. So we are actually working in medical strategic partnership across 7 countries as we speak now. And why do we do this? Last time when we were here in G20 meeting in Gandhinagar, one of the meetings with the ministers, I had made a comment, and I said that out of 195 countries who are part of United Nations, nearly 100-odd countries will never have the financial power to knock at the doors of Mayo's, Cleveland's, and Anderson Institute over a period of time. And money will be a big hindrance in their approach. But India today has a time where an opportunity where we can build institutions and we can be Mayo Cleveland for those 100 countries. All the people who are sitting here, they are the owners of the hospital, the clinicians. The way you have to think about is to build an institution where you can become their go-to person for the people who are actually looking up to India for developing their medical science. So this is an opportunity for everyone who is part of this conference here. And it is based on three principles. We said, teach, train, and treat. Our endeavor will be that we are not looking at getting patients from these countries. We would like to create an impact by teaching and training people in their countries and treating maximum number of people. So it's a principle of 3 T's on which the clinical corridor is being set up. This is the most important part of it. And last time, in fact, Dr. Dhiren and Dr. Anish had traveled with me to Mongolia to set up this entire process of cardiac sciences as far as the hospital is concerned in Mongolia. This is just a snapshot of what we are doing in a couple of places. This is the concept of clinical corridor. These are the countries. And if I look at Iraq, in fact, we have operated nearly more than, we do operate around 25 to 30 cases per month in Iraq by our visiting consultants. We do around 300 patients every month in Iraq as a process. What has done is we are trying to change the landscape of that country by training and teaching people in those areas. And similarly in Uzbekistan, in fact, next week again, I'm traveling to Uzbekistan to look at some government tie-up on these. Kenya, in fact, we were the first ones to actually do the scoliosis surgery and first robotic knee surgery in Kenya. Our team from India had flown down, they have bought a robot, and the robotic knee surgery, first time in East Africa, has been done by the consultants from Meringue hospitals. This is a framework which I've spoken about on the COE. When
5 minutes remaining.
So when we want to create a COE, how do we actually basically progress on this? So it's a roadmap for this. And last but not the least thing, I just want to highlight one thing is, there is on 16th and 17th of February, we are doing the first ITAC conference, second ITAC conference, where first time Harvard and NHS are coming under one roof. So Harvard, NHS, they are participating. There is full faculty from these two institutions is coming there, and they are actually covering this entire piece with us. And Tata Motors has agreed to partner us on working on road safety through this conference. So this is on 16th and 17th. So it's a big event for us. And there's one thing I want to announce here. And this was the conversation which we had with Dr. Parikh sir and rest of the people, saying that what do we do for the people who are sitting here. We said we will launch Generation Next internship program for the people who are basically here. So all the doctors who are here, if their kids, they want to come for doing internship, which is essential for making the portfolio if they want to go abroad, please reach out to Meringue Hospital. Even in medical and non-medical, we are opening up, in fact, a series of internships for all of them. So you can reach out to us. This will be for the Generation Next, a program which we want to initiate. One more point which I want to highlight, which has just missed the slide, is that we have started the MRCP programs for the doctors. 2 years you work in Meringuesia Hospital. This is unique program which we have launched with NHS. 2 years you work with us in Meringuesia Hospital. 1 year you will get a GMC license to practice in UK if you go through this program. And after that, there are chances that you will be absorbed in UK, or UK has assured that they can give a pathway to take these people to Australia. So this is a complete career path which we have actually carved out with these partnerships. So this is all from my side. Thank you once again. And this is an opportunity where people can basically take advantage of Meringuesia hospitals. Thank you, sir.
Much, Dr. Singh. We can start our forum question answer. Any of you, he will be around in the lunch session. So let's start with the question answer for the panel now. Audience, questions from the audience? I think everybody will wake them up again. Questions? Yes. Introduce yourself and then question.
Udaipur, I'm working in American Institute of Medical Sciences at Udaipur. I want to ask, if you give the combination therapy to lower the LDL cholesterol, will you give all drugs in optimum doses or minimum doses?
It's a really great question. And so the question is, how do I give the drugs? And I think, you've had the analogy in the last session about heart failure. With inclisiran, it's a single dose. With bempedoic acid, it's a single dose. Ezetimibe is a single dose. The forthcoming drug, obicetrapib, will be a single dose. But what we're really talking about is statins. And I think there's a couple of things to say. Firstly, the side effects, and they may be real or perceived, are dose-related. So if you go with 5 milligrams of amlodipine, only some people will get ankle swelling. If you go with 10, about 30% will get ankle swelling. It's the same with statin therapy. And I think what combination therapy lets you do, and that's what my friends in Germany have shown, is use a lower dose of statin with the additional therapies. And so, yes, I'm doing exactly that. I'm giving a lower dose of statin with a PCSK9 targeted therapy, usually inclisiran, with ezetimibe. So it is a way of reducing potential side effects of the statin therapies.
Yeah. My name is Dr. Ankur Rawal, and my question is to Dr. Anish Chandarana, sir, and otherwise, yes, fine. Dr. Anish, as you said, that if coronary artery calcium score is more than 300, the LDL goal should be less than 30. Probably, if I'm not mistaken, the embryo is having the LDL of 39. So are we like stretching the horizons which is laid by the superpower God and making them less than 39? And are we wiser in sort of say just on the basis of CSE more than 300? Please, sir.
So maybe first I'll discuss and then doctor can take up. So like people who have got CT coronary calcium score more than 300, they have got very, very high risk of myocardial infarction, stroke, and death because of them. And out of all modalities which we have to reduce this risk, one of them is reducing LDL cholesterol with the help of maybe statin, ezetimibe, PCSK9-based therapy. So if your calcium score is more than 300, taking LDL to less than 50, at least for Indian patients, and optionally those who can tolerate, say for example, somebody is on rosuvastatin 10, ezetimibe 10, and inclisiran, and if he achieves LDL of 30 without any serious issues, then 30 is the target. So more than 300, CT calcium score 50 or 30, number one. Number second point, what you said is something which God has designed by changing that. You said neonate has got LDL of 30, 35, 40. Well, I mean, see, a lot of progress human race has made is made against what is perceived as against nature. So many things, even creation of this house is against nature. So in the pursuit of making our life longer, better, more comfortable, what we do is a lot of things is against nature. Now, what against nature is good and what against nature is bad, time will say that. So perhaps all of us lack that wisdom, but at the moment, world is in the pursuit to increase the comfort and longevity of life of humans. And maybe I will invite the comment of.
I agree entirely. You know, one of the interesting things, though, is the earlier you get in with therapy, the less high you have to go. And that's for most things. So one of the interesting things, last week I had 3 infarcts on the ward who were South Asian, who were all under 35. And so, as you've heard, you know, only 20% of 40-year-olds with coronary disease will have calcification. It's 80% of 50-year-olds. But under 35, they don't have any coronary calcium. Yet we know that lowering the cholesterol there works. All the modeling says it works. So cardiac CT is coming in as another screening tool. But I think the truth is that we've done the data now that if we blanket treated people based on their risk factors and looked at lifetime risk, not just the 10-year risk, we'd be treating many more people, probably with low-dose lipid-lowering therapy to start with, but then more aggressive therapy depending on the imaging. Do you agree?
Agreed. I had a follow-up question that do you have patients who, from a compliance standpoint, say that I just want to be on inclisiran irrespective of the statin reduction?
Yeah. So in the UK, and I was part of the negotiations, I could only get inclisiran for what was initially secondary prevention. But interestingly, patients who had atherosclerosis on a CT coronary angiogram or a CT, we counted for the very first time as secondary prevention. I was very proud that I got that under the bar. For those that are truly primary prevention, either I do a cardiac CT and find out, or if they're paying themselves, I let them take it. And I've got lots of patients. And on this tour of India, I've met several people, including physicians, who are doing exactly that with monotherapy with inclisiran because it fits with their lifestyle of twice-yearly injections. And I don't have an issue because LDL is agnostic of how you lower it. It doesn't matter how you lower it, just lower it.
I have a
Sir,
question.
one question to you. I'm Dr. Nilesh from Navi Mumbai. A patient has got an angioplasty done. He's on inclisiran, statin, ezetimibe, bempedoic acid. 1 year down the line, after taking 3 injections of inclisiran, his LDL is 10, 5, or 0. What do you do to that patient? Do you stop inclisiran or?
I usually shake his hand because, you know, if I had coronary disease, and I don't, I've had the CT, but if I had coronary disease, Jim Broomwald will tell you that LDL is like cigarettes. You want 0.
No, but do you stop inclisiran after he reaches a...
No, I don't stop inclisiran. I would probably stop the bempedoic acid because there's not much point being on 2 cholesterol synthesis inhibitors. If you're on statin or you're on bempedoic acid, you're only getting an extra 10% reduction if you add bempedoic acid to statin therapy. So I'd probably stop that. But no, I wouldn't stop it because at the end of the day, what you want to do, the line goes right down. We showed him Fourier that it was safe. The American Heart Association has made that statement that there is no too low, lowest is best. And you know, one of the interesting things about having a cardiac CT program for 20 years is I do repeat CTs. And lowering your calcium by whatever means increases calcification, but it absolutely gets rid of that low attenuation, high-risk plaque that we see with the vulnerable caps. And so I've got many patients who had horrible CTs, and now they look pretty good. And that's because we've treated not just the cholesterol, but all the risk factors, but I'm very aggressive and have been lowering LDL.
So you mean to say you need to continue inclisiran indefinitely for these people?
The analogy there is brushing your teeth. When do you stop brushing your teeth?
Question to Anish, one question. This
Yes.
for calcium scoring, why you kept the age at 30 years? Before that also we are getting so many patients as having a
So good
acute,
points. I mean, a very good point. Like, see, people less than 30, because of various reasons, will have high risk of events, specifically Indians. A very bad lifestyle, maybe high lipoproteinase, smoking. But most of them will have soft plaques. So if you send them for CT calcium score when they are aging less than 30, very few will have calcium score more than 0. So what will happen is you will induce unnecessary sort of sense of safety to them. Actually, they should be warned. So if you wish, and there are people who have got lipoprotein 100, those who do not stop smoking, who are youngster 20, 23, 24, send them for CT angio and demonstrate those soft plaques. That's where sometimes by showing them those soft plaques, you can change their lifestyle. You can also plan medicines. So before 30, having calcium score more than 0 is quite uncommon. So that's why it will be it will not be a yield. So if you wish, and if you have high-risk youngsters, you send them for CT angio.
You know, I completely agree. And the other thing is, when you get the imaging, show it to the patient, get them to get their smartphone out, get them to take a picture of it, and when they decide not to take the therapy, get them to look at the picture again.
Okay.
Yeah, so I mean, putting one point, now I am seeing many youngsters, really young, aging between 16 to 30 years in India, and many of them have very bad lipid profiles, in India especially. 18 years, 19 years, because I have a daughter and son of roughly 16 to 24, so many of their friends, and to my surprise, at least 25–30% of those youngsters have got LDL more than 120. So we all know that, see, the previous case we discussed, somebody who had calcium score of more than 300, detected at the age of 60, you need to be very aggressive to take their LDL to 30. Instead, if you pick up all these boys and girls at the age of 18, 19, 20, and 21, and if their LDL is persistently more than 120, 130, if you start a very small dose of statin and ezetimibe and get their LDL to even 70 or 75, but if you are starting very early, their cumulative exposure to cholesterol will be so less, so they will perhaps never need that high dose. So why we are needing high dose today is because of our poor knowledge, and we have not been implementing that knowledge. So now we have a knowledge that catch them as early as possible, reduce their LDL cholesterol and maintain them there is important. And that's why I'll seek his comment, but all of people sitting here will have to start daring to write lipid-lowering treatment to 15, 16, 18, 19, and 20 years young boys and girls. Maybe your comment.
You know, the other thing is, you can see there, this is the 21st year of this fantastic conference. I would imagine by the 41st edition of the conference, CRISPR-2 will be here. And we'll be able, with a single injection, to switch PCSK9 off. We'll be able to switch ANGPTL3 and lipoprotein off. And all of those, if you inherit the right genes, and we've shown this in the UK Biobank, then your chance of getting heart disease is very, very low indeed. So potentially, in 20 years, a bit like tuberculosis was, we might be at the point where coronary disease is somewhat historical. Fingers crossed. We'll have to find something else to do, guys.
Again, a question to Dr. Anish Chandarana. We are all after him now. Calcium scoring is a very important thing. Now, you know, there is a controversy regarding, or rather an agreement regarding not to use aspirin for primary prevention, right? So if a guy who is asymptomatic, around 45 years of age, his calcium score is 50, the location of his calcium is in left main or LAD proximal, do we give him aspirin for primary prevention, or is it secondary prevention already?
So good point. Like, see, again, coming to physiological discussion is when you give aspirin or any antiplatelet, especially aspirin to anyone, there is a fixed rate of bleeding. Generally, out of 1,000 people, if you give for 1 year, 4 will bleed. And that's not epistaxis. It may be major GI or ICH in general population. So if you pick up a population which has got risk of MI, stroke, and death, which is more than 4 per 1,000 per year, so you have to find out a population group which has got sufficiently high risk, which can offset the negative effects of aspirin. So if you have a CT, there are so many such factors. If you have a CT calcium score of more than 100, now their future predicted risk is much higher, and those people can accept that small risk of bleed. Now, having said that, before starting aspirin, even to people who have got calcium score more than 100, you just rule out people with high bleeding risk. Those who have got past history of spontaneous bleeding, those who had major GI bleed, ICH, those who have got low platelet count, those who have got other bleeding disorders. So there may be 10–15% of such patients. But the rest 85% of people, if they have got calcium score more than 100, and since they are low bleeding risk, giving an antiplatelet will surely help them to reduce future risk of MI and stroke.
Second 2 minutes
point,
remaining.
When you write any treatment for primary prevention, it's always important to have a shared decision making. Primary prevention is an area where you are treating a patient with a medicine for lifelong without any manifestation of disease. So that's where it's very important he or she understands that because of this high calcium score, your risk of MI and stroke is so high that taking aspirin and inviting some small risk of bleeding is justified. So when he or she comes on this platform of understanding, I'm very sure you can give antiplatelet. Less than 100, that's where risk is not as high to risk bleeding risk. Fine. So again, it's a shared decision. So suppose I've got left main calcium score of 45 or 60, and then it's a shared decision that giving aspirin will reduce risk of thrombosis there, but then you invite. Now see, if it's genuinely me, I have got absolutely very low bleeding risk, so I can take aspirin with a calcium score of 50 in left main. So a good point, see, wherever you cannot use aspirin because of the risk or adverse effect, particularly people with allergy to aspirin, I have seen very rare in my life, or people who have got GI bleed where they say aspirin has got dual effect. It is not only just blood thinning, but also local irritating effect. So these are the two groups of people where you can use clopidogrel. But again, there are data that clopidogrel, Indians will have more resistance as compared to aspirin. So let aspirin be the first choice, but if there are issues, you can go to clopidogrel.
Patient 59-year-old, routine investigation, CT calcium score done, 1180, and then subjected to coronary angiography, and it turned out to be normal. Then now, what should be the future risk and how you treat this?
So good point, and I think, see, anybody who is asymptomatic, who gets calcium score more than 0, my first goal is to put them to stress tests. Now, if that gentleman or girl is less than 35, I'll put them to CT angio or some angio, but what you talk is 59 years of gentleman, no symptoms, 1100 calcium score, put them to stress test, good kind of stress test. If patient is asymptomatic, stress test is negative, there is no need of angiography. But you went ahead and did angiogram, and you said that there is no significant luminal narrowing. So these are the people who are to be put on aggressive preventive therapy. One antiplatelet, get their LDL to less than 30, modify their lifestyle. If they are diabetic or obesity, put them to GLP-1 RA or GIP, etc. So use everything, whatever you are available on this earth, to reduce their future risk of MI, death, and stroke. That's going to be a serious war, but you have to fight that war. But again, let me put a point. Any calcium score, please don't send for angiography without symptoms or positive stress test. See, that's where cardiologists are risking the life of people, unfortunately. You were asymptomatic, you had a score of 500, you went to a doctor did angiogram, he finds 2 blocks of 60, 70, 80%, he puts stents. I have so many doctors who comes to me, Ganesh, my life is saved. I said, what happened? You were exercising with me in club till yesterday. He said, yesterday I got calcium score, as you rightly said. Even I insisted, it was 300. I went to another cardiologist and I got 2 stents. And he saved my life. I said, no, that's not the way. When somebody who had no symptoms, somebody who had no ischemia, he had stable disease. In this entire world in last 100 years, there is no data that a person who doesn't have ischemia with stable disease, putting stent helps. So many people, particularly doctors, that's why I shouted, most of the doctors are getting stents after CT calcium score without symptoms, with no ischemia. That's something which is very serious, so please be aware about that.
Thank you very much,
Question
Anish
to
bhai,
Dr.
for
Anish.
excellent.
One more question to Dr. Anish. Would you like to replace TMT with calcium scores? What is your thought on
That
this?
gives me another very important chance. They two are different path. Calcium score is only for asymptomatic people, and TMT is for symptomatic people. So if I come to you, I have 0 symptoms. For my future prediction, best test is CT calcium score. Now, having said that, if you push me for TMT, that's fine, but my TMT will be normal. So TMT becomes positive in a very late stage of cardiovascular continuum. That's where the disease has progressed to a serious level. What we want to pick up by calcium score is people when they have got just beginning of disease. That is what the beauty of calcium score is. So it's for asymptomatic people. So anybody who comes to you for health checkup, don't put them to TMT who are asymptomatic. Get their calcium score. That is something which is more important.
Most of the companies, they included TMT in their basic
That's fine.
fitness.
That's fine. Let TMT be there. There is no harm about that if patient is fit. But calcium score is must for anybody who's more than 35, 40 in India.
We have to advise them that calcium score is included in the TMT. If there are no symptoms.
That's
like,
always a better way for asymptomatic.
Thank you very much, Anish bhai, for
Thank you.
excellent, clear-cut guidelines for all physicians. Now we are concluding the session, and thank you very much for all speakers for wonderful session.
Thank you very much, all the speakers, all the session experts, panelists, chairpersons, and moderators. Let's break for lunch, and post-lunch we are getting here at right 150. 150 or 145? 150. Thank you. But still, stable plaque will rupture. Not necessarily every stable plaque does not rupture. So like see, if, समझाओ, if patient has acute coronary syndrome,
Primary PCI has to be done in less than 90 or less than 120 minutes, and then in patients with shock, etc. also as well early.
You have to tell your radiologist to check for the pelvic vein thrombosis, whether it's there or not. VQ scan, once it was very popular, but now we hardly do. That's why your lecture has opened up more.
Hello, hello. Hello, good afternoon, everybody, and I welcome you again in this post-lunch session. First of all, I would like to invite chairpersons for this session, Dr. Akhil Mori, Dr. Apurva Madia, Dr. B.I. Patel, Dr. Bhavin Dalal, Dr. Dharmesh Prajapati, Dr. Mehul Solu, Mahesh Solu, Professor Luca Bussetto, and moderators are Dr. Amit Prajapati, Dr. Dharmang Oza, Dr. Khurram Vasaiya, Dr. Rajesh Sangani, Dr. Subhas Telang, and Dr. Tinkal Patel. And panelists, we have Dr. Dhaval Naik and Dr. Rasmi Chovatia. Please come on the stage. Dr. Bhavin Dalal, if he's back, he can come on the stage. The first talk is by Dr. Bhavin Dalal. He will be talking on use of AI with caution in clinical practice.
Hello. Good afternoon, everyone, and thank you very much for this opportunity once again. I think in the last 2 days, in the morning and evening sessions, you guys learned quite a bit about AI, and I think a lot of you guys are using AI. So in a pro-con debate form, I'm actually trying to generate a con part, which is very difficult because AI is now so popular. Are we using it rightly, ethically? Those are the questions I will try to answer in the next few minutes. So, lot of debate about the terminology as well, whether the AI is artificial intelligence or it's an augmented intelligence versus artificial intelligence is a big question. In the ideal world, AI should not and cannot replace the clinician. So it will enhance or should enhance for a healthcare or medical education or research, and I think we have a lot of topics we covered. But remember, the clinician still is in a central seat or in a pilot seat. AI has to be an addition, not a substitution. So one of the biggest question, are we moving too fast in the world of the AI? And these are again data mainly from the the internet situations. How many physicians are using AI? Or back in 2023, as you can see here, only 38% of the physicians used AI. Yesterday, I think we took, like Keyur Parekh did the informal poll, how many of you are using AI? And probably 95% of the people said they have used some form of AI for their healthcare or for their patients. According to the data in 2024, almost 78% of the people started using the AI for the patient care or the medical education, which was kind of steep jump of almost 78% in a year. So is it good or bad whenever we are using something so exponentially fast? We have to use the AI with a caution. So I'm going to show you a few data regarding what are the problems. So you learn about what are the advantages so far. I'm going to show you what are the disadvantages or what are the problems of the AI. So one of the important problem is the algorithmic bias. Remember, the AI gets the data from the data. So whatever we have fed, for example, on the internet, on the blog, on the medical journal articles from the newspapers, everything is kind of compiled together in a big or a large language models. So the information going in is significantly biased. It is collected from different resources. One of the best example of a bias information coming in will give the biased outcome as well. Was studied by the Ziad and the colleague back in 2019, and then actually reproduced in 2024, 2025. So in this study, what they did, that the goal for the healthcare proxy or a goal for a healthcare was considered from the expenditure. Like they have millions of the patients' databases. According to the different ethnicity or a different race, for example, white versus black, how much expenditure happened over time for the black patients versus the white patients that was studied. And what they found that the black patients, of course, the black patient has a lower healthcare cost. So the machine learned that the black patients did not require significantly more healthcare, or black patients do not require more healthcare resources because their expenditure is less. So if I put a clinical question, do black people require more healthcare resources or less healthcare resources? According to the AI, the answer will come that the black patients will require less healthcare resources. In reality, black patients have a less insurance, they cannot afford the healthcare, so they don't go to the clinic, they don't go to the hospitals. So that's why their expenditure were less, not because they require less healthcare. So when they have distributed the healthcare according to this algorithm, actually the black people required, or they were allotted significantly less help or less resources. If they have actually corrected the real life situation, actually the black patient in general, the whole world knows that, they require more healthcare, their healthcare outcomes are actually worst compared to the white patients. This is universally truth for last 100 years or so. So the bias created because of the information going in, or whatever the information you are using is going to give a wrong output. So whenever you have your own question, you have to be very careful that what kind of information was fed inside the AI model, then the output would be variable or significantly deranged compared to the actuality. The second problem is a patient's. I don't want to give a name of a person from the United States, but probably you all heard one of the important person in the healthcare, in the CMS or the Center for Medicaid, the highest level person, created a 70-page report on the vaccines. Now, when I say vaccines, probably half of you guys probably know who I'm talking about. So he created a 70-page report for the vaccines, and whatever the references or citations he has given, almost half the citations were improperly actually imputed into the model. So, when you read the journal article, you might create a different conclusion than I create a different conclusion. So then those citations were either wrong, or the recommendations based on the citations were wrong, almost more than 50% of that. So remember, that is a significant problem, and then whenever you do something, you want to make sure that just don't look at the citations. Every Copilot, Gemini, ChatGPT, everything will give you the citations, like this is coming from this resource. But actually, if you open up the resource, the interpretation of that particular citation might not match with what you wrote in your paper or your recommendation. So that's very important part we have to be aware of. The third is a AI and a de-skilling. This is a very interesting concept that are we actually improving ourselves or deteriorating? Think of a concept of a Google Maps. Back 20 years ago, we used to remember all the roads. We used to remember the routes. Now we don't. I mean, if I have to go from here to there, I need to use the Google map. So are we improving our intelligence, or are we deteriorating? This deterioration is known as a de-skilling. So are we skilling by the AI, or are we de-skilling? And to show you the example, this was a New England Journal of Medicine article. Back in our era, like if you can look at here, this is how we learn, right? A novice person, a medical student, will start his medical career, then slowly will advance. Then at certain point, we will say, okay, now you are board eligible or board certified. This is not working anymore. Now you are board certified to practice intramedicine or general surgery or whatever it is, and then you practice it for the several more years, then you become proficient, right? That's how we used to do. Think of a current medical student or a current resident. They will start their career, for example, here as a novice, like all the medical students are novice. And then what will happen that they will use the ChatGPT or the artificial intelligence. So several people actually never learned anything because every time they use the ChatGPT or Gemini, so they did not have a great fundamental situation. Several people did have actually developmental arrest. Like they learned something and now they started using the Gemini or the ChatGPT and now they cannot learn further. So this was an amazing cartoon diagram that the people can have a de-skilling, mis-skilling, no-skilling. This will all happen. Like again, going backward in a clinical practice, for example, when I started my critical care journey, we used to put a subclavian line and the IJ without any ultrasound guidance. Today, my fellow cannot put any, any line without the ultrasound guidance. They will need the ultrasound guidance because that's how they are trained, which is not bad in a way, but what if you don't have ultrasound? How will you practice? And that's a de-skilling. Another amazing experiment happened, and again published in the Lancet GI and Hepatology. So what they did in one of the retrospective and observational study, they have an AI model. Remember the gastroenterologists, when they do colonoscopy, they will try to find out the adenomas. And several of those adenomas can be cancerous. That's why after the 50 years of age, there is a recommendation for a screening colonoscopy so that we can detect the colon cancer early, right? So what they did, they actually have an AI model. It will actually, while they are moving throughout the intestine, they will tell, the AI model will tell that I think this area looks suspicious. Try to focus more on this area and see if you can find the adenoma. So then the AI model will actually facilitate the endoscopist
5 minutes remaining
during the colonoscopy, and they have studied the the adenoma detection rate. Now after the 3 months, actually they stopped providing that AI model. So for 3 months, they did use the AI model to detect the adenoma. After the 3 months, they stopped using the AI model for an experimental purpose. And you can see that actually the adenoma detection rate went down. So this was before the introduction of AI, the adenoma detection rate of 28% versus adenoma detection rate actually significantly down. So remember that the AI, are we making ourselves more intelligent or not? That's always a question because it's a de-skilling issue came into the picture. AI and a legal liability. Again, I think several people yesterday or in an evening session also asked this question. Remember, you are the clinician, you are liable. You won't be able to defend yourself in the court of law. Oh, the AI model ChatGPT told me this one, that's why I actually treated the patient this way. It's not possible. AI is still an addition, it's not a substitution, so you won't be able to support yourself for the legal liabilities, so always use it with a caution. I don't think this is a significant problem in India because everybody is sending everybody's name and the information through the WhatsApp messages or the messages. But in the United States, we have this HIPAA violation and a significant problem. So in 2023, 2024, 133 million records, inclusive of the patient healthcare information, the PHI, went up in the cloud, and then that was a breach of a confidentiality. So I think this will lead a significant kind of a lawsuit and medical malpractice situations if the information is found on a cloud. Here, I think it's a less of a problem, but eventually would be a trouble if you are not aware of a people confidentiality. The AI models are very important also. They have to be validated in the area where they are being trained. Say, for example, if I am developing an AI model in a rural of Nebraska or Washington, I cannot actually use that model in the well-developed areas or vice versa. So if I have a model developed in India, cannot be used in the United States, and vice versa, United States model may not be able to use in India. So we have to develop our local models based on the infrastructures and availabilities. The last 2 minutes I have, a lot of people are Googling this thing or the ChatGPTing this thing nowadays. The new verb is ChatGPTing rather than Googling. So what I did for the purpose of this exercise, I put this prompt in the ChatGPT, Gemini, and Copilot.
2 minutes remaining.
The 55-year-old male with a decompensated alcoholic cirrhosis came to the ER with a septic shock with a presumed hepatobiliary source for the sepsis. Answer the following questions. Provide the antibiotic recommendations, provide the recommendations for the fluid therapy, and provide the recommendations for the target blood pressure. I mean, these were a very simple question. I think that probably any critical care or even internal medicine doctor should know the answers, but just for the purpose of this exercise, I did this one. So Gemini gave me this answer that give the bolus of a 30 ml per kg, which is the standard of care over 3 hours. A bolus should be crystalloid. Albumin should be considered early. They didn't define what is early. Evidence suggests that albumin may improve survival and renal function in the cirrhotic patients. ChatGPT gave me 10 to 20 ml per kg, not 30 ml per kg. So now you are confused. Should I give a 2.5 liter bolus or should I give a 1.25 liter bolus if the patient is 60 kilogram body weight? They gave it over 30 to 60 minutes, not over 3 hours. They gave a LR and a plasma light. They gave a more specific suggestion for this thing rather than the crystalloid, which includes the normal saline, which we are trying to avoid in a critical care. And then, of course, they both said that, consider albumin early and so forth and so on. And then I put it in an open evidence, which I think is blocked in India, unfortunately, but we do use a lot of open evidence. They did not provide me the actual numbers. They just provided me that the fluid resuscitation should be done, albumin should be considered, dynamic variable should be used, so they did not provide me a specific suggestions. And then finally, I put it in a Copilot, again, the same thing, start with a 10 to 20 ml, not a 30 ml, over the 3 hours, not a 1 hour. So you can see that there are a lot of variations. Which one would you believe? And where are you in this journey? So it's a very complicated, and this was a very simple question. More the complicated question you are going to impute, more the complicated answer is going to come. So I will say that the co-pilot is here, which is the AI, but we are still the pilot. The clinicians are still the pilot, and then we have to use the AI with a caution. Thank you very much.
Hello, thank you, Bhavin Bhai. Now I invite Dr. Milan Chugh for his talk, Interesting Cases of Cath Lab Interventions.
So my actually cases are simple. All of us have seen coronaries and all of you also know coronaries. So I have selected some non-coronary cases which I'm doing here. So first case novel use of intravascular lithotripsy for coral reef aorta. This was the first case in the world. What is coral reef? You know about coral reef, which is an ecosystem in the sea. Produced by coral polyps. These are tiny animals, and these are the coral reefs. And something which is known as coral reef aorta. In aorta, cauliflower-like calcium deposition occurs actually, and actually it blocks the lumen of the aorta. So that was first described in 1984. So coral reef aorta is a rare disease of heavily calcified exophytic plaque in the supra, juxta, or infrarenal aorta, causing significant stenosis. So this heavily calcified exophytic plaque in abdominal aorta can cause significant stenosis, which is leading to visceral ischemia of mesenteric, renal. It can cause renovascular hypertension because of renal artery stenosis. Even suprarenal aortic block itself will cause renal ischemia, and it can cause even claudication. So surgery actually is very complex in such situation, and percutaneous intervention by doing stenting can cause aortic dissection or aortic perforation also. So what can be done? So this is a 67-year-old female who presented with history of hypertension for 4 years in spite of 5 antihypertensive drugs. BP used to be 160, 170. She had claudication, and she was non-diabetic. She was obese. BMI was 32 with weak femoral pulses. BP in arm was 160, in leg it was 80. Creatine was 1.4, EGFR was 42, ECG normal. USC abdomen showed calcific narrowing of infrarenal aorta with increased flow velocity in the both renal arteries. Velocity was almost more than 400. Angiography revealed insignificant coronary disease, and she had bilateral renal artery stenosis, 90%, and almost total cut-off of infrarenal aorta. When I went from below, there was hardly any dye going up by injection. And if you see the gradient, suprarenal aorta and yellow is infrarenal aorta, gradient was almost 100. This was a CT aortogram, and this is the coronal view, this is sagittal view. You can see that infrarenal aorta here at this point is almost totally blocked. This is the transverse axis. This is aorta itself, descending aorta, and almost entire lumen is filled with calcium. So this is what we call coronal reef aorta. Just pinpoint space was there which was giving some flow to the descending aorta. So surgery can be done, thromboendarterectomy, interposition graft, or axillary to iliac bypass graft can be done. Operative mortality is 10%, and postoperative complication requiring surgery is again 15%. Endovascular intervention like plain balloon angioplasty with or without stent can have high risk of perforation because of calcium, which can just prick the aorta. Stent graft with chimney like this, with penetration to perfuse the renal artery, it is a very costly thing, can cost 15-20 lakh rupees per complications also. While I thought of a novel use of balloon angioplasty. So what is intravascular lithotripsy? It is a electrical discharge system where emitter actually, we know about lithotripsy for kidney stones. Here it is same, calcium breaking, but it is now inside the balloon. And when electricity is applied to these emitters, it generates the electrical waves, or what we call sonic pressure waves, which has almost 50 atmosphere pressure. And it just breaks the calcium like this, and calciums become soft. With each pulse, the contrast creates a bubble inside the balloon, and then they are transported in the soft tissue, and they are actually stopped only when it is encountering the calcium in the intima or media or adventitia anywhere. So this calcium is ultimately becomes, broken down, and then balloon is inflated at even low atmosphere pressure, 4 to 6 atmosphere pressure, and then artery is open. So we, at that time, peripheral balloon maximum diameter was 7, aorta diameter was 12, so I used 2 parallel hugging balloon technique, where one was IVL balloon and another was plain balloon. IVL will, intravascular lithotripsy rays will pass, or pressure wave will pass through the plain balloon and reach to the aortic wall. So that is what we did. Initially, I implanted plain balloon, and then there were 2 balloons, hugging balloon. One was 6 by 60 lithotripsy balloon, one was 9 by 30 plain balloon, and simultaneously both were implanted. And this is how, and ultimately bilateral renal artery stenting was also done. So this was the pre, this is the post. Gradient which was 100 becomes 0, practically 0, 4 millimeter of mercury. 4 years have passed, patient is asymptomatic with well-controlled BP on minimal medicines. Present ABI is 0.94, which is normal. Creatinine, which was EGFR was 42, is now 72. Doppler done recently shows patent renal stent and no significant aortic narrowing. So this was the first report of a novel use of intravascular lithotripsy to treat coronal reef aorta in the world. It was already published 4 years back in European Heart Journal. Another case is transcatheter aortic valve implant plus transcatheter mitral valve implant. This was also the first time in the Gujarat somebody had done this thing. 76 years old lady, BMI of 22, frail lady, no risk factor. CABG with mitral valve replacement with perimount bioprosthesis was done in 2010. So almost 15 years back it was done with permanent pacemaker implant also, where battery was changed 3 years back. She presented with class 3 to 4 dyspnea with progressive fatigue and chest pain over 8 months. Echo showed severe degenerative calcific aortic stenosis, which was a native valve, which has now degenerated, and she has severe calcific aortic stenosis with valve area of 0.6. And this mitral valve, which was put 15 years back, has now got mitral valve degeneration with severe mitral stenosis, severe pulmonary hypertension, PA pressure is 670, severe TR, EF 50, still preserved. CAG showed patent graft. So what I decided was to do transcatheter aortic valve heart team discussion was done. She was too sick for repeat surgery at this age. With it will be a redo surgery. So in that case, and there was patent grafts also. So even sternotomy is a difficult in patent graft situation. So we decided to do aortic valve replacement with balloon expandable aortic valve and transcatheter valve-in-valve mitral valve replacement with balloon expandable valve, where we go from IVC to RA. We do transseptal puncture under transesophageal echo guidance. Specific puncture is there, and then we enter the mitral valve and valve-in-valve like this. Valve-in-valve balloon expandable valve is implanted in the degenerated bioprosthetic mitral valve. So these are the routine protocols. CT scan is mandatory and it has to be done. This is the baseline aortogram. This is the old mitral valve. Aortic valve is here. And here 24.5 millimeter my valve, balloon expandable valve is implanted, and this is the result. No paravalvular leak. There was no gradient. And then we went for mitral valve. This is a transseptal puncture. From RA to LA we have gone. Then there is agilis sheath which can be manipulated to point towards the biological degenerated mitral valve prosthesis. Intra-atrial septum has to be dilated so that valve can go like this. And now even mitral valve is pre-dilated. And later on, this is the implantation of mitral valve, balloon expandable transcatheter valve inside the degenerated bioprosthetic valve, and this is how we do it, and this is now valve-in-valve. So there are two valves. This is the aortic valve, and this is mitral valve, valve-in-valve. Transmitral gradient reduced from 20 to 1, LVOT gradient was 8, RVSP reduced from 70 to 45, patient was discharged after 2 days, 18 months follow-up, she is asymptomatic. Dr. Sailas Desai's patient, this was, I think he was here in the morning. I don't know whether he's there now. She's doing fine. Another case, 50-year-old male with no risk factor, presented with class 3 angina, dyspnea, dizziness, exertional syncope, no family history of coronary disease or sudden cardiac death. This was his baseline ECG. This was the baseline echo. Everybody knows this is hypertrophic obstructive cardiomyopathy. Very thick, 20 millimeter was the thickness of basal IVS with hyperrefractile granular texture, moderate MR because mitral valve is now going anteriorly, systolic anti-motion of mitral valve will cause incomplete coaptation of mitral valve leading to MR also. This is what we call classic systolic anti-motion of mitral valve on M mode. This is systole. Nothing should come here. Now valve is going anteriorly. So systolic anti-motion was causing peak gradient of 100, and on provocation, peak gradient across LVOT was up to 150. What we do, myomectomy is the solution. Of course, myomectomy has come to India now. Dr. Umilsa is going to tell a little bit about that also, but this is more definitive therapy. Either you do surgical myomectomy like this, which is an open heart surgery. There are some 2,000 surgeons in India, but hardly 10 surgeons can do this satisfactorily. So another option is alcohol septal ablation. So what we do is like doing angioplasty, we cannulate the LAD, we go to septal artery, we inflate the balloon of the size of the septal artery, remove the guide wire and inject absolute alcohol. What that does is, it causes controlled infarct of this part of interventricular septum, which causes some scarring and thinning, and the Venturi effect goes away and systolic anti-motion disappears. It does not cause too much of thinning, but then systolic anti-motion disappears. This patient had associated LAD lesion also, so that was also stented, and then simultaneously in the same sitting, we pushed this alcohol. This is a contrast by which we know that we are injecting the correct septal artery, and alcohol is injected. Now septal artery is blocked. On table only itself, baseline gradient which was 90 has become 0, provocable gradient which was 130 has become 10. This is the, now 10-year follow-up is there with this patient, not 12 years, even now 13 years. Patient has come for even repeat angiography, everything is fine. Stent is also patent. And this is my 100 consecutive cases. I presented last year in the Europe PCR in Paris in our international conference, which is the largest conference in the world, where I had presented this paper. So 100 consecutive cases of a single operator, single center. Of course, many of these cases were from my team colleagues also who had referred to me to do the procedure. Zero mortality, no operator mortality. On long-term follow-up, 5% died because of natural history of cardiomyopathy. 80% patient remained in NYHA class 2. Gradient reduced from 82 to 14 on table, and provocable gradient was reduced from 124 to 36. So this paper I had presented in Europe PCR conference in 2024. I'm writing the paper. This is the largest study in India, and follow-up is of 21 years, single center, single operator experience. Another case, unexplained polycythemia, 20-year-old female, BMI 24, presented with class 2 dyspnea, mild cyanosis and clubbing, and hemoglobin was 18 gram, hematocrit 55. So she had polycythemia. SpO2 was 90% at rest, which was going to almost 80% on exercise. So she went to various hematologists. Physician had seen, hematologist had seen, and for polycythemia, she had undergone even bone marrow evaluation, apart from the multiple hematological tests to find out what is the cause of polycythemia. She was referred here. We did contrast echo. There was clear-cut contrast appearing on the left side when we injected dye in the contrast in the cubital vein. Within 3 beats, if it comes in the left side, that means there is intracardiac shunt. But it comes after 3 cycles, then it has to be pulmonary AV fistula. There is only one diagnosis. So pulmonary CT angiography was done after this contrast echo, which was positive, and it clearly showed that there is a CT pulmonary AV fistula, which can easily be identified and can be easily be blocked by implantar vascular plug, which we did. 8 millimeter implantar vascular plug was put. See, this is the pulmonary angiogram. We can identify this AV fistula here. This is the fistula here. It is selectively injected. You can see that this is the feeder artery, and then this is fistula, and directly this is in vein and goes to LA. So there is no capillary circulation in between. So venous pulmonary arterial blood, that is unoxygenated blood, directly goes in the LA and causes hypoxia. You block the feeder artery, and that's all. That is the treatment. It was done on the table only. Patient saturation becomes normal. So always take home message for the residents and clinicians. When patient is having hypoxia, desaturation, and polycythemia, and there is hardly any symptom, ECG, X-ray are normal, always think of pulmonary AV fistula. Just do contrast echo and your diagnosis will be there. Another case, transcatheter wall-in-wall tricuspid valve implant. This was also the first time in Gujarat. We did just 15 days back. Apurva Patel actually showed this slide actually, but I'll give you the clinical history. 61-year-old female, NYHA 324, first surgery 1984, mitral valve replacement, second surgery, redo mitral valve replacement, third surgery, tricuspid valve replacement in 2016. Now that tricuspid valve has degenerated, caused severe TS, severe TR, EGFR, cardiorenal syndrome, EGFR 15 mm, gradient across tricuspid valve 14/7, IVC is 28 mm, and this is how we did it. Just cross the tricuspid valve. This is tricuspid valve, this is old mitral valve, and balloon pre-dilated. This is the balloon expandable valve which was implanted here, and this is valve-in-valve. This was again the first time in the Gujarat state that we did this thing. I think time is over. It's okay. One more case is there, but it's okay. Thank you.
Thank you, Milan bhai. I think time is always short for you. So just we heading with another lecture with Dr. Aditya Kapoor. Bit interesting actually. Sudden cardiac arrest, I believe. A community-based project. So another 15 minutes. Thank you.
Thank you, Dr. Ajay and the entire team for inviting me for this very important topic. And Dr. Ajay has been involved in these CPR projects for a long time, so I'll just show what we have with us. A bit about statistics in India. Where do we stand in terms of preparedness? Because the general physician should also know that in terms of preparedness, bystander CPR rates, we are doing very badly. What are the challenges faced by CPR programs, and what is the current status of these programs in India? Because we as physician community should come more forward and involve ourselves in these programs. So this was the first data which came to us from the Andhra Pradesh Rural Health Initiative nearly 10 years ago. 1.8 lakh subjects were surveyed, and although the questionnaires were not SCD specific, the retrospective data taught us that about 15 to 17% people were meeting the criteria for sudden cardiac death, which is a fairly high number, and cardiovascular disease expectedly was the majority responsible for these sudden cardiac death events. And then Haigrave Rao, who is another colleague of ours, he teased out this very, very good data. Two-tiered questionnaire among 25,000 people who were sampled, and each death was actually adjudicated by a 3-physician panel. And they found a similar percentage, about 10% of the all deaths were due to sudden cardiac deaths. The main concern was that 50% of these people were less than 60 years of age. 1 in 5 were less than 50 years of age. And 1 in 5 were actually housewives. So this was very, very unexpected, meaning thereby that we need to do something about it. And again, similar percentage that sudden cardiac death as the first manifestation of coronary artery disease was very, very common. So when all this data was extrapolated, the numbers about a decade ago was about 7 lakh sudden cardiac deaths occur in India, most of them out of hospital and most of them don't survive. And of course, this number has grown now. Most of these people are young, economically productive, so that is the tragedy. They die. We need better preventive measures, better emergency response, timely ACS care, we all know that. But the main focus has to be on CPR programs, community-based CPR. So how do we do that? We all know this chain of survival, early recognition, high-quality CPR, early defibrillation if it is available, the AED and post-resuscitation care. But what are we doing about it? So this is some data which has been published. Where do we stand in terms of bystander CPR rates and public familiarity with what is cardiac arrest? So this is pretty dismal. If you see, these are two very important studies. One is from Manipal, the other is from North India. And they sampled graduate students who are, we expect them to know something about CPR, sudden cardiac arrest. The bottom study from North India, it had about 50% people who were educated. Surprisingly, only 2/3 were aware of Indian Emergency Helpline. 1 in 3 were confident of recognizing a cardiac arrest, and less than 10% were actually familiar with what is hands-only CPR and what is AED. So this is pretty sobering data. And these are two important, again, studies. I'll just quote some important studies. This is the CARO registry, which is from North, and the bottom data is from Manipal. The bystander CPR rates in people who were having a cardiac arrest and then ultimately being brought to the hospital were 1% and 9% respectively. And if you see other data sets from India across the years, 2016, 20, 2022, these two studies are Pan-Asian and the PAROS registry, which are including some Indian patients, they're pretty dismal. 7%, 0%, only the WACA registry, which is the Warangal data, had 27% out of hospital bystander CPR rates. But again, overall data is very, very bad. And we all know that, and these studies also taught us that the survival rate will be better if the arrest is witnessed and early CPR is started and the cause is non-cardiac. So the basic thing has to be early bystander CPR. This is a very, very important data. If you see the international CPR education rates across the world, first of all, in the last 2 decades, only 60-odd studies have been published related to CPR, which tells us that the global thrust is actually not there in terms of public being taught about CPR. So that is, again, a very concerning thing. So if you see this, amongst Australia, Canada, New Zealand, the developed world, the general population being aware of CPR, at least one single CPR being taught to them, is about 60 to 70%. And this stands well with what the ACC tells us, the AHA tells us that if your population 60% is CPR aware, you have achieved your goals. And look at the other Asian countries, South Korea, Singapore, Taiwan, 30 to 40%, which is pretty impressive. And India is just 3%. And the most common causes are never thought about or felt the need to go for training, lack of time, and do not know where to take the training. So this is an important thing for us, maybe for SIMS group as well, because you are so active in public health programs. So go forward and step out and try to teach people about CPR. So what are the challenges we faced as when the CPR programs are launched in India, both at the personal level, at the institutional level, and the national level? If you see personal level, there is lack of knowledge. People don't know where to go for and where to learn CPR. They are reluctant to act in a group. That is our mindset, assuming that others will respond. Fear of legal repercussions, so people are taught about the Good Samaritan law, that the law supports you if you help a person. Cultural factors, and of course the false notion that bystander resuscitation can only be done by doctors or guys who are formally trained in BLS. So this is a notion which needs to be busted. At the institution level, our EMS infrastructure is very, very underpowered and under-resourced. There is lack of protocols across institutions. The ambulances are merely used as transport vehicles. We all know that. So there is no actual pre-hospital care being given to people who are being transmitted to hospital, be it acute MI, be it out of hospital cardiac arrest, because the personnel who are manning the ambulances are not aware how to do CPR, let alone handle a defibrillator. So that is another thing which institutions need to look at. And at the national level, many of us has been trying. Dr. Ajay Nayak, as the president of the IHRS, would be witnessed, he knows about it, that there is no legislation at the government level also, that in many foreign countries, whenever you are taking a thing like a passport or a driver's license, you are mandated to know something about CPR. So we have been trying to do that, but there's not much headway in that. And bystander CPR training is only being driven by individual organizations like Revive Heart in Mumbai, other people who are publicly conscious, or societies like IHRS, CSI, Indian Society of Electrocardiology, the Indian Anesthetist Society, etc. So it's not a government-driven initiative. There is no national initiative. We don't have out-of-hospital cardiac arrest registries, so we don't have robust data as well. So these are the lacunae at the national level which we need to address in the coming years. I'll quickly wind up with what are the challenges and how we are trying to surmount these challenges at these 3-4 levels. So in terms of public education, bystander hands-only CPR is being taught, and there is substantial data to show that, bystander CPR, that is chest-only compression, is good enough, because if the person knows how to do it and he does it in time, guys can be saved. So this is the CALLS initiative, or the compression-only life support, which was started by the Indian Society of Anesthetists, which says that it is as good as giving mouth-to-mouth respiration and chest compression. So it is an Indian version which has been accepted now by many societies. It is simple to learn, easy to remember, wherein the guy is just taught hands-only compression in cycles of 30 chest compressions each. So this is the thing which we are trying to teach everybody. This is very, very easy to learn, and the person is not mandated to give mouth-to-mouth respiration. Second thing is making public access defibrillation accessible and available. As of now, AEDs are only available at select locations, and they are not available at places which actually need them, like schools, colleges, shopping malls. Most are closeted AEDs, that is, they are locked most of the times, not available in out-of-office hours. So that is one important thing which needs to be looked into. We need to have better signages wherein the AEDs are available, as has happened in the West. If you see the bus stops, even there are railway stations where the AEDs are completely well marked and designated. And since it's a very high cost investment, we need to have a foresight and accountability wherein the AED is being located. So that is very, very important. If you look at the guidelines, we should also be aware that this is what the West recommends: 2 AEDs per kilometer square, or every 100 meters within out-of-hospital cardiac arrest. But this is not practical in India. So we need to place it at places where there is a very, very high public footfall, like shopping malls, as I said, swimming pools, gyms, etc. In the West, what they have done is, like Boston has mapped sudden cardiac arrest hotspots, ATMs, coffee shops. Singapore has AED on wheels, which is taxis or motorbikes have the AEDs, the first responder comes there. Finland has now a drone-delivered AED program, because this is not practical in India, but we need to figure out where to put them and how to put them. So in terms of this, I'll just briefly tell you what the Revive Heart, based in Mumbai, started by Yash and his group, have been doing in the past. And as I said, many physicians are being involved with this. So we have regional coordinators, about 100 members, and whoever wishes to volunteer can come forward and join this. About 15 lakh people have been trained in the last 4 or 5 years. Sudden cardiac arrest awareness campaigns are being done across the country, and there are real-life success stories. So there have been certain small successes. People are being saved in terms of out-of-hospital cardiac arrest. This was the Revive CPR app, which was launched in December 2024. So I would encourage everybody to launch it. It's freely available on the mobile phones. And we are now trying to give this to our patients as well on discharge. So we are telling the patients to download this app, because this not only gives you every instruction about CPR, but also maps out the nearest AED location. So this is a great app to download for patients and their relatives as well. And the other societies, like the Indian Society of Anesthesia, has also done a lot of work in this. The CSI has launched the CALS program, which is supported by Making India Heart Strong. So societies are coming forward. Not only this, private players like Zomato last year did a very, very big program, community-based program for CPR for its workers. And this was the second thing is another very important, innovative thing in which these were critical care guys. And last year on the World Emergency Day, they organized a CPR training program for the Rapido drivers and found that it was pretty successful. The guys were very, very motivated. So this is how all of us physicians can come forward and contribute to this. So I'll wind up by saying that the third thing which we need to do at a more larger scale is at the national level, have good 24/7 EMS services which are manned by better equipped ambulances, manned by trained personnel. So they should be having defibrillators, it should be a cardiac ambulance, we should have national level registries wherein out of hospital cardiac arrest becomes a reportable event so that we have some data and we can audit ourselves. CSR partnerships, big players, like it's a mandatory thing in the Companies Act to contribute to it, so we can encourage the private players to contribute to donate AEDs and adopt regions. So this is being done in the West now. The big companies are adopting regions wherein they are trying to donate AEDs. In terms of this, Dr. Akshay in Mumbai has tied up with the Rotary Club, and they have done, I think to the last count, they had put in AEDs at 40 metro stations in Mumbai. So this is what people have been doing. We have had some metro installations in UP as well. So this is how we as physicians can motivate big corporate players to contribute to AED installations. As part of Make in India policies, what is being done now is maybe good quality, low cost defibrillators.
2 minutes remaining.
Feedback mannequins to teach people, e-learning modules, and encourage government funding at central and state levels for these campaigns. Because as of now, there is no, as I said, cohesive national campaign. And the last thing is extend these outreach to schools and colleges. So this is the biggest thing which is happening now. We are trying to encourage schools and colleges to participate in this because students are the biggest teachers. So we're trying to get this into school curriculum. So that is one thing in which we would want help at all levels. If somebody knows some source in which the curriculum can adopt CPR, because this is now in our national education policy. And surprisingly, this bill was floated in 2019, but did not see the light of the day. So this is one thing which we are working on. And the West also endorses this in their guidelines that CPR training should be required for graduation from secondary school, and students should be aware of AEDs. And in terms of this, the IHRS, as I said, Dr. Ajay is heading this, and we brought out this joint publication with the Heart Rhythm Society that establishing a national CPR program in high schools. So the mandate is to start teaching this in schools from the age of 12 years onwards. So this document has been published last year, and hopefully we'll make some headway in this. So there is always light at the end of the tunnel, and even the Ministry of Health and Family Welfare did this program last year. The PMO officials were sensitized. So hopefully something is going to happen. And although the survival rates remain dismal, I think we should all come forward and strengthen government and community involvement in bystander CPR, encourage AED installation, and the main thing is include CPR training in schools and colleges. Thank you.
So we are inviting Urmilbhai next. It was a wonderful lecture, Dr. Aditya, and we assure certainly our involvement here in Ahmedabad also. Thank you.
Good afternoon, everyone. This is the new molecule, or I would say a very definitive way of managing the HOCM. I don't have any financial interest arrangement this. I will just briefly overview what HOCM is there, how we normally diagnose, and mainly I will focus on the treatment part, which is the new molecule, which is now available, and what data we have regarding this. HOCM or HCM, I would say, is a quite common disease. genetically very strong autosomal dominant disease. And obstructive HOCM is basically, obstructive HCM is basically 50 to 70% of all HCM. And the criteria for diagnosis is resting gradient should be, or the provoke gradient should be more than 30. That is what we normally do. Now, what is the basic pathology? Why this disease occurs? It is basically because of the excess of actin-myosin cross-linkage or cross-bridging. So normally when the muscle contracts, the bridging occurs and then relaxes. The relaxation is not possible. So there is going to be hypercontractility and impaired relaxation, and ultimately there is going to be poor compliance, and also it is going to cause left ventricular obstruction. This is something about the family history we all should be asking whenever you come across any patient who is having HCM, because there is a strong association, and you might have to ask a second generation because there may be something like a skip gene, so you may not be, one in between may not be having the disease. What normally pathology is, we all know it's a ventricular septal thickening, mitral valve dysfunction, and cellular changes. The heart failure is a common problem which occurs. Arrhythmia also is very common, and it can develop stroke also, especially when there is an atrial fibrillation. Sudden cardiac death also is not so common, but it is also that which we have to keep in mind. So symptoms of dyspnea, exercise chest pain, syncope, pre-syncope, dizziness, these are the common symptoms. Family history is usually there. As I have told, we have to ask third generation family history also. Physical examination, ECG ultimately can, echo is probably the most important thing. So whenever you come across a patient who is having this kind of symptoms, murmur, we know it is going to be a typical murmur, which is a diminished murmur when a patient is squatting compared to the standing, reduction in the murmur will be there. ECG is very, very classic. We normally come across, and we immediately come to the conclusion that this patient may have HOCM or probably HCM. Echocardiography, as I have told, is the most important thing. Left ventricular thickness assessment is important. The simple criteria is to diagnose when the thickness is more than 15 millimeter septal thickness, and if it is more than 13 and there is a strong family history, we can suspect that this patient can have auditory obstruction. Resting may not be there in every patient. Always remember that we have to do either Valsalva or exercise maneuver to precipitate the gradient. So that should be a part and parcel, because if that is not done, many times we miss the diagnosis. At the same time, if you just look at it, a left ventricular hypertrophy, if it is very significant, like more than 30, it is a bad prognosis. If you have ejection fraction less than 50, basically it carries a very bad prognosis. As I have told, evaluation of alveolar obstruction during precipitation or provocation is very important, like Valsalva, squatting to standing maneuver, and amyloid inhalation. And exercise also is very important. That is what we normally do in the resting condition. Ask the patient to do simple exercise and repeat the echocardiography specifically just to see the gradient. And if gradient is more, the diagnosis is HOCM is definitely clear in most of the patient. Up till now, we don't have a specific molecule for this. What we used to do, we are used to treat this patient by beta blocker, and there are some beneficial effects also, even calcium channel blocker. There is many times a tolerability issue, both of them. Disopyramide is the molecule which we're using, but it is not a very specific molecule. It is basically non-specific molecule. And most of the patients with this molecule, like beta blocker or maybe disopyramide, still have a refractory symptom, and their alveolar gradient may be high. So we really need something which is very specific about treating this disease. And that is the reason this is the molecule which has come up. What basically does is it target the basic pathophysiology or pathology of the HOCM. That is a cross linkage of actin and myosin bridge. And once it is reduced, then definitely hypercontractility will go down, and relaxation abnormality also will be normal.
Contraction. Researchers have traced the cause largely to the sarcomere, where too many cross bridges form between myosin and actin to generate excessive force during each power stroke. Current drug therapy options do not directly target the interaction of myosin with actin. The novel pharmacological agent mavacamten has been identified through a targeted molecular approach. Mavacamten is the first selective inhibitor of cardiac myosin. It has been specifically developed for the treatment of hypertrophic cardiomyopathy by targeting the underlying cause of the disease. Mavacamten stabilizes the resting state of myosin, which normalizes the proportion of myosin heads that can interact with actin. In other words, mavacamten converts excess myosin heads from the on state to the off state, thereby reducing the energetic burden on the heart. In this manner, mavacamten helps normalize the activity of the contractile proteins of the heart. Physiologically, mavacamten corrects the abnormal function of the hypertrophic heart to a more normal state. Research.
So this is basically just to demonstrate how the mavacamten basically act. And these are the data which are coming over last, I would say, 7-10 years, and the reasonable evidence that this is a benefit which really gives good long-term outcome benefit. This was the first study that was Explorer HCM, and where patients were randomized to those who are having NYHA class 2 and 3 with obstructive HCM. So it is only an obstructive HCM, this molecule is beneficial. Non-obstructive variety, it is not beneficial. And the composite endpoint, if you look at it, is functional class improvement and VO2 max after starting the therapy. And secondary endpoint was to find out what was the gradient which is reduced and what was the NYHA class improvement in this group of patients. And the same study, and the same study is basically extended on the long term to see whether the benefit of reducing alveolar obstruction persists over a period of time. This was the inclusion criteria. As you can see, obstructive HCM, thickness more than 50, gradient more than 50 at rest, and more than 30 with the Valsalva. And the documented ejection fraction more than 55. Patient is having NYHA class 2 and 3 symptoms. This was the primary endpoint. As you can see, those on mavacamten has significant better outcome as far as NYHA class improvement is concerned, and increase in the peak VO2 measurement. Alveolar gradient, as you can see, is significantly reduced. Look at the p-value, it is 0.001. The difference is almost 45 millimeters. So from its gradient baseline of average of 86, it has gone to 36, which was not there with the placebo. If you just look at how many of the patient has gone down to the less than 50 millimeter of gradient at the end of the therapy, so almost 74% the patient had gradient which has definitely gone down. So overall post-exercise alveolar gradient was significantly reduced by using this molecule. If you look at the VO2, as you can see, compared to placebo, there is a significant improvement, p-value of 0.006. NYHA class improvement, as you can see here, there is a significant advantage at the end of 30 weeks of the therapy. More than one NYHA class improvement was found in almost 2/3 of the patient using this molecule. And if you look at the overall patient, those who are in NYHA class 3, and at the end of the study, NYHA class 1 and 2, they were significantly high. The quality of life score also was much better after using this therapy, and patients were also feeling very comfortable even as early as week 16. NT-proBNP reduction also was significant, as you can see, which is a prognostic marker. It has gone significantly down. Even the troponin level also has significantly down after using this molecule. So mavacamten basically in this study has met the primary endpoint of symptoms and exercise capacity improvement and NYHA class improvement also. It also reduced the alveolar gradient and also the symptomatic life score also, there is significant improvement. As far as adverse effects are concerned, practically no major adverse. One of the adverse effect which is important is it may cause in few patients transient alveolar dysfunction, so we have to be very, very careful. And this is what has been observed over a period of long time. As you can see at the end of 30 weeks, most of the patient has slight reduction in the left ventricular ejection fraction, but by and large, they were all okay. This is a 5-year extensive study of the same study which was done. Primary study has shown the improvement. The purpose of this study is whether the long-term outcome beneficial effect which we have found at the end of 30 weeks persisted or not. So that has been basically demonstrated. As you can see here, the NYHA class improvement at the end of 3.5 years is significant, which has persisted, which was there at the start of the therapy. At the same time, the NT-proBNP, which has gone down initially, has also been persistently low throughout the period. Left atrial volume, which is an index of the beneficial effects of therapy, also was found significantly better with this therapy. Ejection fraction change those patients who has initial some LV dysfunction. Otherwise, all the patients have stable LV dysfunction, LV function later on.
5 minutes remaining.
So the key take-home message of this study was on the background therapy of beta. All the patients were on beta blocker or on calcium channel blockers or maybe on disopyramide, and they have addition of this therapy. And as you can see, we can optimize the dose within 24 weeks, and they have sustained improvement at the end of 180 weeks. So it's a long-term beneficial effects, and only few patients had transient left dysfunction. Otherwise, they were very well tolerated. The Valor HCM was another study where they were taken little high-risk patient or a severe symptomatic patient, and who were basically referred for surgical revascular therapy or something like a alcohol septal ablation. So they are more symptomatic patient, and the purpose of this study is to find whether the requirement for the surgical therapy has gone down after using this therapy. So almost similar sort of inclusion criteria, but here the patients are severe dyspneic on therapy, symptoms are not improved with this, and they were having slight high, and they were basically referred for either surgical therapy or alcohol septal ablation. And this is what the outcome at the end of 16 weeks. As you can see, many of the patients did not fall into the criteria of surgical correction in this group of patients. And as you can see, the LVOT gradient here also has been found to go down by almost 40%. The symptomatic improvement also was persisted at the end of 16 months. NT-proBNP also has gone down. So beneficial effects of the previous study were almost same, but the purpose of the study was whether the surgical need will go down or not. And change in ejection fraction, as you can see, is always maintained. So safety aspect, there is no major side effects except LV dysfunction, so we have to be a little careful when you start the therapy. But once it is stabilized, there is practically no case of having LV dysfunction later on. And as you can see, the same study was extended for 128 weeks. And here also the purpose was to find out that LVOT gradient, which has gone down, is persisted over a long period of time or not. The NYHA class improvement also has been persisted throughout the period of time. NT-proBNP, which has gone down initially in this study also, has been maintained basically for a very long time. Safety endpoint, as I have told, very few patients had to reduce the dose of mavacamten because of LV dysfunction, but otherwise it is a very well-tolerated molecule on the long run. So take our message, those patients who are referred for surgical therapy, myomectomy, 16 weeks and 128 weeks, all the parameters are much better when mavacamten was used in this group of patients. This is the guideline recommendation, 2024 European Association, and this, one guideline basically tells that we start beta blocker, and then you can either add mavacamten or you can add disopyramide or may opt for the surgical therapy. And other basically tells that along with the beta blocker, if beta blocker is not tolerated, straight away we can start the mavacamten because it is a very specific molecule. The dose titration is very simple and very easy. Normally we start with the 5 milligram. We expect gradient to go down, okay, to less than 20 within 4 weeks. And if it has gone down, then definitely we can down titrate. So that is how we normally do. We down titrate to 2.5 milligram and just follow up the patient. If the again gradient goes up, then 5 milligram should be the optimal dose for this patient. Otherwise, we can continue this patient on 2.5 milligram. And if the gradient has not gone down for 5 milligram, we can always increase the dose to 5 milligram to the higher side to get beneficial effects. 12 weeks is the time where we normally change. Up to 12 weeks, we continue with the same dose, mainly looking at the LV ejection fraction, which is very important because if ejection fraction is gone down, then definitely we might have to stop therapy for a certain period of time, or we might have to reduce therapy in this patient. So in general, mavacamten is an important definitive therapy which is now available in, I would say, Ahmedabad also, and which maybe in some patients we can use because beta blocker and calcium channel blocker, even disopyramide, are not a specific therapy. This is the first specific therapy which is acting on the basic pathology of the HOCM. Thank you very much.
Thank you very much, Chonul Bhai, for timely completing this wonderful talk. And I just invite the last talk, Professor Luca Bussetto. So there's going to be another interesting lecture on transforming the weight loss journey with semaglutide. Thank you.
Thank you. Thank you to the chairman for the introduction, and thank you for the invitation here. It's a real pleasure to be here in India. And my task is a bit difficult this afternoon because I need to move your
this audience from a very pure cardiologic environment to obesity management. This is quite different. But in order not to cause too much stress, I decided to concentrate my talk on the cardiovascular effect that semaglutide could have in your patients affected by heart disease and obesity. We know that obesity is a complex disease. It is associated with multiple medical problems. This is the most frequent one. One important point that need to be stressed in order to understand better the management of obesity is the point that several of these complications, what we call obesity-related complications, and in particular the metabolic and cardiac complication, they are not related so much to the amount of adipose tissue that the patient has in the body, but is much more related to the distribution and function of the adipose tissue. So you can have the same risk of cardiometabolic complication, both having very high BMI or having relatively low BMI level in the overweight range, but having the adipose tissue much more concentrated on the abdominal visceral level. And this is the reason why when in the European Association for the Study of Obesity last year, we decided to revise a bit the diagnostic criteria for obesity. This has been published in the Nature Medicine in 2024. We introduced the concept that when we diagnose obesity, we need to measure anthropometry, that remain important, but we also need to put together with anthropometry a full, complete clinical evaluation of the patients, looking at the medical, functional, and mental complication of obesity. And also we stress the fact that we have a fraction of patients represented by people with BMI in the overweight range, that they have high waist to height ratio, so they have abdominal fat distribution, and these people, if they already have some minor alteration in the metabolism, they should be considered at the same range of severity of people with high BMI. Because the problem today is that we stress the importance to treat obesity for large bodies, large people with severe obesity, but we neglect the importance of treating adipose tissue accumulation in people with overweight and metabolic complications that represent the majority of the patients. And the second important thing is that in those people, frequently we have a combination of diseases. So these people, they have higher rate of metabolic complication, but they have also higher rate of cardiovascular disease, higher rate of heart failure, higher rate of chronic kidney disease, and they have the liver problem. And the risk here is to skip the patients. Cardiologists look at the heart, hepatologists look at the liver, but nobody look at the whole patients. So we need to consider that we are treating the same individual from different angles, and we need to maintain a holistic point of view in building the treatment. Of course, obesity is a progressive disease. Here you have the different stages of the Edmonton Obesity Staging System, a system that we use for classifying obesity. And you move normally from a relatively normal clinical situation, what the Lens Commission called preclinical obesity, and then you evolve initial metabolic alteration, obesity-related complications, organ damage, and stage chronic disease. Of course, if this is the pathway, the aim of our treatment is to prevent the occurrence of complication, in one hand, and in the second hand, in the patients that already have the complication, we need to remit possibly or improve the complications. And this is the reason why we need something more than lifestyle modifications, in particular for the remission of complication. This scheme has been adopted by the European Association for the Study of Obesity last year. This has been published in October last year.
This is the first algorithm designed in order to facilitate the selection of the obesity management medications according to the patient's characteristics. And the algorithm is divided in two branches: body weight management in people with obesity without complications, and in case of the complications, their focus should be on the management of the complications itself. And weight loss is a mean for improving the complications, not the final aim of obesity management. Weight loss do not solve obesity. Weight loss control obesity as a disease. Weight loss is not the solution. Remember, this is important, because otherwise you cannot understand why we need continuous treatment. So the weight is gone, the problem is fixed. It's not true. The weight will regain if we don't continue to treat. And for the management of the complications, we divide the complications according to what we call fat mass diseases, so the diseases that are much more related to the amount of adipose tissue, like osteoarthritis in the knee or in the hips, and sick fat diseases that are much more related to the alteration of adipose tissue and its distribution. And here you have prediabetes, diabetes, but you have also cardiovascular diseases, heart failure, and liver diseases. And I will talk now specifically on the role of semaglutide in the management of cardiovascular diseases and heart failure in people with overweight and obesity. Let me start with the cardiovascular events. We have a very important study here. This is the SELECT. Maybe some of you you are aware. It was the first cardiovascular randomized controlled trial performed with an obesity management medications, in particular semaglutide 2.4, in people with overweight or obesity without type 2 diabetes, because we had the cardiovascular trials in people with type 2 diabetes, but we did not have any trial in people with obesity without diabetes. 70,000 people enrolled in the world, all people with previous cardiovascular events, so high-risk people, and the main results here, it was a 20% reduction in MACE in people receiving semaglutide as compared with people receiving placebo. Remember, those people, they are all people that already had a cardiovascular event, so they are receiving antiplatelets, ACE inhibitors, statins, and whatever you want. This is on top of the traditional pharmacological management of people with cardiovascular disease. One important point in these slides is that the two curves separate very early after the initiation of the treatment. Maybe you are aware that when you start to use semaglutide, you need to up-titrate the drug. You start with very low dose, and then you go up. So in the first week of treatment, there was no significant weight loss. And despite this fact, there was a significant reduction in cardiovascular events. This suggests that, at least in part, the cardiovascular effect of the drug is not related to weight loss alone. There is some suggestion that the part of the effect could be weight loss independent. So other mechanisms could explain. This is further suggested by this second post-hoc analysis, in which authors compare people having at least 5% BMI weight loss to people having less than 5%. These are the curve in placebo, and you can clearly appreciate that people having at least 5% weight loss in the placebo group, they have a reduction in cardiovascular events. But if you look at the curve in the semaglutide group, the two curves are superimposed. So no differences in the reduction in the cardiovascular events in between people having more than 5 or less than 5% weight loss. And this also suggests that we can have some weight loss independent effect here. The study in people with obesity without diabetes, of course, came after the several studies that we have with the semaglutide 1 milligram in people with cardiovascular disease and type 2 diabetes. This is the SUSTAIN 6 in people with type 2 diabetes and cardiovascular disease or chronic kidney disease. And the reduction in MACE is confirmed also in these patients. And this is SOUL, a study much more focused on the kidney in people with type 2 diabetes, cardiovascular disease, and or chronic kidney disease. And this is with oral semaglutide, and you have the same results. And finally, also in the FLOW, the kidney study with semaglutide in people with type 2 diabetes and chronic kidney disease, there was also a reduction in the MACE. So the reduction in the MACE is constant across all the long-term cardiovascular trials with semaglutide at different dosages. We have also some much more recent real-world data with data coming out from large healthcare database. This is the first one. The study was called SCORE. It was performed in people with cardiovascular disease and overweight without type 2 diabetes, and the author tried to match people using semaglutide 2.4 against people not receiving semaglutide with a propensity score matching, as typical in these studies. And the analysis of the data confirmed a reduction in the rate of MACE in people using semaglutide as compared with non-users in the real world. We have also the STEER that has been published 2 weeks ago, officially. This is the first slides. And again, people with overweight or obesity and without type 2 diabetes. Here you have the comparison in between semaglutide user and tirzepatide user, and the effect was in favor of semaglutide against tirzepatide in this real-world data. And finally, we have also some analysis, the REACH study, comparing user of semaglutide against user of dulaglutide, here in people with type 2 diabetes, and the results are in favor of semaglutide. So maybe semaglutide is a molecule with a specific effect on cardiovascular risk. And this is summarized here, but I think that I can skip this slide because you can read and it is very clear. What about heart failure? You are well aware that in people with obesity, the most common form of heart failure is heart failure with preserved ejection fraction. We have a lot of very good drugs for patients with heart failure with reduced ejection fraction, but until a few years ago, we did not have so much drug for the patients with preserved ejection fraction, apart the SGLT.
Thank you, everyone. And
this form is related to obesity, is part of the metabolic syndrome of people with overweight and obesity, probably related to chronic systemic inflammation, remodeling in the heart, and at the end, increased ventricular stiffness and cardiac dysfunction. And the clinical practice guideline for heart failure with preserved ejection fraction recommend multidisciplinary care in order to treat the cardiometabolic risk factor for this form of heart failure. And obesity is a risk factor for this form. So it was very reasonable to start a program with the GLP-1 analogs for the management of heart failure with preserved ejection fraction. And we have two studies. Here they are combined. The two studies with semaglutide 2.4, they are dedicated to people with obesity without diabetes, the first study, and people with obesity and diabetes, the second study. The design was very similar. Here you have the characteristics of the patients. Mean BMI was 37 in both the cases, so large people here. If you have the main results, change in body weight, more important in people without diabetes than in people with diabetes, as usual, because this is a very classical observation. But
5 minutes remaining.
the improvement in the symptoms questionnaire was clearly significant in both the study as compared with placebo. And we have also pulling the two studies together, the reduction in body weight, reduction in the symptoms, change in the 6-minute walking distance, change in the C-reactive protein, that is probably important in this disease, and looking at the combined population of the two studies, there was also a reduction in the rate of first event or cardiovascular death in the people, first heart failure related event. And the difference was mostly driven by the reduction in the hospitalization, new hospitalization for heart failure, or need for increasing the diuretic dose. And we have also some data on the modification of the structure of the heart, in particular the left atrial volume after management. So again, the results speak in favor of an effect of weight loss obtained with semaglutide in people with heart failure and preserved ejection fraction. We can discuss a lot here. It is metabolic, is it weight loss dependent or weight loss independent? Probably here weight loss count much more than in cardiovascular disease, probably, at least in my opinion. But this data has been demonstrated also in other studies looking at, in particular, the SELECT or the FLOW. In the cardiovascular outcome study, we observe also a reduction in the rate of heart failure-related events. So again, we have a consistency of the results across the study. And these are my conclusion about the heart failure part of the talk. So I think that I can stop here. In Italian, we say, grazie per l'attenzione, thank you for your attention, and I will be happy to receive questions eventually. Thank you again.
Thank you very much, Professor. So we'll end the session here and we'll take a few questions. Sir, we have mic there. Is Bhavin Bhai around?
Yeah. My question is to Milan Chak, sir. Sir, in today's era, nobody wants to undergo surgery. Everyone likes the transcatheter guided treatment. Like nowadays, TAVR is very famous. Sir, we have not heard much about the transcatheter mitral valve replacement that you have shown in today's lecture, your slides. Sir, the long-term outcomes are, it is same as surgical repair and surgical replacement. And if a young person doesn't want to undergo surgery and want to undergo this transcatheter treatment, then can we recommend them to them?
So it's a very good question, important question. See, the transcatheter valve, which I just saw, was failure of surgically implanted bioprosthesis. It was not native valve of the patient himself, right? For aortic valve, which is a calcified aortic valve, where we can implant the TAVI valve, transcatheter heart valve, which is either balloon expandable or self-expanding, in a native valve. Now, trials are going on with native. See, mitral anatomy is very peculiar. It is an oval orifice. It has papillae muscles, subvalvular apparatus going right up to the LV cavity, and this is a very complex structure. So when you implant a valve, everything will come on the way. And being a oval structure, valve will not fit also there. And in aortic valve, where we are implanting the valve, the stent is holding there because of calcium. So stent, that metallic frame and the calcium, they interact with each other and it does not allow it to get popped out during every heartbeat. In mitral, that is not possible because it's a native tissue. It is not always a calcific valve. So in that case, transcatheter specific type of valves are under investigations. They are not yet commercially available, but in USA and in some European centers, native mitral valve replacement by peculiar shaped valve is being studied. They are still under trials. Their initial results are good, so maybe in next 2-3 years, it will be available commercially. But what I showed was a biological valve where oval valve was converted to a rounded structure. There was a base of the surgically put valve. Inside that valve, now I can put my round balloon expandable valve, and that is what I put in mitral valve, and last case was tricuspid valve also, which was the first time in Gujarat. So that was also failed surgically put biological valve. Any valve you put, biological valve will last in average 10 years or so, not more than that. Whether the surgeon puts or we put, is same, 10 years or so. So if patient is relatively young, you put, say, at age of 50, he says that I don't want surgery. If you put at 45 or 50 years of age, aortic valve, after 10 years, again you put another valve. So metal, valve in valve, will be too much of metal around that. And in aortic valve, you have to think about coronary flow also, which goes between the frames of that diamond of the transcatheter heart valve. Blood flow goes to coronary through that coronary sinuses. So if you put too much of metal there, then again you have to think about coronary flow also. So that is one-time treatment. You think of lifetime treatment for the aortic valve. So you try to avoid at a later age. You put at 65, so maybe for 10-15 years it lasts, and that's all for the patient. So usually in younger patient, we still put surgical valve. If it's less than 55 years of age, it is metallic valve. If it is more than 55 years of age, surgically put biological valve. Later on, when it fails after 10-15 years, we put a transcatheter heart valve. So it doesn't need second open heart surgery. So mitral is still under investigations for native valve. Yeah, that is simple because it is less risky also. It goes without surgery. And if it is biological valve, if it is a metallic valve, suppose somebody had a mitral valve replacement in a young age, 25 years of age, and it's a metallic valve, then if it fails, then you have to do repeat surgery. You cannot put valve in valve for a metallic valve. It is only for biological valve. Yeah, that is a good question. I mean, it can last if you keep your INR well throughout that. I've got some patients in follow-up for 40 years. Somehow ball and cage valve, I have one patient is there for 50 years. 50 years ball and cage valve. It is not now being manufactured also. I don't know, surgeons are here. Dawalbhai is here. Dhirenbhai is here. Dawalbhai is here. So, but I mean, that is history. Many of you are not born even before 50 years. But I have got some patients who are in follow-up. 2 patients are there with ball and cage valve with 50 years, 45, 50 years of follow-up. And at that time, possibly INR, it was not needed that much INR, I think, for ball and cage valve, which is not being manufactured. Metallic valve, tilting disc valve, bileaflet valve, durability is good if you keep good INR. Any comment by Dawalbhai, Dhirenbhai for a metallic valve?
Yeah,
durability.
so that ball and cage valve was been outdated due to a couple of reasons. It was a very high profile valve actually. It was too bulky. So we have now a very less profile valve. And there was a high chances of thromboembolism in ball and cage valve, which is now less with this pyrolylated carbon, these all valves. So there are 2 reasons. And as I said, guidelines say, if a previous MVR, tissue MVR, if it is more than 65, if patient is high risk, by certain means like old age or some lung issues or acute or CKD kind of things, where the second or redo surgery is high risk, then TMVR is indicated. So younger age, as he said, mentioned, if you do TMVR or TAVR, if that valve generates, it is very difficult to remove that valve by somehow if we cannot do valve in valve. So that scenario is not yet come in India. So indication of the procedure, surgery or anything has to be very stringently justified. Yeah. Thank you.
Sir, any difference between the oral semaglutide and injectable by result or anything?
Any difference in what outcome? Because, of course, oral, oral versus subcutaneous. It depends from which outcomes we are considering. Of course, in order to obtain the same level of weight loss, we need to use higher dosages of oral semaglutide than what we do subcutaneously. It's very high doses because the absorption is much more complicated. But in people looking at the cardiovascular effects, in people with obesity and type 2 diabetes, we have the cardiovascular outcome trial with oral semaglutide demonstrating a significant reduction in the rate of cardiovascular event as we had in using the subcutaneous injection in people with type 2 diabetes. At the moment, we do not have yet a cardiovascular outcome trial with oral semaglutide in people with obesity, without type 2 diabetes. This is what we have at the moment. Hello. Oral semaglutide 25 milligram per day will be soon on the market, I think, next year.
Yeah, thank you, Dr. Luca, for your wonderful presentation. One point, like you showed in patients who had obesity and ASCVD, the graph started separating early as far as future reduction in MACE is concerned, even almost before the genuine weight loss was apparent. And you mentioned there is likely chance of some effect beyond weight reduction. So every new molecule comes, this is always a feature behind that when statin came, it's something beyond LDL reduction. When SGLT2 comes, SGLT2 inhibitor comes, it's something beyond sugar reduction. So what are the probable mechanisms by which it is working beyond weight loss? I know there is some hsCRP reduction in the trials, so it might be working on inflammation. The effect on hsCRP, is it beyond what you see when you correct HbA1c and obesity, or it's because HbA1c correction and obesity correction, hsCRP has gone down?
I think that the effect is related to the local action of the drug. So we have GLP-1 receptor on the arterial wall, and in particular we have GLP-1 receptor in the fat surrounding the coronary artery, not in the adipocytes, but in the inflammatory cells that are inside the inflamed adipose tissue around the coronary artery. And we have some mechanistic study in animal model of atherosclerosis demonstrating that the infusion of the GLP-1 can reduce the inflammation at the level of the arterial wall. This is probably one of the most important mechanisms explaining the direct action. And this could also explain why different GLP-1 receptor agonists, they could have different effects, because the effect could depend from the local interaction in between the drug and the receptors at the different site in the body. We have GLP-1 receptor agonists not producing weight loss, despite the fact they are very good in reducing glucose levels. Dulaglutide is a very good example, because for weight loss reduction, you need the action at the level of the central nervous system. This could be probably the same at the level of the arterial wall. Depends from the distribution of the molecule, the interaction with the receptors, how much drug arrive in the right place at the end.
Thank you. I think we'll wind up the session here. And I invite chairperson, moderators, and panelists for next session. Dr. Alkesh Patelia, Dr. Dinkar Goswami, Dr. Iles Mehta, Dr. Kaushal Jani, Dr. Mahesh Dayalani, and Professor Lukwan Gal. Moderators Dr. Bhagirath Solanki, Dr. Hitesh Parekh, Dr. Jayant Mayavansi, Dr. Mahesh Sanghvi sir, and Dr. Varis Contractor. And I request Dr. Hiren Kevadia and Dr. Tejas Patel to be a panelist. I also request everyone to visit once post-op presentation area to encourage junior doctors. Actually, they're doing wonderful job there. Thank you.
Now we are in the last session of this afternoon. I'll request straight away to Anish Bhai. Please come and start with your nice lecture. एक बार सबको हंसा दो तो उन सबकी नींद खुल जाएगी.
ऐसा है? नींद भगानी है, चलो भगा लेते यार. हो जाते हैं खड़े.
Yes, let's all stand up.
Let's all stand up. All those who can and who wish to, spread your hands. Have a great laugh.
अब कोई नहीं सोएगा सर.
चलो अच्छा है. बाकी सर मान रहे थे मेरे लेक्चर में लोग सो जाएंगे. Thank you and good afternoon. It's always pleasant to talk to the doctor friends who have been trusting us for so many years and learning a lot of good things. I'm very happy. I mean, since yesterday morning, myself and all the colleagues of mine have been attending this conference fully well. Even we are cardiologists, but we attended internal medicine session yesterday, and we all feel happy to learn how the internal medicine field has grown up. So my talk in next 14-15 minutes is to understand what is heart failure with relatively preserved ejection fraction. That is either ejection fraction is more than 50, 55, 60, or people who have got sort of mildly or moderately reduced ejection fraction that is between 40 to 50. Why it is important to understand is, number one, we generally do not give too much significance to these people. This patient might have come to you with symptoms of heart failure, but the moment you get echo done and ejection fraction is 60%, perhaps you lose that sensitivity and sincerity towards patient कि ठीक है, इसको कुछ ज़्यादा problem नहीं है. So it's important to understand that these people need a lot of attention. So heart failure basically is divided into three parts as far as ejection fraction is concerned, and it's very important to understand them on the perspective of ejection fraction. Let me get the pointer. Screen, pointer. So those people who have got ejection fraction less than 40%, it is HFrEF, heart failure with reduced ejection fraction, that is well known. And that's where the treatment is well established. That's where the diagnostic pathways are well established. Then comes a group of people who have got heart failure with mild reduced ejection fraction between 40 to 50%. And then there comes a group who have got ejection fraction more than 50%, but they have got heart failure based on symptoms and signs and based on certain evidences which suggest that there is diastolic heart failure. So there are evidences of diastolic. What are they? You can find on echo, see there is increase in LA size, there is increase in LV mass, and then if you go for Doppler studies, you find that there is restrictive filling pattern of left ventricle. So echo can tell you. Other is BNP or NT-proBNP. Generally, we use NT-proBNP more because BNP is influenced by presence of ARNI, which is a well-used medicine in today's world. So that's why we go for NT-proBNP. So if NT-proBNP is beyond certain limits, say for example 3 to 5 times more than upper limit, then they are the people who got diastolic heart failure. So heart failure can exist with all the ejection fraction. So there is a case, this is a lady, 70 years, she has got HFpEF and CKD. She has got HbA1c of 5.9%, blood pressure is stage 1, 131/85. Ejection fraction is reasonably well maintained. She has been having class 2 to 3 dyspnea. EGFR is 45, USER is 150. So she has reasonably advanced CKD also. And she has been put on right medicines, ACE inhibitors, SGLT2 inhibitors, and diuretics to take care of congestion. So once you have studied this case, and I'm very sure you all are seeing such patients on day-to-day basis. So before we go further, let me understand where is your level of knowledge at the moment as far as HFpEF is concerned. So following is true for HFpEF. Only one sentence is correct, rest everything is wrong. Point 1, HFpEF patients are often misdiagnosed or diagnosed late. Number 2, HFpEF patients who need admission for heart failure have equally bad prognosis like those with HFrEF. Number 3, there are not many medicines for HFpEF which can improve the prognosis. Number 4, all of them are true. Number 5, all of them are wrong. You have to pick up only one option. Your time starts now. Can I have timer? Is timer working inside? Yes. So house is divided. Let's see. In fact, all these 3 statements are correct, and let's study them. Number 1, if you look to the world's data, this is HFpEF, this is heart failure with MR, mildly reduced ejection fraction. This is heart failure with severely reduced ejection fraction. So if you look to the year by year, now number of patients who are getting admitted with heart failure in the Western world, HFpEF is increasing. India still scenario has not reached the level. We still have more patients who have got HFrEF and getting admitted. But if you look to your past 2 to 3 years, now you are seeing more and more patients of HFpEF and they are getting admitted. So we are not much behind the Western world's. HFpEF basically a situation of heightened inflammation in the body, and it's a condition where there are so many comorbid conditions exist: obesity, obstructive sleep apnea, CKD, etc. And we, India being capital of all these diseases, we are going to see a very high number of such cases. Now, very important point, and which is I would like to pay a lot of attention to, once a patient has been admitted with heart failure, irrespective of ejection fraction, prognosis is similarly bad. So somebody who got admitted with EF of 55 and gross heart failure has equally bad prognosis as somebody who had ejection fraction of 30%. So we as physicians have to be very, very clear that EF is not everything as far as prognosis of heart failure is concerned. And then if you look to the need of recurrent admission, that is also equally high. So once there is heart failure, EF as a figure loses certain importance as far as prognosis is concerned. Now, if you look to the treatment across the world, just look at on this line. For HFrEF, we have got at least 4 good molecules which reduce mortality. So ARNI or ACE inhibitors, MRAs, you know that, SGLT inhibitors, beta blockers, and now we have got 5th pillar also, that is very Vericiguat. I personally use quite frequently, is a wonderful drug. If you look to the heart failure with ejection fraction between 40 to 50 or more than 50, there are hardly drugs. At the moment, if somebody says that, which is the drug which has got data and evidences that it improves mortality, it's only one, SGLT2 inhibitors. So till this trial, which I'm going to discuss, it was just 1 SGLT inhibitors for people who have got more than 40% EF or more than 50%. Having said that, at least up to 50% EF, even between 40 to 50, we use the 4 pillars. You know that, because we do not stop using them. Somebody who had EF of 30 now improves to 45, don't stop using all those 4 pillars. So between 40 to 50, we do use 4 pillars, but if you ask me, are there any trials of these 4 pillars between 40 to 50% EF? They are not there, because all the trials of 4 pillars took patients of HFrEF with ejection fraction less than 40%. So in fact, really, we do not have strong trials, but we use them. But as far as more than 50% EF is concerned, we have a lot of darkness. Now, if you ask me what are the best trials for people with HFpEF, then we have got EMPA and dapagliflozin trials, which you have studied for last 5 years. Now, if you look to the Emperor preserved or delivered, that is DAPA preserved, so when you use empagliflozin or dapagliflozin as compared to placebo, you reduce risk of mortality and admission to heart failure. So we know that it reduces, absolute risk reduction is also there 2 to 3%, which is very good. But still, if you look in the EMPA or DAPA arm, still large number of patients are left to their destiny. They can have variety of events. You have not solved the problem of HFpEF. So that's why we need a drug which works beyond SGLT2 inhibitors. So at the moment, we believe in people who have got heart failure with ejection fraction more than 40%, it is the mineralocorticoid receptor overactivation triggered by RAS that's working. It leads to sodium and fluid retention, inflammation and fibrosis, hemodynamic alteration, leading to hypertrophy of vascular tissue and cardiac tissue, and so leading to fibrosis in the heart and fibrosis in the kidney. So it's basically MR overactivation leads to fibrosis, that is replacement of functional organ tissue by a tissue which cannot work, rather which impairs the performance of the organ, which is called as remodeling. So we know that we have got 2 molecules in the field. One is spironolactone and one is eplerenone. Both of them have been well tested in HFrEF. So anybody who has got heart failure with ejection fraction less than 40%, you use either spironolactone or eplerenone. Now a third MRA has come, and that is Finrenon, which is little different than rest of the two. Potency-wise, it is as potent and as strong as spironolactone. Eplerenone is a little weaker drug. It's basically a non-steroidal agent. While your two existing drugs, that is spironolactone and eplerenone, are steroidal, while this is non-steroidal. And the biggest benefit being it's non-steroidal, it is more specific for MR, and that's why sexual side effect, that is gynecomastia, etc., does not happen with Finrenon. Half-life, if you look, it is short, and that's why literature says that it causes less hyperkalemia as compared to spironolactone. And there are no active metabolites. It is a drug by itself. And if you look to the approved indication of spironolactone and eplerenone at the moment, it's HFrEF. While if you look to the Finrenon, it is extremely well established in diabetic CKD with proteinuria, extremely well established, and now it's going to be established in people who got heart failure with EF more than 40% or 50%. So if you look to the fidelity, this data has been discussed in nephrology platform, a wonderful combination of trials where they picked up patient who had type 2 diabetes with CKD stage 1 to 4 with USER more than 30. So these are typical diabetic patients irrespective of presence of or absence of ASCVD or presence or absence of ejection fraction, whatever. What was found is renal endpoints improve and cardiac endpoints improve. So when you use Finrenon in people who have got diabetes, kidney disease with proteinuria, it's going to not only improve renal outcomes, it's not only going to reduce further deterioration of GFR, it's not only going to reduce need of dialysis and transplant, but it is also going to reduce risk of heart failure, 3-point MACE, and need of admission. And we all know that diabetic CKD patients die because of cardiovascular cases and not because of the kidney. So you need to prevent cardiovascular endpoints. So there was a wonderful trial which got published before 1.5 to 2 years called as Fine Arts HF. This is Finrenon in people with heart failure with ejection fraction 40% or more. So 40, 45, 50, 55, 60, 65. And what was found is as compared to placebo, when you give Finrenon, there is significant reduction in cardiovascular death and total heart failure events, and absolute risk reduction was close to 3 per 100. So if you treat 100 patients for 1 year, you are going to prevent 3 events in terms of either CV death or need for admission. And as was suggested for the semaglutide in previous trial, here if you look, the graph started separating within first month only. So that's why what we talk that every heart failure patient, maybe HFrEF or HFpEF, introduction of all these medicines which change the disease trajectory should be done as early as possible. So once you start Finrenon, within 1 month, it starts being active as far as clinical outcomes are concerned. So if you see a patient of HFpEF today, and if you wait for Finrenon to be started for 3 months, you already lost the time. You have to start it today upfront so that your patient starts getting benefited. Now there are 2 drugs which can be used in people with ejection fraction more than 40%, which has got strong data. One is your SGLT2 inhibitors, no doubt, and second is Finrenon. So when you combine both of them, rather than placebo, if you combine both of them, it adds almost 3 to 6 years of event-free survival. So now for the first time, you've got 2 molecules for HFpEF patients where if you use them, you are going to improve their quality and quantity of life. Little busy slide, but I would just take you through very fast. So whether if you add Finrenon to HFpEF patients who are receiving SGLT2 inhibitors, does it work? It works. When you start Finrenon in patients with HFpEF, it reduces future risk of diabetes. When you start Finrenon in people with HFpEF, it reduces future risk of atrial fibrillation. It works across all the ejection fraction, maybe 40, 45, 50, or 60, and overall safety and effectivity balance is quite good. The biggest problem is how to use Finrenon in this patient. So there are 2 groups of patients where you will start Finrenon. One is diabetic CKD with proteinuria, USER more than 30, and second is all heart failure patients whose ejection fraction is more than 40%. The first rule, do not initiate if potassium is more than 5. So that is first rule. You check potassium. If potassium is more than 5, get it lower by various methods, and then only you can start, otherwise no. And check EGFR.
2 minutes remaining.
If EGFR is less than 25, you do not start. So these are 2 big no's. Potassium more than 5 and EGFR less than 25, don't use. Now if your EGFR is 25 to 60, start with 10 milligram. Your plan is to go to 20 milligram once a day. If eGFR is good, more than 60, start with 20 and your plan is to go to 40. So based on eGFR, you start the dose and build up the dose. And what you have to do, at 1 to 1.5 or 2 months, you have to repeat the potassium. If potassium remains less than 5, you build up the dose. If it's potassium between 5 to 5.5, stay at the same dose. You cannot build up the dose. If potassium has gone more than 5.5, you have to reduce the dose or stop the dose and have to work on hyperkalemia. So eGFR and potassium are very important. This way you can titrate. So ladies and gentlemen, now for the first time, if you look to the various guidelines of the world, this is international guideline, this is Japanese guideline, all of them have started putting Finrenon as number 2 molecule as far as HepPEF is concerned. So for HepPEF, SGLT2 inhibitors, DAPA 10 mg or EMPA 10 mg, and second is Finrenon. When you use DAPA and EMPA, they give additional benefit in terms of they do help to reduce hyperkalemia. So what is the carry-home message? HepPEF patients are high-risk patients and there are not too many proven treatment options. MR overactivation is the key as far as HepPEF with ejection fraction more than 40% is concerned. Finrenon, which is an NSMRA, non-steroidal mineralocorticoid receptor antagonist, has got distinct physicochemical properties than your existing MRAs. Finrenon at the moment is the only approved MRA in the world to treat patients with HepPEF who have got ejection fraction more than 40%. And believe me, people who have got HFmrEF or HepPEF are serious and they should be helped by these 2 molecules in addition to taking care of overall scenario. Thank you very much.
Thank you very much, Anish Bhai, for your nice understanding of the topic. And now I'll request Hiren Bhai to please come up for his talk.
So I'm again having a presentation on ECG. So how do I evaluate a case of non-sustained VT which I detected on ECG or Holter or anywhere? So I don't have any disclosure. So case number 1 is a 50-year male with frequent palpitations. There are runs of NSVT and they are all monomorphic NSVT, all right? And case number 2 is a 40-year lady with frequent palpitation. Again, she's having NSVT on ECG, and here they are not looking single morphology, they are polymorphic NSVT. Case number 3, a very young girl, 20-year girl with frequent palpitation and Holter detected NSVT. It's a very rapid NSVT at the rate of almost more than 250 beats per minute. And it is a monomorphic NSVT. So these are 3 cases. Now, how will I evaluate these cases? So let us discuss about it. So number 1, history, family history, and physical examination is always having a critical role whenever we see any case with the arrhythmias. Number 2 is a 12-channel ECG. Number 3 is an ambulatory ECG if required, which can be having a 12-channel or a single channel that is known as loop recorder. Can have a stress ECG, that means treadmill test. Can have an imaging in form of either echo, cardiac MR, FDG PET, SOS biopsy. Number 6 is a genetic study whenever required. Case number 7 is EP study for restratification. And obviously angiography to rule out ischemia. So let us discuss all the points one by one. So what is important in history, family history, or physical examination, we should always remember the red flags. So whenever a patient has history of syncope and you have noted a non-sustained ventricular tachycardia, very important, it's a red flag sign. Absence of vagal prodrome, whenever a patient has syncope without prodrome and there is a sudden transient LOC without any prodrome is a warning sign. If patient is having a family history of premature sudden cardiac death, heart failure, cardiomyopathy, or family history of having a pacemaker implantation, again, it's a red flag sign. On auscultation, if we are able to see any murmur on the left parasternal border, a mid-systolic murmur, which can be suggestive of hypertrophic obstructive cardiomyopathy, or if they're having a mid-systolic click, suggestive of mitral valve prolapse. So these are all warning signs in a case who had a non-sustained VT. So why do we go for a 12-channel ECG? A resting ECG is important to look for primary electrical disease. that is either a Brugada syndrome in form of Brugada pattern, or they may be having a long QT interval to suggest long QT syndrome, or for diagnosis of underlying disease like hypertrophic cardiomyopathy when baseline ECG is showing LV hypertrophy with significant repolarization abnormality, ARVD where patient has a right bundle branch block in V1, ischemic cardiomyopathy we can find out the Q waves, then underlying conduction system disease we can see for bundle branch blocks, AV blocks, or a fascicular block in 12-channel ECG. And what's the importance of non-sustained VT analysis on ECG? We want to look mainly for the morphology of tachycardia, and that morphology will tell us about the localization from where the NSVT is coming from, and to look for whether they are monomorphic or polymorphic. We can look for the coupling interval of the NSVT, what was the coupling interval of the first beat, and third is the cycle length, that is whether this NSVT is fast, that is more than 200 beats per minute, or they are relatively slow NSVT. So case number 2, where she had a polymorphic arrhythmias and her ECG is showing a baseline conduction system disease, that is right bundle branch block. So this patient is having a right bundle branch block in form of conduction system disease and had a ECG which is showing polymorphic arrhythmias. So what is the importance of that? We'll see into the next slides. So the morphology of NSVT will guide us whether these NSVTs are whether idiopathic non-sustained VT is coming from the routine outflow tracts or from papillary muscles or from fascicles or mitral annulus. And if the PVCs are not fitting into any of that criteria, that means that these PVCs are not idiopathic, they are having probably associated structural heart disease. So that's how the localization of the NSVT will help us whether these PVCs are idiopathic or having a dangerous structural heart disease associated with it. Second thing, in NSVT morphology, if your PVCs are having single morphology or if they are pleomorphic, so obviously the pleomorphic PVCs are having a bad prognosis and monomorphic PVCs are having relatively better prognosis. So that's how the morphology help us. Then second most important part is coupling interval of the first beat, whether it is a PVC or whether it is a PVC followed by NSVT. We should always look at the coupling interval, whether it is a short couple PVC or whether it is a long couple PVC. So the long couple PVC usually falls beyond 300 millisecond and short couple PVC usually falls very early, like in this ECG. And that short couple interval PVC can fall on T wave, it fall on peak of the T wave and can lead to R on T phenomenon. And the short couple PVCs can ultimately lead to idiopathic VF. That means that short couple PVC is triggering polymorphic VT, degenerating to ventricular fibrillation and sudden cardiac arrest. That is the most common mechanism of idiopathic ventricular fibrillation, where patient does not have any significant past history, they have structurally normal heart. So what is the role of ambulatory ECG? So ambulatory ECG we do when we want to look for overall arrhythmia burden. That means that a single ECG is showing NSVT or a single ECG does not show NSVT, that does not carry any meaning of burden point of view. So I would like to look for the overall burden of arrhythmia throughout a day or night, maybe for 2 days, and sometimes for 5 to 7 days also to look for the burden. And second thing, it will also tell us about the cycle length of the NSVT during Holter, whether they are rapid or whether they are slow. And very important part, patient can have a circadian fluctuation in arrhythmias. During nighttime when there is more vagotonia, PVCs might get suppressed, or some patients can have a PVCs throughout night and day also. So those patients who have PVCs throughout day and night were having a bad prognosis, and those patients who have PVC more during daytime and nighttime, they reduces. It is associated with the better prognosis. So like in these patients where 12-channel Holter was done, where the patient was getting frequent arrhythmias, so by looking at the 12-channel ECG, we can see the first beat of that run, which is inducing the arrhythmia. That will help us to localize from where these PVCs are coming. So here the PVCs were coming from fascicles in post-MI patients, and that PVCs were falling on R on T and were causing polymorphic VT. So if we go and find out that location of PVC and do ablation of that PVC, we might get rid of this polymorphic VT also, and that's how this patient was also managed. Number 4, what is the role of doing exercise ECG? That is treadmill test. So whenever a patient tells that my symptoms are more related to exercise or physical exertion, in that case is to find out the reason for exercise-related symptoms, exercise ECG is very important. So that will help us in correlation of symptoms also during exercise by documenting arrhythmias during exercise. So that will help us for adrenergic dependent arrhythmias also. That will help us for monitoring therapy also. Once we start the therapy, we can again subject the patient to stress ECG and see whether now the arrhythmias are coming or not. If the therapy is in an effective dose, then ideally the arrhythmias should not happen again now with the stress ECG. So that helps us in identifying, evaluating the response to therapy also. And if the patient is having exercise-induced NSVT, definitely this patient had a poor prognosis compared to those patients where NSVTs are getting suppressed during exercise. So they are having good prognosis. So let us see one example, a treadmill test, a baseline ECG is normal, sinus rhythm, but when the patient is going for exercise, on stage 2 itself, patient is starting arrhythmias. So these are the arrhythmias which are adrenergic sensitive and they are coming more during exercise. This patient is having a poor prognosis compared to those patients who get suppressed. So these patients should be treated very meticulously to avoid sudden cardiac death because of arrhythmias during exercise. Then what is the role of echo? Obviously echo we look for mainly ventricular function, LV function or RV function. We look for the valvular heart disease. In valvular heart disease, more important here from arrhythmia point of view is mitral valve prolapse. And when the mitral valve prolapse is associated with mitral annular disjunction, where annulus is having a distance from the ventricular end of the muscles, so the mitral annular disjunction patients are at more risk of getting ventricular arrhythmia. So all mitral valve prolapse are not benign. There are some of the substrates, subgroup of the mitral valve prolapse disease where there is mitral annular disjunction also. These patients are at a very high risk of getting ventricular arrhythmias and sudden cardiac arrest. We should always look at meticulously in all MVP patients whether there is mitral annular disjunction or not. And second, obviously, we can look for other cardiomyopathies like hypertrophic cardiomyopathy, ischemic cardiomyopathy. Very important is arrhythmogenic RV cardiomyopathy, where it is very important to meticulously look at right ventricle particularly, because left ventricle might look completely normal. And if we don't look at RV properly, we might miss the RV cardiomyopathy. That is isolated right ventricular involvement, that is known as ARVC, and ARVC patients are at risk of getting exercise-induced ventricular tachycardia, and these patients are at risk of getting
5 minutes
sudden
remaining.
cardiac death because of it. Number 6 is again an imaging in form of cardiac MRI. So cardiac MRI, sometimes in echo we think that heart looks normal, but it may not be actually. So macroscopically heart is normal by echo, but when we go for a MRI, we have seen that echo looking normal, but MRI is showing significant abnormality. So MRI is equally very important. It helps us in detecting myocardial edema and myocardial scar and fibrofatty infiltration. Sometimes in hypertrophic cardiomyopathy, aneurysm might get missed in echo, but obviously MRI is going to pick it up. And obviously in mitral valve prolapse, where there is mitral annular disjunction, to look for the mitral annular disjunction and to look for the scar also, MRI is very important. This is number case 2 with a pleomorphic PVC with a baseline ECG showing right bundle branch block. When the MRI was done for this patient, it was showing significant myocardial edema, and we can see significant patchy scar in the muscles in left ventricle. So these are the patients who are at a very high risk of getting sudden cardiac arrest and death because of sustained arrhythmias. And this is mitral annular disjunction syndrome, where there is a mitral annular disjunction. And when we go for a MRI, we can see the infralateral wall having late gadolinium enhancement. So obviously these patients are again at a risk of getting cardiac arrhythmias which are sustained and lead to cardiac arrest and sudden cardiac death. Again, an imaging, the cardiac FDG PET scan. Now, what is the role of cardiac FDG PET scan? So whenever a patient has a baseline conduction system disease on ECG in form of right bundle branch block, left bundle branch block, or a fascicular block or a AV block, and having a pleomorphic PVC, that means that this morphology is not suggestive of arrhythmia which is idiopathic. In these cases, it is very important to rule out inflammatory cardiomyopathies. So inflammatory cardiomyopathy, we have to look for the active inflammation, and that can only be detected by doing cardiac FDG PET. Like in this patient, again, this is case number 2 with a lady with a pleomorphic PVC, pleomorphic NSVT, who had a baseline right bundle branch and cardiac MRI showing myocardial edema and scar. When the PET scan was done for this patient, it was showing a myocardial involvement also. Lateral wall was having a hotspot, and at the same time, mediastinal lymph nodes were also enlarged, and it was suspected to have a cardiac sarcoidosis and not to be ruled out the tuberculosis also. And ultimately, we went for a biopsy also for this patient because there was a lymph node. We can always go for an EBUS transbronchial biopsy, and when we took the sample from there, it was showing non-caseating granulomatous inflammation, and that's how it was confirmed to be a cardiac sarcoidosis, and therapy of choice should be immunomodulators, steroid therapy and steroid-sparing immunomodulators for the permanent remission of the sarcoidosis. Number 8, role of EP study. So EP study here is mainly for the diagnosis in form of a VT induction study, where we try to induce the ventricular
2
arrhythmias.
minutes remaining.
And if we are able to induce ventricular arrhythmias, then probably this patient is at risk of getting sudden cardiac death. This is mainly done for those patients who have myocardial infarction with an ejection fraction which is less than 40%, but not fulfilling criteria for AICD implantation, but they have a ECG which is showing NSVT. Go for EP study, induce the VT, and if his VT is getting induced, this patient should definitely go for AICD for prevention of sudden cardiac death. And the last investigation is a genetic testing. So when should I go for a genetic testing? So whenever we have any young patient with unexplained arrhythmias, unexplained sudden cardiac arrest, unexplained near drowning, or recurrent exertional syncope, and those patients who don't have ischemic or other structural heart disease on echo, these patients should go for a genetic testing, especially like a long QT syndrome, CPVT, idiopathic VT, VF, especially non-ischemic cardiomyopathy where the age is less than 40 years and they have a family history which is strong for having an early disease. This patient should always go for a genetic analysis also. And the case number 3, a 20-year girl which I had seen where there was a rapid paroxysmal palpitation and the Holter was showing a very rapid NSVT at the rate of more than 250 beats per minute monomorphic. When I went for the genetic analysis, she had a desmoplekin cardiomyopathy. It is not uncommon, and her younger brother also had the same palpitation, and I have not gone for yet genetic analysis for him, but probably that is again a genetic cardiomyopathy. So genetic testing is equally important, especially in young patients and having a significant family history. So that's how I go for evaluation of my case of NSVT. It needs basically a systematic evaluation of arrhythmia, not only from the focus point of view, from the prognosis point of view, and that helps us in getting a better decision to prevent sudden cardiac death for such patients. Thank you.
Thank you, Dr. Eden. For the next talk, I would like to invite Dr. Hemang Bakshi, and his talk is ferric carboxymaltose, emerging pillar in the heart failure management. Meanwhile, I would request Dr. Professor Luqman Gal also to come on the dais. He's the chairperson for the same session.
Good afternoon, friends. So I will be talking on this ferric carboxymaltose. So, dear friends, we know that heart failure burden is increasing in India, and you can see that millions of people are affected with heart failure. And the most worrisome point is the Indian heart patients are affected at relatively younger age, and they have got high morbidity and mortality, and worsens quality of life in hospital and also after discharge as compared to the Western counterparts. And 2021 update to the 2017 ACC expert consensus decision pathway for optimization of heart failure answers to 10 pivotal issues about the heart failure with reduced ejection fraction. And one of the important thing they have mentioned is common cardiovascular and non-cardiovascular comorbidities with suggested action. And as you can see, of these common non-cardiac comorbidities, iron deficiency is listed here, which has got a strong association with heart failure outcomes and has got intermediate clinical trial evidence for modulating the comorbidity. So iron deficiency is a comorbidity that goes unnoticed in heart failure, and it is often neglected. And you can see the incidence. It is almost 50% of patients with heart failure have got iron deficiency. And these are the data which shows that that iron deficiency is seen in 37 to 50% of the patients in Europe, and it goes to as high as 82% in Singaporean Indian. And so that we have got this alarming burden of iron deficiency in heart failure in India. And this was the paper which was published, which showed prevalence and spectrum of iron deficiency in heart failure patients in South Rajasthan. and they say, they have shown that iron deficiency was present in 76% of the patient, and out of this, 48.7% of the patient was having absolute iron deficiency, and 27.3% of the patient had functional iron deficiency. Now, what is absolute iron deficiency? Absolute iron deficiency is when total iron body store is decreased, while iron deficiency is functional when total body iron is normal or increased, but inadequate to meet the needs of the target tissues because of the iron maldistribution. And here comes the role of hepcidin, which is a hormone produced by the liver. Hepcidin basically inhibits iron transport across the gut mucosa macrophages, and in states of high hepcidin levels, like inflammatory states in chronic diseases, serum iron levels can drop because iron is trapped inside the macrophages, right? Now, so the causes of iron deficiency in heart failure patients are reduced iron stores as measured by serum ferritin level. That may be because of the GI blood loss, because of any reason, malabsorption or malnutrition, or it may be because of the reduced iron mobilization as measured by serum ferritin saturation. And this basically, shows hepcidin-mediated malabsorption and reticuloendothelial system pooling. What is the impact of iron deficiency in CHF patients? These patients have got reduced exercise capacity, reduced quality of life, increased risk of hospitalization, and also increased risk of death. So iron deficiency is an important therapeutic target in the management of heart failure. The clinical and prognostic consequences of iron deficiency, as we discussed, decreased exercise tolerance, decreased quality of life, increased long-term all-cause mortality, and in acute heart failure hospitalized patient, it increases the risk of rehospitalization within 30 days and increases the combined all-cause death and non-fatal cardiovascular death or heart transplantation. Now, what does the guideline say as far as the iron deficiency in heart failure is concerned? The ESC guidelines 2021 suggest that it is recommended that all patients with heart failure be periodically screened for anemia and iron deficiency with full blood count, serum ferritin concentration, and TSAT. It is a class 1C indication. So how iron deficiency is diagnosed? The patient test that we do is serum ferritin. If it is less than 100 mg%, then patient is iron deficient. Or if serum ferritin is between 100 to 299, then you go for this transferrin saturation, and if it is less than 20%, then patient is iron deficit. Now, despite these ESC guidelines stating that the iron deficiency is a common comorbidity in patients with heart failure and recommends regular screening and assessment, unfortunately, there is lack of awareness of iron deficiency by clinicians. And you should also remember that iron deficiency is not synonymous to anemia, right? Iron deficiency can be there without anemia also. And the challenges in the diagnosis is because there are symptoms are similar for different problems. So heart failure symptoms and iron deficiency symptoms are more or less similar. So what to check in patients with heart failure? You have to check hemoglobin level as well as other iron parameters, particularly serum ferritin and TSAT. Now the ferritin, it measures stored iron, and it is not affected by short-term variations in iron intake, but the limitation is it is affected by inflammatory states limiting sensitivity, and it is affected by liver diseases. While TSAT, it is not affected by inflammatory states, measures transported iron available for cell uptake, and it does not directly measure the iron store. As I said, iron deficiency is not synonymous with anemia. It can be there with patients who are having anemia, or it can be present in patients who are not having anemia. But it remains an independent predictor in mortality in anemic as well as in non-anemic patients. So, this is the schematic diagram, these are the control cardiomyocytes contracting normally. And what happens in iron deficiency? The contractility of the myocytes decreases. So iron deficiency reduces contractile force by as much as 43%. And it has been shown that subsequent addition of transferrin-bound iron could reverse this effect. Now coming to the treatment part, whether we should give intravenous iron or oral iron for treatment of iron deficiency in heart failure patient, the answer is intravenous iron, because oral therapy is not so effective because it is poorly tolerated, GI absorption is impaired, standard doses are often insufficient, there are drug interaction and hepcidin issues, because increased hepcidin levels, typically in inflammatory states such as heart failure, precludes resorption of iron from the gut, and high levels of hepcidin can trap iron in the storage pool. So oral iron is no benefit as far as the heart failure with iron deficiency is concerned. So the ESC guideline recommends that intravenous iron supplementation with ferric carboxymaltose should be considered in symptomatic patients with LVEF less than 45% and iron deficiency class 2AA indication. It also suggests that intravenous iron should be given in symptomatic heart failure patient recently hospitalized for heart failure and with LVEF of less than 50%. It is class 2AB indication. So we have various preparations for iron, and out of this, ferric carboxymaltase has got the definite advantage, and it is the preferred agent as far as the iron deficiency in heart failure is concerned. And the most important thing is you need not have to do the test dose, right? So you have to give high dose, 15-minute iron infusion that rapidly replenishes iron store. Extensive clinical trial and real-world experience are there which firmly establish its efficacy, improves quality of life, NYHA functional class, exercise capacity, well tolerated with a low risk of hypersensitivity reaction, and better tolerability profile than oral ferrous sulfate. And these are the trials: FAIR-HF, CONFIRM-HF, EFFECT-HF, and the meta-analysis of this trial, which shows that this ferric carboxymaltose improves functional capacity, symptoms, quality of life of heart failure patients with iron deficiency. Meta-analysis data from the 4 major randomized control trials conducted to date demonstrated that there is a reduction in this recurrent CV hospitalization. So in the patients who are hospitalized and decompensated, you first stabilize the patient, and then you measure the iron status in this patient. If iron deficiency is there, you give IV FCM. In rehabilitated heart failure patients, you have to check iron status, and if iron deficiency is there, you have to supplement IV FCM. AFFIRM-AHF was the trial in patients who were being discharged after acute heart failure, and they compared this FCM versus placebo. So what they did was, at week 0, 1 gram FCM was given if HB was between 8 to 14. If HB was more than 14 and less than 15, 500 milligram FCM was given, and it was compared with placebo. And at week 6, if the patient's HB was between 8 to 10, then less than 70 kg, 500 milligram FCM, more than 70, 1 gram. Similarly, 10 to 14 HB, less than 70, no dose, more than 70, 500 milligram, HB more than 14, less than 15, no dose. And at the week 12 to 24, only if iron deficiency persisted, 500 milligram FCM was given. The mean total dose of this FCM administered during trial was 1352 milligram, and the study showed that there was, benefit as far as the total heart failure hospitalization and CV death is concerned. And you can see secondary endpoint was also, beneficial. There was 21% reduction in the primary composite endpoint of hospitalization and cardiovascular death, and there was a 26% reduction as far as the hospitalization was concerned, and only 1 or 2 injection in 80% of the patients in the FCM group was needed. So this was the first study demonstrating the benefit of iron supplementation initiated in stabilized hospitalized patients for acute heart failure. Now, you have to remember, dear friends, that as was mentioned in this editorial comment, the eyes are useless when the mind is blind. Iron deficiency assessment and treatment in heart failure constitute example of difficulties in translating randomized clinical trials and guidelines to daily clinical practice. Incorporation of iron deficiency assessment, that is serum ferritin and TSAT, should be promoted in the routine evaluation of patients with heart failure, and importance of proactive pharmacological up-titration in HFrEF must be stressed, and adding to the 4 pillars of the treatment, a 5th one, IV-FCM, when iron deficiency is present, which is not so uncommon in patients with heart failure. So in summary, iron deficiency, even without anemia, is very common, but neglected comorbidity in heart failure and is associated with worse clinical outcomes. There is low adherence to current guidelines in terms of screening for and treatment of iron deficiency in heart failure patients. Intravenous FCM therapy is safe, leads to improvement in functional class, exercise capacity, and reduces hospitalization in patients with heart failure. And you have to use appropriate diagnostic and intervention strategies to improve iron deficiency management and overall heart failure care. Thank you.
Like to welcome Professor Luc Van Gaal. He is a professor of medicine at University of Antwerp, and he is an internationally recognized specialist in obesity, weight management, and cardiovascular disease. Over to you, sir.
Good afternoon, ladies and gentlemen, dear colleagues. Thank you, Mr. Chairman, for this kind introduction. It's my great pleasure being here. And as you have already learned in a previous session, how important obesity may be also for cardiovascular disease, I'm going to try with you to go into the links between obesity, but probably in a somewhat different way than what we are classically used, and trying to decode the link. These are my disclaimers. This program is sponsored by Eli Lilly and Company, and I am contracted by them for making this presentation. And these are my disclosures to my conflicts of interests to disclose. I think I do not have to convince you that excess weight, particularly when present in the abdominal area, is an important risk factor for cardiovascular disease and premature mortality. And that is already a very important aspect, which is when present in the abdominal area. It is this year, exactly 80 years ago, 80, that Jean Vague from Marseille in France was the first to tell people and researchers that there were more obesities, not one weight or BMI linked overweight or obesity, but obesities. And this is due to the fact that fat and excess fat may be located in different places, the so-called ectopic fat, in places where it normally does not belong, also in the heart. We know that the incidence of obesity has increased dramatically in recent decades, with an estimated 600 million adults and 100 million children who are now obese. And I think that for the aspects of obesity, the association is particularly evident for people with a BMI over 30, over 35, and or those who are characterized by that other type of obesity with mainly an accumulation of fat deep in the abdomen. We should think, as I mentioned, beyond the BMI, and the recent Lancet Commission paper published in 2025 have also focused on that, and that is what we call the ABCD of obesity. We prefer more and more to speak about adiposity, or even better, adiposopathy, instead of just obesity. It is considered to be a chronic disease, and as you can see on the left panel, you may have a fat mass disease with just altered pathological mechanical forces, or you may have a sick fat disease, where also deranged endocrine and immune responses, mainly driven by cytokines, by peptides, by hormones, who are released from that deep abdominal cavity. So not only the degree of fat is important, that's the amount, the function is important, and when it becomes dysfunctional, then we may lead to the complications, as we know, diabetes, cardiovascular disease, cancer, sleep apnea, hepatic disease with MASLD and MASH. And that, as I mentioned before, the distribution of the fat is important. It may not be seen in places where it normally does not belong. A large study published more than 10 million individuals who have been followed up for almost 14 years. So it's together 239 prospective studies have clearly shown that for CHD, for stroke, for respiratory disease, also for cancer, less pronounced, that there is roughly in between 20 and 42% increase in the risk to develop that. Certainly when we take a BMI of 22 to 25 as the reference category, then we can see that by increasing BMI, the risk for all these diseases, cardiovascular disease, coronary ischemic heart disease in particular, and heart failure is increasing. So this is an important aspect. And if we would put these same graphs, just mentioning the waist circumference or the amount of deep visceral fat, then you would see that the hazard ratio would even further increase. And that is a little bit summarized in this slide, where you put the fat, where you have the fat, that will matter. And then you can make the difference between the favorable adiposity, when fat is accumulated subcutaneously or at the lower parts of the body. Then you will see that the inverse variance weighted estimate, the odds ratio, is clearly different between favorable adiposity or unfavorable adiposity when it is located in the belly, in the liver, in the muscle, in the heart, in the beta cell in the pancreas, around the kidney. That are all these specific places of ectopic fat that we can call unfavorable adiposity. And as you can see, we have just selected here a few outcome diseases. This is true for diabetes, this is true for hypertension, this is true for coronary artery disease, and in the field of gynecology and fertility, this is also true, even very pronounced, for polycystic ovary syndrome. Another study that looked into the risk of cardiovascular disease risk, for every 5 units increase in BMI, starting from a BMI of 25. And that hazard ratio will progressively increase, and you will see again that the dip is somewhere around 20 to 22 kilogram per square meter, and that it progressively increases. Whatever type of cardiovascular disease you consider, any hypertensive heart disease, ischemic heart disease, atrial fibrillation, heart failure, or cerebrovascular disease. And probably, as you can see here, those with the sharpest increase is for hypertensive heart disease and a very hot topic these days, which is heart failure. And in that respect, to try to do as early as possible something on that progress, because obesity is a chronic disease. It is a relapsing disease. It's a progressive disease. For that reason, as early you can intervene as possible. And for that reason, we more and more also use the so-called CKM syndrome, the cardio-kidney metabolic syndrome, immediately indicating that there are important links between the heart, the kidney, and all metabolic aspects. From stage 1 to stage 0, there are either no risk factors or just that excess of fat, which may be that dysfunctional adipose tissue. Metabolic risk factors seem to start, also factors for chronic kidney disease, and in stage 3 and stage 4, then we move from subclinical cardiovascular disease, subclinical heart failure, to stage 4, which is the full-blown picture of CVD and CKM syndrome. And, as it is indicating very clearly there, at the beginning, a disease is easy to cure, but difficult to diagnose. So early recognition for the simplest and the easiest signs, because as time passes, it becomes easy to diagnose, but very often difficult to cure. And then what we know in preventing that CKM stage progression is to try to regress by weight loss, regress by pharmacotherapy, regress by bariatric surgery if necessary. And the pathophysiology underlining that CKM syndrome starts with that excess dysfunctional adipose tissue, with the release of these adipocytes and the adipokines, mainly interleukin-6, tumor necrosis factor alpha, a decrease in adiponectin, CRP, and many other parameters that are released. They will have effects on blood pressure, on dyslipidemia, leading to metabolic syndrome and diabetes. And that is for metabolic aspects. For an aspect of the kidney, it may lead to glomerulosclerosis, because you will have also that fat accumulation around the kidney, and that all as the same as it is in a metabolic field, as it is for the heart and the peripheral circulation, as it is for the kidney. This is inflammation, oxidative stress. This is the core business and the core underlying pathology that may lead to this CKM syndrome, and later on to cardiovascular disease, heart failure, atrial fibrillation. This is nicely shown that the main mechanisms that are involved in that increased risk of cardiometabolic disease is on the left part, a normal weight individual, where no inflammation is present and where an optimal insulin sensitivity is present. And if you move to the right, when obesity occurs, when fat is going to be accumulated in the belly, inflammation will increase and insulin sensitivity will become insulin resistance. And that the left part has a low cardiometabolic risk, the right part with that secretion of all these cytokines, and you see what happens in the belly and in that ectopic fat may give you hypoxia, may give you the release of these adipokines, may lead to ectopic lipid accumulation in the heart, but also specifically in the muscle, and this leads to that increased cardiometabolic risk. This also leads to increased mortality, and cardiovascular disease is the main cause of death and of premature mortality in individuals with obesity. And when healthy weight with a BMI between 18.5 to 25 is considered as the parameter, you will see by increasing BMI that the hazard ratio will progressively increase. Not to forget that people living with anorexia and underweight, that they also have a risk, and that is a risk that is a little bit in between BMI 30 and BMI 32. So also underweight should be considered as a potential risk through other mechanisms, because these mechanisms are mostly vitamin deficiency, undernutrition, low albumin, maybe also low serum iron, as we have just learned by the previous speaker. We do not have to wait until an individual has accumulated fat in the belly with a large waist-to-hip circumference. We do not have to wait until the BMI is 35 or 40. Already in the concept of overweight, BMI between 25 and 30, you will see that risks and problems with coronary heart disease, cerebrovascular disease, and heart failure may develop, even if we consider the patient relatively healthy because of the metabolic abnormalities that are not present yet. And that is the concept of the so-called a metabolically healthy individual. Is that individual really healthy? Maybe in a transient period, yes, but it definitely will develop into a disease state. And you will see here again from this part that even in the absence of metabolic abnormalities, if you are obese, BMI over 30, that again heart failure shows the strongest risk for CVD, as you will see on this graph. An aspect that we may not forget, and that doctors may not forget, and that people who take care of people with overweight and obesity is atrial fibrillation. We see more and more atrial fibrillation in individuals with obesity and those who later on will become a diabetic individual, the so-called diabesity. And this atrial fibrillation may lead to many mechanisms, may lead to aspects of mechanical aspects, may lead to remodeling, and remodeling by itself may also be a reason for atrial fibrillation. It's just a message: atrial fibrillation should be checked in every single patient living with overweight and obesity when doctors do a perfect normal assessment before starting any therapy and before starting to identify the risk of a patient living with overweight and obesity. I mentioned already the ectopic fats. The most known these days is the fat in the liver, steatosis, MASH and NASH with hepatitis, but also there is also important epicardial fats, epicardial adipose tissue in heart failure. And this may lead to a chronic systemic, first a local inflammatory profile, and later on a more systemic inflammatory profile. And this is this epicardial adipose tissue that may lead to different mechanisms. And you can see the graph. It can be located pericardially, it may be epicardially, just situated above the myocardium. And since this epicardial adipose tissue will also have aspects of migration and transformation of mesangial cells, that may lead to a local secretion of pro-inflammatory cytokines. This will then finally also lead to the heart failure, mostly in the field
5 minutes remaining.
Obesity with preserved ejection fraction. And this is a nice graph that a few years ago was published in Nature Reviews in Cardiology from Jacobellis, where you can see that there's a very nice layer of fat cells, of macrophages that have infiltrated in this adipose tissue, and that at the level of the myocardium may then lead via fibrosis, inflammation, and apoptosis to diastolic dysfunction and finally heart failure. And that is the reason why also for heart failure, doctors who treat obesity should be aware of that, should ask about symptoms, should screen with other methods if possible to see whether subclinical and early diagnosed heart failure is present, to intervene as early as possible. Because it is said that obesity may be the perfect storm for heart failure due to metabolic abnormalities, structural abnormalities, the functional one that we described already, and even neurohormonal abnormalities may lead, mostly in the field of obesity, for heart failure with preserved ejection fraction. But there is even the last years when more research linking obesity to heart failure has been studied, that also heart failure with restricted function has been identified. So we should manage. And a good management starts with a good aspect of assessment. An assessment, as we do for clinical examination, looking into the risk factors, looking into glucose tolerance, lipid abnormalities, looking whether we can see whether there is a more generalized inflammation, endocrine parameters that may play a role. So a good assessment is one of the important aspects to start. And then we should reduce body weight and we should reduce adiposity. We not only should look into the scale, we should look into the health of an individual. Every individual would like to lose 20 kilograms, of course. But it is important that a strategy and a target together in a negotiation with the patient is done, is put forward in order to bring good health back to the individual. That is one point. But the second point, and at least as important, is maintain the weight loss. Because we see that losing weight, 10 or 15 kilograms, is easy, at least in the majority of individuals, but the way to maintain it, that is the most important aspect. And in general, we always have said years ago that 5 to 10% weight loss is good, reducing glucose, lipids, blood pressure, but if you need aspects on diabetes remission, on cardiovascular disease, certainly on cardiovascular mortality, on heart failure, on sleep apnea, we know these days that we need a so-called double digit, which is at least 15 and most likely more than 20% weight loss in the newer approaches that we have these days are able to show that, also in order to prevent further weight gain. So it is prevention and improving of quality of life for the patient on one hand, and preventing or improving the overall health and obesity-related complications. And as I mentioned, what was previously said, 5 to 10% is okay. We should individualize, putting targets forward, the greater weight loss that has been associated to reduce or normalize these individuals. I just only would say that a previous study, which was the Look Ahead study, looked into cardiovascular outcome in individuals with obesity and diabetes. The 10 years data showed nice effects on weight reduction, on physical fitness, on waist circumference, but the cardiovascular outcome was unfortunately negative. And that was considered to be a negative study. However, if a subgroup of these individuals that was analyzed could show more than 10% weight loss, then a primary as well as the secondary outcome were positive. As you can see, it was an estimated rate ratio of 0.79 and 0.76. So, as a summary, I hope to have convinced you that obesity is a chronic progressive disease that can lead to premature death. The cardiometabolic complications of obesity have the greatest impact upon health, and excess adipose tissue and adipose dysfunction has also mechanical effects on the body. I would like to thank you for your attention.
Hello. Thank you very much, sir, for your very informative talk. It's a question-answer session is open for 10 minutes. If anybody, any audience has a question, welcome.
Hello. Sir, you will answer? Dr. Bakshi, sir, is not there.
Yeah, he has gone for the emergency. You can ask the questions.
Okay.
You can ask the
He has told about ferric carboxymaltose, FCM. Just wanted to know what should be the dose, single dose or divided dose? What should be the duration between two doses, 1000 milligram, 1500 or 750, 752 times? And usually iron preparations are notorious for anaphylactic reactions. So what are chances of that? And after, how will able to decide, okay, now 2 injections, 1 injection, 3 injections are enough? And what should be the maintenance dose so that patient does not require again the injectable form?
Yeah, so the last question, there is nothing like a maintenance dose. It is all based on the serum ferritin level, which we need to keep checking when the patient comes on the follow-up. It is like what we check the other parameters of the blood at the same time. Initial dose can be decided based on the serum ferritin level, but we can give it from 500 to 1000 gram as a straight dose over the period of 30 minutes. second dose should be repeated after 2 weeks at least, 2 to 3 weeks after the duration of 2 to 3 weeks. And again, we can check the serum ferritin level at the same time. Regarding the anaphylactic issue, yes, it can happen, but it is again, like the other medications, it is very, very rare. It is recommended to give the test dose before giving the full injection. So it can happen. Very few incidences has been happened, but it can happen. So we need to be vigilant about that thing. And that's why it should not be given at home, or it should not be given in the setup where we cannot take care of the
Anaphylactic reactions. Yeah. But sir, after follow-up, suppose 2 injections has been given, then after follow-up, patient will should be called for 15 days, 1 month, and only ferritin level is still low, again injectable should be given, or some oral therapy will work?
Yeah, so oral, as we have discussed, that it cannot be tolerated because of the multiple issues. And the side effects also very high. So we can give serum ferritin, we can give the ferric carboxymaltose again on the follow-up. Probably 3 to 4 injections will replenish the store of the ferritin, iron store in the body, and subsequently it won't be required. And we can encourage at the same time about the diet and all.
Okay. Yeah, just adding to the points what Tejas said. Number one, it has been reasonably safe. Like it seems we give generally 1 or 2 patients on a daily basis. So for last maybe 3, 4, 5 years, hundreds and thousands of patient data. Hardly 1 or 2 cases we had to stop injection. Otherwise, all of them have tolerated well. For people who do not have gross heart failure, you can give within 30 to 60 minutes. For people who have got gross heart failure, give it over 2 hours, but keep monitoring during those time. There is a calculation formula and methodology how to calculate the dose from 500 to 1500. What I do practically is for everybody 1000 in it, because patients do not like to come again and again for the same thing. Every time you have to take intracath monitoring, some cost, so 1000 state. Now, there is no need to follow it with the help of oral drugs, because once you have loaded iron to the blood, if your body has capacity to store the iron, then it will store. If it is not doing, then there is some other issue. So I do not give any oral hematinics to anyone, whomever I give. Now, mind well, the indication is HFrEF patient, heart failure with ejection fraction less than 45. That's where it improves symptoms and quality of life. That's how. And beginning, as Dr. Bakshi said, I missed the part, but just based on ferritin and TSAT, transferrin saturation, you have to select the patient. In India, out of all, 80% or 90% will meet the criteria of ferric carboxymaltose, because we have very poor iron store. Particularly the area which we practice, Gujarat, Rajasthan, MP, most of the people are vegetarian. People with heart failure have already appetite issue, absorption issues, iron in content in food issues. So generally all of them need it, give them.
Sir, you have said that about test dose. So is the subcutaneous test dose or what we have to do?
I have never. There is more chance of reaction. So if you shorter the period, you give better.
Oh.
Shorter the duration, less adverse effect. Longer the duration, more adverse effect. I have never given any test dose, but I tell people at the beginning, just be more watchful. Otherwise.
Just a comment from sir.
Okay, so we have one comment from here.
Can I add something on the ferritin story? My question or a remark is, if you have people with obesity, where we know that their ferritin levels are always high because of the high inflammatory situation, what parameter are you going to use?
5 minutes remaining.
So TSAT is something which, in addition to ferritin, what we look for. If TSAT is less than 20, we go for supplementing iron. And see, frankly speaking, it's very, very safe in our experience. International experience is also same. Our experience is also same. It does improve symptomatology of people with HFrEF. So generally, if at all, I err on the side of giving it rather than not giving it.
One explanation.
Like, see, serum iron is not a part of assessment in patients with heart failure with reduced EF. So HFrEF patient, you have to look only ferritin and transferrin saturation. There is nothing to do with the serum iron in this data. TSAT less than 20.
One of the explanation that he asked about the oral iron. Basically, this disease is because of HIPCD, chronic inflammatory diseases. all will produce hepcidin and there will be no absorption of the iron through oral cavity.
Yes.
So it should be always given by the IV. And regarding, as you have at a big center, is there any way of measuring hepcidin?
Is there a way of?
Hepcidin.
Hepcidin, I have not integrated into my practice. If anybody has experience of measuring hepcidin.
So ideally, if we measure the hepcidin, and some hepcidin inhibitors are also available, in future we can get that therapy for also.
Yeah.
To Dr. Hiret Kevadia, sir, what can we do for patients who are having unifocal or monomorphic VPCs, or maybe ventricular bigeminy, trigeminy, asymptomatic, echo normal, even in spite if you start them on beta blockers, they are not suppressed. What should we do for those patients?
So when a patient has asymptomatic PVC in structurally normal heart, the foremost part whether we should go for further treatment depends on the number one is PVC burden. So that's why we go for Holter or loop recorder for a longer duration. And if the PVC burden is more than 15 to 20%, so that type of burden can lead to PVC-induced LV dysfunction on a prolonged duration if we don't control it. So those patients who have PVC burden more than 15 to 20%, in spite of they may be asymptomatic, should go for a definitive therapy to reduce PVC burden. And that's how we reduce the chance of getting PVC-induced cardiomyopathy in future, number one. Number two, if PVCs are single morphology, but if their coupling interval is short, which can become a malignant PVC to induce arrhythmia, the PVC burden may be less, maybe 5% also. Still, we need to go for a definitive therapy. Definitive therapy, usually they don't respond to beta blocker well. They may need sometimes to go for a 3D mapping, EP study, find out the focus and ablate it. Number three is PVC worsened cardiomyopathy, like those patients who have dilated cardiomyopathy with ejection fraction of previously used to be 40%, but now patient is getting frequent PVCs, and that ejection fraction which was 40% has come down now to 30% or something. That means we have a documented decrease in the ejection fraction after getting PVCs. That is known as PVC worsened cardiomyopathy. That patient should also go for PVC ablation in form of 3D mapping, in whatever is the burden of the PVC. That will probably lead to again get back to the ejection fraction that was 40% before.
Good evening, everyone. My question is to Dr. Anish, sir. Sir, I am an exam-going medicine R3, and I have read a term which is heart failure with improved ejection fraction. And around last year, there have been trials ongoing for de-escalation of GDMT in selected few patients. So, sir, can you shed some light on clinical implications of the same about de-escalation of GDMT?
So answering the first part, what is heart failure with improved ejection fraction? So generally this term applies to a patient who previously presented with HFrEF, heart failure with reduced EF, maybe whatever 10, 15, 20, 30, 35. You give treatment, you may correct structural heart disease, you may improve the ischemia, whatever you do, whatever kind of treatment. But when EF improves to what it was, it is called as heart failure with improved EF. Now this term is coined for multiple reasons. One of them is it's likely that this patient might have still existing pathophysiology of heart failure. Say, for example, somebody who had got dilated cardiomyopathy you have treated has now gone EF from 30 to 45. So it's improved, but still heart failure term stays there because still there are so many pathophysiological wrong things can be there in the body as well as in the myocardium. At the moment, science strictly believes anybody and everybody who had heart failure with reduced EF, till EF goes to the perfection, that is 55, 60%, until you believe that the underlying pathophysiology and cause has been totally corrected, there is no place of de-escalation of treatment. So we should not de-escalate because there is a serious chance that patient will go back to heart failure. So let the EF be 55, 60 for months and months. Let the underlying cause be totally corrected and you be assured Maybe sometimes people do all kinds of tests like troponin, NT-proBNP, they are also normal. Maybe sometimes for certain disease, people do MRI heart, and MRI heart is also normal. So de-escalating treatment after attainment of ejection fraction and asymptomatic status needs a lot of consideration, because the biggest issue is if patient goes back to heart failure, there can be serious issue. So at the moment, I believe just take a message that no de-escalation, let's continue the treatment, unless a top-notch institute where 2-3 doctors meet together with all these tests and define, and now there is reason to stop the treatment. Number one. Number two, what you said is these 2 points, improved and de-escalate.
My question to Professor Luke Wan. So we have two group here, sir, on your right side. On your right side.
Sorry.
So we have two group of medications, especially for the obesity management. So how is your experience, and which molecule will you prefer in a specific condition?
I assume that you mean semaglutide on one hand and tirzepatide on the other hand. Well, you know that these two drugs are different. Semaglutide is a monoagonist of GLP-1. The tirzepatide is a dual agonist, so it's GLP-1 GIP. They both have similar effects on the eating behavior and on satiety. They both have the same effects on the pancreas for treating type 2 diabetes, as well on the stomach. So mechanistically, they are quite the same. The only difference is that tirzepatide has also, due to the GIP moiety, an effect on adipose tissue, what all the GLP-1 related drugs do not have. They both have nice effects on glucose control, on cardiovascular outcome, on weight loss. If you compare them both in a one-to-one, head-to-head comparison, then for the weight loss and for the cardiometabolic risk factors, tirzepatide is roughly 10 to 15% more powerful than semaglutide. The only point is that semaglutide has, with its SELECT study, already a positive cardiovascular outcome trial, what was positive, which was the first time in history that we have seen an anti-obesity agent showing positive results. We do not have that yet with tirzepatide. There is an ongoing study, the SURMOUNT-MMO study, that will be closed somewhere, I think, end 27. I assume that the effect will be the same, because we have seen that with tirzepatide in patients with type 2 diabetes, that excellent cardiovascular outcome is also there. So on average, I think maybe the one was superior than the other, but the demand for anti-obesity agents is so large that I think that there will be a place for the two of them, and maybe for a third to come, because there are many drugs in the pipeline, also the GLP-1s in oral formulation. I said semaglutide is monoagonist, tirzepatide is a dual agonist, and we have now in the pipeline also 3 agonists. So the future is huge.
So taking the story of semaglutide and tirzepatide further, we know all those efforts which leads to weight loss, may it be dietary interventions or drugs, if not combined with proper protein intake and adequate resistance training exercise, leads to sarcopenia, everything, not only drugs. Now, tirzepatide being having GIP and little more adipose tissue specific, do you see difference in sarcopenia between the two, semaglutide and tirzepatide? That tirzepatide has less sarcopenia with the similar weight loss effect, or there is no such study or data available?
I first will underline that, of course, all these drugs have been studied in the RCTs and have been approved in combination with lifestyle intervention. The better the lifestyle will be, the better the outcome will be. The better the lifestyle will be, the better and the lower the gastrointestinal side effects with nausea, vomiting will be. So that is indeed a fact that is very important. Sarcopenia and muscle loss is a very huge discussion because the majority of studies have been performed measuring lean mass. And lean mass is not muscle mass. Lean mass is bone, water that we lose a lot in the beginning of a treatment, and of course, fat mass, and then lean mass and muscle. You may not forget that in obese individuals, the muscles are full of adipocytes. That's the ectopic fat in the muscle. So if you measure that in an imprecise way, and you lose 20 kilos, and the fat is going out of the muscle, you will measure a new muscle entity without fat. And then if you measure it in an imprecise way, it gives the impression that you have muscle loss and maybe sarcopenia. And I do not believe that that is true. What is true, and studies have shown that, both with semaglutide as well as with tirzepatide, that muscle functionality is important for everything, for insulin resistance, for insulin sensitivity, for the heart, for everything. The only good way to look what happens with the muscle is MRI technology, but that is of course very difficult. We only have a few studies that have looked to that. The only risk that I personally think that sarcopenia may be a problem due to the SELECT study and what will come with other molecules for outcome in the future. We are going to give that to elderly individuals who have already a history of cardiovascular disease. So if we do that to elderly individuals where already less muscle mass is present, for that category, I would be careful and looking at, and then you should try to test muscle functionality with hand grip, with DEXA technology. But saying on average that all GLP-1s will give sarcopenia, personally, I think that's a little bit overestimated because we do not have the precise ways of measuring it.
Thank you.
So we end the session here. Thank you very much to all the speakers for their nice talk. The hot tea is waiting for you, and we will meet 7:30 sharp at the Hyatt Regency. Thank you.
Regarding the GIC. Now immediately? Yeah, because I have another lecture in the hotel at...
I'm so sorry.
So we have to do it immediately.
That's fine.
I can do it immediately.
Oh, no, we can plan immediately.
It is
Just
set
for
to
a
7:30, so the next stop, watching. This next stop is at 7:30. You can quickly get.
અત્યારે અહીંયા જ હું કરાવી દઉં છું દિલીપ વિડીયોગ્રાફી અહીંયા જ કરાવી દઉં છું.
So you have time at the next lecture when you it is nearby.
બધી ખુરશીઓ પેલા રૂમમાં જવા સોફા છે ને એ રહેવા દે સામાન કોણ હતા તો ખુરશીઓ લઈ જાઓ પહેલા ખુરશી લઈ
કાઢવાનું કેબલે કાઢવા કે કેબલ રહેવા દે સર
કેબલ રહેવા દો ટીવી લઈ એ સાઈડમાં
હા લઈ લે
એક આપણે આપણે ખાલી અહીંયા સાઈડમાં મૂકી દઈએ આને ઉઠાવીને લઈ લો એ રહેવા દો બધું
નહીં પાછળ છે એક મિનિટ
એક મિનિટ બાર બધું છે બાર
લેપટોપ લઈ લો